Good morning, honorable dignitaries, learned delegates, and respected teachers. I welcome one and all sitting over here. I am Dr. Sheetal Mahajan. Feel privileged to welcome you all on behalf of Organizing Committee and Department of Pathology IIMSR for this academic feast of CME on blood transfusion practices. It is on occasion like this we get opportunities to enhance our knowledge and understanding. We look forward to get an exposure about what the best of the brains think about this very dynamic issue on blood transfusion and its practices. So without much delay, we'll be starting with our first session. For the first session, it will be my pleasure to invite as a chairperson Dr. Fozia ma'am and Dr. Shafi sir. Dr. Fozia ma'am, she has a work experience as lecturer in GMC, Aurangabad and MGM Hospital. She is president of Maharashtra Rakta Kendra Association, Marathwada. Welcome ma'am. Our second chairperson is Dr. Shafi sir. Presently, he is working as professor of community medicine in our college and member secretary of institutional ethics committee. He joined as professor and head of this institute in September 2023 to September 2017. He also worked in College of Public Health at Dammam University, Saudi Arabia. He has 30 national and 15 international publications to his credit. I welcome you, sir. The speaker for this session on the topic of transfusion transmitted infection is respected Dr. Ajit Dam, sir. Now I would request our chairperson to kindly introduce our speakers.
speaker for first session. He is professor in the Department of Microbiology at our college. Total UG teaching experience he is having of 45 years and PG teaching experience of 30 years, and he has guided almost 16 MD students. He is also a PhD guide for microbiology at Maharashtra Institute of Health Sciences. The two students are registered under him for PhD. Scientific publications, he has published almost 80 publications, including national and international journals. And he has given talk as a guest speaker faculty on various platforms in more than 20. So we welcome you, sir, and we proceed with the presentation.
Thank you for kind introduction, my introduction. We'll start with our today's first presentation, transfusion transmitted infections. The schedule was a bit disturbed today, but I'm presenting this presentation just before you. What are these transfusion transmitted infections or infectious agents? These agents are those organisms that are transmissible by blood and can cause and mortality in recipients. Therefore, they are important. This is a long list of organisms that can be transmitted by blood transfusion. Of these, the ones that have clearly made into red are the 5 important organisms or diseases that are to be tested for manually in every blood bank. Therefore, I have highlighted them. Others are comparatively, I would say, either less important or they are not seen over here, there is no like that. For example, Babesia and Trypanosoma cruzi are not at all seen in India, so we need not look for them. Secondary virus, Epstein-Barr virus are on a low incidence rate, therefore usually they are not being tested for. Some blood banks do test for them, of course with additional costs. Others, leishmania in our area is not very common. Toxoplasma gondii after infection usually stays dormant in tissues in the form of tissue cysts and pseudocysts and stays like that for years together. And therefore, for practical purposes, it does not carry much meaning in blood transfusion. Microfilaria is a larval form of filaриal worm. Though it circulates in the blood and can be transmitted to the recipient, it has got no clinical implication because microfilaria do any symptoms in the patient, in the recipient. One. Second is, it does not develop further in the recipient. It is the end stage of development in human beings. To the next host through the agency of mosquitoes, but here that also will not be possible because the number of microfilaria coming over here will be too less. So microfilaria per se, though they are transmitted, they don't produce any infection per se. Now, what are the characteristics of transfusion transmitted infections? In the donors, they cause mild or asymptomatic infections, and therefore they are likely to be missed as a suitable donor because we don't know that they are infected. One. Second is, some of them can have extremely long incubation periods. For example, we know that hepatitis B virus, hepatitis C, and especially HIV have got extremely long incubation periods. During this incubation period, the agent circulates in the blood and is transmissible. आवाज कभी करता आवाज देना and some of these they stay in the form of carrier state like hepatitis B and hepatitis C. During this carrier phase also, the organisms can circulate in the blood and be transmissible. But because the carrier state is asymptomatic, we do not suspect that this person is having, and therefore we can miss it and the donor is accepted. We should see about these 5 important agents individually, about their general features first and then about their transmissions. HIV, as you all know, is a retrovirus having the enzyme reverse transcriptase with it. Basically, it's a single-stranded RNA. With the help of this reverse transcriptase converts into double-stranded DNA and then gets incorporated into our host genome, that is our genome. From there, it controls the complete metabolism of the cell, and in due course of time, it may even destroy the cell. After the entry of the virus, it circulates in the blood, and specifically CD4 cells, these are the helper T cells. It can infect the macrophages who have got the CD4 marker and activated the lymphocytes. They are the three cells that it can infect. It will rupture them, and then ultimately the CD4 cell counts start falling. However, this is not so simple. Though it enters the cell and starts multiplying inside the cell, after some time, though it kills the cell, our immune system is so efficient that if the virus kills 100 lymphocytes today, CD4 lymphocytes today, 100 are repressed. If it kills 10,000, 10,000 are repressed, 1 lakh are repressed. And this fight between the virus and the immune system continues for about 10 or 15 years until then the patient remains absolutely healthy. Afterwards, ultimately, the immune system fails, wherein the CD4 cells start falling down. Till that time, we don't even know that the CD4s are infected and they are not declining. Only after the incubation period is over, they start falling down. Now is the time where the immunity comes down. CD4 is important because it is the backbone of our immunity. It controls the antibody formation as well as the CMI. And therefore, if those cells are destroyed, naturally our immune system is going to be absolutely down. In such a case, the person suffers from various opportunistic infections. But during those 10 or 15 years, the viruses circulate in the blood and then can be transmitted to the recipient. Most of the infections are caused by HIV, or more than 99% of the infections of HIV throughout the world are because of HIV-1. Very few are because of HIV-2, that too especially in Western Africa. However, sporadic cases have been reported from almost all the countries, including India. Because this virus can be a killer virus, we don't want to take any chance that it is transmitted because of us to the recipient. And therefore, when we test for HIV, we test for both HIV-1 as well as HIV-2. The overall transmission, we can say, of the HIV by sexual route is the maximum. This is, we can say, IV drug use. Blood transfusion comes at a very low level because almost all the risk important. Antibodies are formed, and therefore, though antibodies are there, the virus continues to multiply. We usually test for antibodies for detecting the virus in the donated blood. The time between infection and antibody detection is known as the window period. This is in weeks. It can vary from 3 to 12 weeks. This is in weeks. During this time, the virus, its RNA, and the antigen P24 circulates in the blood. Infection to the clinical signs and symptoms is the incubation period. As I have told you, it can be within 10 to 15 years. So there are conditions that we should know about the virus. During whole of this period, in the period as well as the incubation period, the person can transmit HIV. Now we shall say about hepatitis B. This is a double-stranded DNA virus, HBV. It belongs to the family Badnapur. Usually we consider only as a single virus in the family Badnapur, but we should know as a common as a general knowledge that apart from humans, other animals can also be infected by hepatitis B viruses, and those belong to this Badnapur. Ours is hepatitis B virus. These viruses originally they enter the hepatocytes, multiply there, and circulate in the blood. The routine course of infection is acute infection, jaundice, and then recovery. On an average, most of the patients recover, but few of them are unfortunate. They can go into a variety of different carrier stages and processes. I come to that in a short time. When HBsAg, HBV virus is infected a person, there are about 6 or 7 markers that we say can be detected in the patient's blood. of these hepatitis B surface antigen is the most important one that I have highlighted. As soon as anti-H base starts rising, HbS declines and is disappears. Anti-HbC is the only marker against another, we can say, antigen known as the core antigen. Core will see somewhere, it's not the function only. It functions on the cell, but it's not taking about that. So the core antigen is present somewhere on the core. In the inner circle, antigen is present somewhere on the core. In the inner circle, and hepatitis B antigen is also present on the core. HbS is on the surface. So this is what we should know. This is the one that we can say is the protective one, because antibody against it can have some effect on controlling the virus. Hepatitis B DNA circulates and DNA polymerase also circulates when the patient is highly infectious. I was telling about the chronicity. In chronicity, the patients become carriers. The carriers can be either simple carriers where only the hepatitis B antigen is positive in the blood, no other marker is seen. Such persons are having low infectivity. In super carrier, we get hepatitis B surface antigen along with the DNA of the hepatitis B virus. Also, such persons are having high infectivity. Our donors, we usually test only for hepatitis B surface antigen, so we have to presume that probably he or she is having a high infectivity and such units have to be displayed. Hepatitis C virus was a bit neglected because it was not known earlier. When hepatitis A and B were seen and they were targeted for testing this and that, there were many other persons who were suffering from jaundice but did not have A or B. Such persons were called to be suffering from non-A, non-B hepatitis, wherein one of the is C virus. This is RNA single-stranded RNA virus of flavivalent group. As with hepatitis B, the same routes, sexual, blood and blood clots, and vertical transmission are true over here also. Again, it multiple hepatocytes circulates in the blood, acute infection, jaundice recovery, and chronicity carrier stage. The same thing as in hepatitis B. However, in UCD, we don't differentiate between super carrier and simple carrier. All of them we call as carriers. However, the chronicity can lead to cirrhosis and malignancy, and hepatitis B as the delayed complications which are lethal, we can say. Therefore, UCD is important. Syphilis. Syphilis is a spirochete, it is a bacteria. It is spherical, it is having spirals, it is motile and extremely thin. It does not take routine gram stain or ZN stain at all. It has thermal microscopy, fluorescence microscopy, or by cerebral integration. It is transmitted by variety of routes. First one is of course sexual, wherein the lesion or the disease that it causes is referred to as primary syphilis. Because it's a sexual transmission, we get genital on the penis, on some part of the penis in males, and vulva or cervix in case of females. These ulcers are not at all painful, they are indurated and they are non-painful. Also, usually a single ulcer occurs in syphilis. This ulcer heals automatically within a few days. Local lymph nodes are also enlarged. They become, we can say, though enlarged, they are still not painful. All these things, the lesions as well as the lymph nodes, because they are painless, the patient usually neglects them. As soon as he recovers from them, because the ulcers heal automatically, the patient feels that now I am safe, I will recover. अच्छा होगा मैं डॉक्टर के पास नहीं गया, फिर वही इंजेक्शन देता. ऐसे होगा, ठीक हो. But he is under wrong impression because many or most of them go into secondary phase, where the patients show manifestations in the form of skin rashes, ulcers, especially when the serpentine ulcers on the mucous membranes, condylomas on the mucocutaneous junctions. Perineal chondromas are well known. All these lesions are again painless and non-itching and are also self-healing. Therefore, within few weeks, these lesions also disappear. The patient at this time does not know that this is manifestation of secondary syphilis because it has occurred after few weeks of primary infection. Then the virus goes into the latent stage. This latency can continue for years together. During this, there is clinical latency but not malaria. The organisms can circulate in the blood because they can multiply in the internal organs and they can communicate with the blood also. In late stages, this becomes almost non-infectious. Very few cases reach to the late stage. Gamma formations or the gametas, we can say, lesions appear on the skin, bone marrow, and earlier they was typically shown to be present on the tongue. Nowadays, itself has reduced to a great extent, so these lesions are not usually seen. Cardiovascular and neurosyphilis are also well-known complications of syphilis. Some people call it as quaternary syphilis also. Because this organism circulates in the blood when the patient is asymptomatic during latency, in that case, the transfusion efficacy is quite high, but in this case, no chancre appears. The patient go directly into secondary syphilis or further. This is how they look like. I'm sorry, this is not seen. Yeah. The first one is about fluorescence microscope, down below is Jalna microscope, and the last one is the cellular information. No malaria. All of us know that species, humans in this case are intermediate hosts because male parasites carry out asexual life cycle in human beings. The sexual phase is carried out in female anopheles mosquitoes, therefore female anopheles mosquitoes are definitely host. Why only females? Because males do not suck blood. Only females suck the blood. Therefore females. We have learned traditionally that there are 4 species of malarial parasite: Vivax, Falciparum, malaria, and oval. Recently, one more has been added, Plasmodium moraci. But now, some cases, purely human cases, and has been added as a human malarial parasite nowadays. Relapses occur because of lymphocytes, that is, dormant liver cells, liver phase in Plasmodium vivax. Whereas continuation of RBC stages lead to recrudescences. And these relapses and recrudescences can occur over few months. And during all these phases or in between, there can be low level parasitism. There are the various stages that we can see. Sporozoite was the stage that comes in first, then ring stage occurs, schizons appear, from which neurocytes come out, and ultimately the gametocytes. The gametocytes shown over here is that of falciparum. Other gametocytes of other parasites are usually spherical or oval. This is what we see in peripheral skin. Now, because now we have seen all the main agents, now we shall see what is the effect of the blood storage that we do after blood donations. In brief, treponins, they die within 3 to 5 days of time, between 4 and 20 days. Die means their cells become so damaged that they are unable to multiply afterwards. Therefore, the blood becomes safe as far as syphilis alone is concerned. All other agents remain viable at this temperature. Treponins remain viable at a higher temperature, more than 20, plus 20. And in this case, when we store the platelets at plus 22, they remain a threat to the recipient. Therefore, we have to take this point into consideration. Now we come to the screening of blood units for transfusion-transmitted infections. Here I would like to just tell you that earlier on, before 1985, only syphilis were tested. In 85, HIV testing started. HIV testing started. 89, HIV testing started. And somewhere around 2000 or 2001, HCV testing also started. So earlier only 2, syphilis and malaria, being tested. In HIV testing, when the testing started, the main aim was to detect the antibodies because that was the easiest technique available in those days, we can say. And the duration was varying from usually 8 weeks to 12 weeks because the antibody testing kits in those days were not so efficient. They were of the, we can say, first generation of ELISAs. The lack of, that is antibodies, was the reason in those antibodies were yet to develop, and the test was also tested by third generation ELISA, where the incubation period has been brought down to 3 weeks. That is, we can detect them as early as 3 weeks. Fourth generation detects antibodies simultaneous with antigen, and it has brought down incubation to about 12 days. And more better than that is nucleic acid amplification test for viral RNA, which can be detected within 10 days of infection, 10 days of experiment. Therefore, by using such high sensitivity tests, the risk of TTI reduces greatly as regards HIV is considered. Hepatitis B surface antigen is tested usually by ELISA. Nowadays, NAT is available. Hepatitis C, it has for antibodies, NAT is also available. VDRF, immunochromatography, RPHA, ELISA, all are available for syphilis. Rapid diagnostic test for malaria, and peripheral smear examination are the two main commonly used tests. Other tests like again PCR are available for malaria testing. Though all these tests are available, along with this, some other rapid tests are also available, but FDA usually does not approve using the rapid tests. Those tests have to be kept only for such situations where there is dire emergency, where the need of the blood is imminent, huge number of blood samples there, donors are available, recipients need blood, but we are having 3 hours of ELISA testing. We will save that time. In that case only, we can go with people will be more authentic in telling about this. Even though we are testing all these organisms, some residual risk remains. Again, because of the middle period, or lack of seroconversion in HIV or SCV, low parasitemia in malaria, viruses show some variability which may not be picked up by the tests, and some laboratory errors can also occur, giving us false negative results. False positive may be there, but they are more considered false negatives. How laboratory errors can be reduced? First and foremost is proper labeling of the blood units and the samples collected at the time of donation. And always that collect the blood to be tested for these agents at the time of donation, not afterwards, not prior. Prior testing is most of us do it, that donation and testing sample simultaneously. Linking of all the screening tests with the donor unit has to be there, and I'm sure that all the blood tests do this very carefully, very meticulously, so mismatch is not there. Usually it's not there. 99.999% times this won't happen because everybody is so experienced, so meticulous about this. How are this can be reduced in a further way? One of them is quality controls, positive controls, negative controls, external controls we can add. Sometimes we have to use our homemade controls. Validation methods have to be used. We have to participate in equal programs. Maintenance and calibration of equipment has to be there, and training and updation of technicians is also equally important. I would say they have to be updated every now and then. Then only they remain updated and do it. Now we come to another aspect of blood donation: infection, that is sepsis. Transfusion-associated sepsis is comparatively low, but it is said that it is the second most important cause of transfusion-related mortality next to ABO mismatch. This can occur because of contaminated blood units or components, and random platelet concentrates to cause the sepsis rather than single donor. The idea is very simple: single donor platelets they are taken, handling is much less. Therefore, probably the thing happens. What are the causes of bacterial contamination? It could be donor bacteremia. Usually, bacteremias are symptomatic, and therefore such donors may be, we can say, kept aside. But if a patient has bacteremia, it can transmit. Second is contamination of collection bag. and third is contamination during blood processing. These three things can be there. Now we can prevent this. What? In what way? One is strict preparation of the viniculture site. SOPs have been prepared, it will be followed meticulously so that the skin contamination from the site of collection are none. Use of blood bags with diversion pouch advised by some people, so that the first aliquot of the blood goes to the diversion pouch, which is likely to contain skin contaminants, goes to the collection pouch, and the rest of it can be collected as a whole duty. Optimizing storage temperatures, it has to be there because at different temperatures, we know that the organisms can multiply, they can give problems to us. Visualization of the components before use is also advised to see whether anything wrong has happened with the bottle of the component. Donor, proper testing of the donor, and if we see that this donor is reliable, has got low behavioral risk, and is negative for all the injective agents, such persons can be counseled, retained, and are motivated to become voluntary donors repeatedly. Voluntary donor selection, again, as I said, all these things we have to do it. And it has been advised that if some donor is tested for any of these agents, we should advise him to voluntarily defer from blood donation. Please don't go for blood donation, therefore, because you are likely to be a threat to the recipient. Many of these persons can agree to it, and this voluntary deferral is a good strategy. Universal leukocyte reduction is also a strategy to reduce the TTI. Other studies include using tests with highest sensitivity specificity, using the kits within the exploration period, so there is no false positive chances, applying upgrades to the lab and the blood bank, so they have to be done. Others like optimizing transfusion indicators, we are going to see about this in the later presentations, and single donor products should be preferred over pooled ones. Thus, to recap in brief, some of the infections can be transmitted by the transfusion. Where we look for 5 dreaded agents, HIV, HBV, HCV, syphilis and malaria, because they may cause morbidity in the recipients. Use of latest method technology as far as possible should be promoted. High sensitivity tests, quality assurance has to be ensured, and this will prevent sepsis by following standard. I think I have come to the end of my presentation. Thank you for listening.
Thank you, sir, for the elaborate and enlightening talk. Many of our delegates are looking forward for your presentation. Now, I would like to invite queries from the audience side.
Sir, this is Dr. Sachin Medical College. When sir was talking, I was transported back to my medical college days in 1992. When sir used to teach us, he was a wonderful teacher and we used to be his fan. And the same spark and same clarity in hearing your lecture. There was a trio, I would say 3 musketeers of microbiology department, sir, Karyakarte sir, and Jalna. 3 of you were wonderful teachers. Thank you so much.
Thank you very much, sir, for very and for enlightening our concepts about TTI. I was not that fortunate as Sachin Kai sir was there, but because I was postgraduate when sir was there. But now today I got that opportunity, and really I am very much impressed by the presentation. Sir, I want to ask 2 questions. One, that I have recently read about transmission of hepatitis E through blood transfusion, and the other one is about the comment about the COVID-19.
So COVID-19 probably won't be transmitted because most of the patients are so symptomatic, they won't come for donation first. Hepatitis E, well, there is no carrier stage per se for hepatitis A as well as E. So chances are very minimal. It would be an accidental transmission, I don't know, but chances are very rare because there is no chronicity, no carrier station A as well as B. And T, we know that it will go along with B only, so we don't test for T separately.
Hepatitis E, sir.
E has said that there are no carrier stages, and therefore asymptomatic patients is unlikely to be asymptomatic patients. So they won't come there. That report that you have read might be an offhand accelerated transmission. Somehow the patient or the donor was picked up. I don't know why. I have to see.
Sir, patients having symptoms are referred to us for giving fitness for surgery. Now, most of the times, patient is clinically asymptomatic, latent syphilis, is reactive, and TPH is positive. So, when to use that patient? Whether that any contraindication for surgery or we can use fitness.
No, there is no contraindication for surgery. The patient is going to remain this way throughout his life almost, because even if we treat the patient in that
In our experience, even if you give treatment, the same doctor remains for years together.
Exactly what you
Where do
said.
you fitness then?
So you can give fitness because it's not
What
contraindication.
is
Only
happening
thing
in
is the
spite of giving
surgeons.
fitness for surgery? Patient is repeatedly being sent to us for giving
The
disability.
surgeons are apprehensive. If they take precautions, then syphilis that
My
way.
knowledge, there is no contraindication. Patient is asymptomatic. So what is your view?
So my view is saying, unless the syphilis is treated in primary stage, these antibodies of VDI or TPH, they do not come to baseline. They remain high for years together.
Yes, yes.
Even if the patient is now bacteriologically clear,
In
the
spite of
antibody
giving
the
good
antibody
of
will-
whether with medicine, still titer remains the same.
Exactly. So at the most what we can do is, you treat the patient as if he is having bacteremia with penicillin or whatever drugs that
But
you
I do usually I do prophylactically whether with penicillin under that cover. I am ready to operate.
And the antibodies will remain throughout the life. They won't come down. In latent phase, the antibodies will not come to zero level. No. So you can advise the surgeon that this is what is happening. I have treated
My
the patient with
request is that you
penicillin.
can put a circular.
So if we can,
Because all the time patients are being referred back to me.
because we have done this earlier also for say some other illnesses. For example,
What happens? Surgeons refer to us.
we had reference regarding something else. We have operated a patient on HIV. What to do about OT? We gave got Dr. Sarkar.
Your patient is sent to venereologist. He again gives some treatment.
I know.
And again that patient is sent to us.
Sir, the point is, in this case, you should mention clearly that this patient has been properly treated for syphilis, and the antibodies which have appeared earlier on continue to be there for a long time, and they will not come down to zero level. And therefore, this patient is.
So routinely we are doing hepatitis B and HIV for all patients going for surgery. But VDRL we are not doing every patient.
So there is no need also.
Yes,
There is no
this is what I wanted to ask.
Yeah.
There's no need to.
No.
It's mainly the anesthetists and not the surgeons who are referring.
Thank you for questions.
So, sir, I would like to ask one question. How to deal with the window period testing of HIV? Suppose a donor comes in window period and you are testing the HIV infection, there are chances of missing the infection. So, how to deal with that?
So it is they have already reduced it to up to 12 days by doing 4th generation ELISAs. At every places we are doing it. It comes to about 12 days. It is not possible to guarantee 100% safety of blood users. We cannot guarantee that. We are only reducing the chances, that's what we can do. With that, it comes down to 2 more days, 10 days. But again, we don't guarantee. Nobody can guarantee that this blood is absolutely safe. No.
So, thank you, sir, for your nice presentation.
Now, I request our chairpersons to consider our speaker. We conclude our first session by felicitating our chairpersons. I request our HOD Dr. Tubanga to kindly felicitate the chairpersons. To chair our second session, I am privileged to invite Dr. Khale sir and Dr. Kare sir. Dr. Khale sir is HOD and Professor, Department of Pathology, MGM. He is Director of the NABL Accredited Laboratory. He was also Organizing Secretary of MAPCOM 2022. He has 20 papers published in national and international journals to his credit. Our second chairperson is Dr. Sachin Kare sir. He is Professor and Head of Central Laboratory, MGM Medical College, Aurangabad. He is a frequent speaker in state and national conferences. He is interested in quality management systems and upgradation of labs and hospitals. He is also known to all of us for his teaching skills as well as his posts on social media platforms. I welcome you both, sir. Now, I invite on stage our speaker for the second session, Dr. Pranita Sontake ma'am. She will be addressing us on challenges in blood grouping and cross-matching. I request our chairpersons to kindly introduce the speaker.
So this is a very interesting session. It is about blood grouping and challenges in it. I think blood group is like marriage. Finding a perfect match is difficult. And even if you find a perfect match, there are unexpected reactions. Very pertinent session. Hello. So it's a very interesting session, and the landscape of blood grouping is changing continuously from simple slide test to now day cards are common, automated machines are coming up. But ABO blood group system remains the cornerstone. But at the same time, there are now increasingly wide spectrum of unexpected antibodies, rare phenotypes, and complex interactions. So to unravel these complexities, we have with us Dr. Pranita Sontake, who is MD from Tata Memorial Center in Immunohematology and Transfusion Medicine. She is also our colleague at NJ Medical College. She is Assistant Professor in Blood Center of NJ Medical College. Her areas of expertise include immunohematological investigations, routine as well as advanced platelet pheresis, peripheral blood stem cell collection in adult and pediatric donors and patients, granulocyte collections, and there is a big list of expertise that she is all having. She is also a member of International and Indian Society of Transfusion Medicine. And not only that, she has received awards as a young professional at 29th Regional Congress in Basel, Switzerland. And she has also received SAM for presenting her oral paper at Basel in Switzerland. She is also a winner of Inquisitive Quiz Contest held by Indian Foundation for Safe Learning in 2018. So we have very illustrious speaker with us, and over to you, Dr. Pranita, for this.
Thank you so much, sir, for the kind introduction. Thank you both the chairpersons. Thank you organizers for the invitation. And we will straightforward start the topic. The topic is challenges in blood grouping and cross-matching. So, as we all know, the blood group you belong to depends on what genes you have inherited from your parents. Right? And the ABO and visual systems are the most important blood group systems that we are routinely tested in the laboratory. So, coming to the genetics of the ABO blood group system, H antigen, A antigen, B antigen. These are the three most important antigens of the ABO system, and And the genes responsible for these antigens are H gene, E gene and B gene. So, if you have H gene in your DNA, then what happens? This H gene produces an H enzyme which acts on the type 2 precursor substance, which is then converted into H antigen. Right? H gene converts precursor substance into H antigen. If you have A gene along with H gene, you will have A antigen, which is produced from H antigen. If you have B gene and H gene, you will have B antigen along with H antigen. If you have both the genes, A and B genes, then you will have H, A and B antigen. And if you have only H gene, no A gene, no B gene, then you will have only H antigen, that will be O blood group. But in case if you don't have H gene, then that will be H deficient genotype. H substance will not be there on your RBC membrane and then becomes Bombay phenotype. So the basic difference between Bombay and O is H is present in O and H is absent in Bombay. So according to the Landsteiner, if an antigen is present on the red blood cells, the corresponding antibodies will not be present in plasma under normal conditions. So therefore, if you have A antigen on your RBC, your plasma will have anti-B antibody. It will not have anti-A antibody. A antibody. If you have both the antigens, you will have no antigen. You will have both the antibodies in your plasma. So this is the basic precursor substance, that is paragomoside or glycan, to which H antigen, to which H gene will form an H enzyme which will attach the fucose, and it will convert this precursor substance into H antigen. To this H antigen, in presence of A gene, acetic galactosamine will be added to form the A antigen, and in presence of B gene, galactose will be added to form the B antigen. So coming to ABO antigens and secretions. We have ABO antigens on our RBCs, as well as we have antigens in secretions also. And what are these secretions? Which have soluble antigen substances: saliva, tears, urine, digestive juices, bile, milk, amniotic fluid and pathological fluids. But the presence of secreted blood group antigens depends on the presence of SE gene. So if you have capital SE gene, then you are a secretor, because that decides whether you secrete the blood group substances in your secretions, for example saliva. So if H gene is there and SE gene is there, you will be a secretor, right? But if you have only H gene and you don't have SE gene, you will be a non-secretor. So almost 78-80% population is secretor, while 20% population is non-secretor. This is very important, because whenever we have a blood group discrepancy, we can always check for the substances that we secrete in saliva. So if you find substances secrete in saliva, even if you are getting the weaker reactions in your grouping, that can be a confirmatory point for your reporting. Coming to ABO subgroups, deletions, mutations or gene recombination in chromosome 9 exons will cause the less effective enzymes production. The enzymes which convert the H antigen into respective antigens, they will be less efficient, and therefore there will be fewer antigenic sites present on the RBC, which will lead the weaker reactions in the serology, and that those we are calling as weak subgroups. Sometimes, most of the times it is quantitative, because number of antigenic sites are less. But then when there is epitopal change or antigenic determinants are changed because of some biochemical alteration, then there will be qualitative difference in the blood group antigens. So subgroups of A, the principal subgroups of A are A1 and A2. To distinguish A1 from A2 red cells, the lectin dolichos bifluorous is used, that is anti-A1 lectin. So if you put a reaction with anti-A1 with a patient cell, if he is A1, anti-A1 will react with that cell, but if he is not A1, anti-A1 will not react. In that case, we should suspect a weaker subgroup, most probably A2, and after that other subgroups. A1. So they are either A1 or A1B. Remaining 20% are the weaker subgroups, and among that 19% are A2. So 20% are weaker subgroups, 80% are A1, 20% are weaker like A2, AX, AM, AEL. But among those weaker subgroups also 19% will be A2 and only 1% will be the rest other subgroups. So it is not necessary to classify group A patients routinely or others as A1 or A2 except when we find an anti-A1 in the reverse grouping of the patient. If we do reverse grouping, and we will come to it later, we suspect that there is anti-A1, then only we go for A1 or A2. Otherwise, there is no need to go for A1 or A2 in the routine type. Subgroups weaker than A2 occur infrequently, as I told, and characterized by the declining number of A antigen sites on red cells, and then higher number of H antigen, because most of the H antigen will remain unconverted. Adsorption and elution techniques will be necessary for the detection of antigens on the surface of red cells. This also we will cover in later slides, and there are mainly A3, AX, AM, and A intermediate. Coming to ABO antibodies, these are the very important antibodies as far as the transfusion of RBCs is concerned. So IgM, there are two types of antibodies, IgM and IgG. In group A and B individuals, IgM is the predominant antibody because like in A group individual there will be anti-B, in B group individuals there will be anti-A. So predominant type of antibody in these individuals is IgM. But when the person is O, donor or patient, the antibodies in his plasma will be predominantly IgG. They will not be IgM, and that is the reason we get avio-hemolytic disease of the newborn. Because if these were IgM antibodies in O group mother and the fetus is B, then if these were IgM antibodies, they will not cross the placenta. They is not able to cross the placenta. But because these are predominantly IgG, we see that in group O mothers, these IgG antibodies are crossing the placenta and they are coating the fetal blood cells, and therefore we get avio-hemolytic disease of the newborn. And this is also important in across the group transfusion of the platelets, because platelets, if they are O group platelets and for some A patient, then we should do the titer of IgG anti-A antibodies in that platelet component, because there is a high chance these IgG antibodies will go and coat the patient's red cells. So across the group platelet transfusions also these IgG antibodies are important. What to do for that? We will see that in later slides. So this reaction phase of ABO antibodies is room temperature. They can activate the complement and therefore there will be fatal intravascular because that will be an acute reaction. And high titer, they are always high titer, react strongly, either 3+ or 4 reaction you should get in the serology whenever you are putting group. Discussed earlier, hemolytic transfusion reaction, these antibodies are most important, capable of causing HDFN, and ABO compatibility is also significant. Yes, compatibility is also significant in solid organ transplantation. Why? For example, renal transplantation. These ABO antigens are histoblood group antigens. RBCs as well as the endothelium. And kidney, as we all know, is a highly vascular structure. It has a lot of endothelial cells. And endothelial cells will have this A antigen. If the recipient is A and donor is B, what will happen? Donor kidney is transplanted, recipient has donor kidney is transplanted, which is B. That kidney is having B antigens on its endothelium. The recipient is having anti-B antibodies. There will be acute graft rejection. So this is very important in solid organ transplantation also. In those cases, we can go for pre-transplant titer, post-transplant titer, and by apheresis we can reduce the antibody titer. There are various strategies, and using those, incompatible transplants are also possible these days. Coming to RH blood group system, RH blood group system is the most important blood group after ABO on the because the T antigen is highly immunogenic, and if transfused to a patient who is D negative, there will be sensitization and production of anti-D antibodies. And that is very important in disease of newborn, because This is the protein antigen, and TRH antibodies are IgG antibodies which can cross the placenta and there will be severe HbF. So coming to RH antigens, there are 5 major antigens that we are testing routinely. We are routinely testing only D, but in patients of thalassemia or who are transfused, it is recommended to test for this 5: capital D, capital C, capital E, small c and small e. So the immunogenicity order is capital D is most immunogenic, then small c, then capital C and small e. D antigen is present only on the red blood cells, unlike A antigens, which is present on other organs also. RHD antigen is clinically the most important because it is highly antigenic. In India, this is the latest data. 94.61% of the population is Rh positive and 5.39% is Rh negative. D antigen is made up of various epitopes that were originally defined by the D antibodies made by sensitized individuals. So these D epitopes are antigenic determinants. These are highly conformational and amino acid changes have resulted in altered D antigens. And these altered D antigens are classified into weak D, partial D, DL and non-functional RH. So what is weak D? This is a very frequent query everybody is having and that becomes important for reporting of the blood group also. So weak D is red cells with a reduced number of D antigens. Indirect antiglobulin test for detection. So if the number of antigenic sites are less, we are putting the cells, we are putting the antiserum and we are looking for the agglutination. With lesser number of antigenic sites, there might not be this agglutination. And the reagents that we are using for anti-D are IgM type. So the agglutination, they only cause sensitization, but agglutination will not be visible. For that we are using IAT. So IAT will cause what? We are putting an anti-human globulin which will bring the sensitized RBCs together and will cause the agglutination to be visible. So DU red cells are agglutinated by some anti-D sera and not by others, but mostly it is reacted by the AAG technique. And 2017 review estimates that 0.2 to 1% of routine RHD blood clotting result is a serologic weak D phenotype in India. In India, 0.2 to 1% only. Most of the weak D individuals do not make, this is very important. Even if inadvertently we miss whether it is weak D and we consider a patient as positive, D positive, and if we transfuse D positive blood to this patient, most individuals will not make an anti-D when transfused with D positive blood. So that is not clinically significant. It is significant in partial D. So what is partial D? It can make anti-D when they are exposed to conventional D antigen. So partial D is if there are 37 epitopes of normal RHD antigen and in some individuals 1 or 2 epitopes is missing, right? So in routine typing, our antiserum is having antibodies against his epitopes. So he will be typed as positive. But if we transfuse D positive blood to that person and unfortunately that person is having an epitope which is missing in the patient may form an antibody against the epitope which donor is having. So there is a possibility of anti-D antibody formation, that is sensitization, and if subsequent transfusion also happens to be with that individual or the same antigenic phenotype, then there will be a hemolytic transfusion reaction. So partial D is important in that sense, but during routine serology we cannot differentiate between weak D and partial D. So D elution, an extremely low level of D antigen that can be detected only by adsorption and elution studies and not by any of the routine serological methods including IAT. And what is Rh null syndrome? The absence of all Rh antigens characterizes Rh null. So Rh null, they will not be having any Rh antigens. Rh null red cells exhibit membrane abnormality. They have stomatocytes and therefore reduce survival. And they are known to develop antibodies to the Rh system. So what is the significance of weak D testing? In all the donors, we go for weak D testing. If non-reactive with anti-D, test by indirect antiglobulin test. In all the pregnant mothers, we have to go for the weak D testing because because if mother is weakly positive, we have to give immunoprophylaxis to the mother. Sorry, if mother is weakly positive, we can omit immunoprophylaxis in mother, even if baby happens to be positive. But if we have to confirm that if the mother is negative, we have to give the immunoprophylaxis. Of RHD negative mother. If mother is negative, we have to test the newborn for TB. If the newborn is typing as negative in the routine testing, we have to go for the weekly testing of the newborn. And if the newborn is weakly positive, we have to give the post-delivery immunoprophylaxis that we give. So that we cannot miss. In recipients, the role of weekly testing is less clear. Many blood banks don't do weekly testing on recipient red cells. So it is not required because even if the recipient is weakly positive, you have to consider the recipient as negative and transfuse negative blood to that recipient to avoid like to be on safer side. So if found negative, B negative. If found weakly positive, both receive B negative blood. But if you want to report considering the recipient mildly future donor and we should know his correct blood group, you can report as weakly positive. But as far as all the transfusion purposes are concerned, the recipient has to be considered Rh negative. Rh antibodies are IgG antibodies. They are actively at 37 degrees Celsius or with AHG. They do not bind complement, and that is why the hemolysis that is caused by these Rh antibodies, anti-D antibodies, is extravascular, and that is why it is delayed. So if Rh mismatching is there and there is transfusion reaction, so that will be delayed. Unlike JIIU mismatch transfusion reaction, which will be very acute and fatal. Cross the placenta because they are IgG and therefore they are causing hemolytic disease of the newborn. And because they are reactive at 37 degrees Celsius, they are very clinically significant. They will result in shortened red cell survival, and therefore we always need to transfuse negative blood to the negative recipient. So coming to grouping discrepancies. So routinely we are supposed to do the cell grouping and serum grouping of every patient or donor sample that we receive. So cell grouping is like this. So as we see here, anti-A and anti-B, so that is the anti-serum that we are putting onto the cells of the individual of which we are performing the blood group. So that is cell grouping. Cells are having antigens that we don't know. So we have to have something that we know. So we are having antibodies which are known. So we are putting antibodies onto the cell, that is anti-A, anti-B. This is our cell grouping or forward grouping. A, C, B, C, O, C. The A cell, B cell and O cell. If you want to test the plasma, plasma is having antibodies. So we are testing for the presence of antibodies in the plasma. So antibodies are unknown. So we have to add something known, and that is why we are adding cells that are known. So A cells, B cells and O cells. These are pooled cells to have the maximum antigenic representation. We are pooling 3 known donor cells together, minimum 3, identified to have the maximum antigenic size representation. So A cells, pooled A cells, pooled B cells and pooled O cells. That is our reverse grouping or serum grouping. So anti-A 4 plus, anti-B 0, A cell 0, B cell some reaction, O cell some reaction. So anti-A, anti-B, the reactions we interpret that the blood group is A because reacting with anti-A, not reacting with anti-B. And there is some reaction in the B. Actually consider it as 4 plus. So A cell 0, B cell 4 plus, O cell 0. So what is the interpretation of reverse grouping? The antibodies are anti-B. So if antibodies are anti-B, antigen will be A, only RBC. So interpretation of forward grouping is A, interpretation of reverse grouping is also A. Both the interpretations are matching, and then only we can report the blood group of that particular individual. And when these two reports are not tallying with each other, they are not matching, that is what is a grouping discrepancy is. So a grouping discrepancy occurs when the red cell testing does not match the serum testing result, or does not match the reverse. So how we suspect the grouping discrepancy? we expected a strong reaction with the B cells if the individual was A. But there is no strong reaction, it's a weak reaction. So we suspect that there is a grouping discrepancy. So reaction strengths could be weaker than expected and some reactions may be missing. So if there was no reaction with B cell, that reaction was missing. Because interpretation of forward was A. But we expected a reaction with B cell that was missing, and there might be some extra reactions in the reverse grouping. That is also a discrepancy. We will see it later. So what are the causes of discrepancy? Most important causes of discrepancy are clerical issues, mislabeled specimen or testing tubes, improper recording of test results. So mislabeled specimens or wrong blooding tube is the most important cause of fatal aviohemolytic transfusion reaction. So these are the bedside causes, and improper recording of test results, this can happen in blood bank. So always it is important to confirm the results with two different individuals to finally interpret. So these are the clerical issues. Technical issues: not following the manufacturer's instructions, deleted procedural steps, missed or interpreted weak reactions, incorrect interpretation of serological reactions, missing or incorrect reagents test samples, contaminated anti-sera or cells, and incorrect cell suspension. So we need 5% cell suspension for tube testing. So it has to be 5%. Then only we get the correct results. Clinical issues: there might be problems inherent to the patient or donor. So for that, essential information such as age, patient's or donor's medical condition, medication, recent transfusion history, must be considered. Example: you are testing for a newborn's blood grouping. You are getting weak reactions. So first you will see what is the problem, what is the patient's demographic. So he is a newborn. We are expecting a weak reaction because newborns' antibodies are not well developed. So that is the problem inherent to the patient, right? So group 1 discrepancies. Group 1 discrepancies are unexpected reactions in the reverse grouping due to a weakly reacting or missing antibodies. These are most common. Group 2 are unexpected reactions in the forward grouping due to a weakly reacting or missing antigen. These are least common. Group 3 are caused by protein or plasma abnormalities and result in the Role formation or pseudoagglutination, and these are caused by elevated levels of globulin. You may get bad agglutination in these cases, that we will see later. And group 4 discrepancies due to miscellaneous problems. We will see. Before that, what is the general approach for solving discrepancies? Whenever you are investigating ABO group, RBC and serum grouping reactions are weaker reactions typically represent the discrepancy. So you should expect 3+4+ reactions in your serum grouping and cell grouping. If there are weaker reactions, suspect your discrepancy. When a blood group discrepancy is encountered, all results must be recorded, but the interpretation of the ABO type must be delayed until the discrepancy is resolved. So proper communication with the clinician is very important. You should never report until your discrepancy is solved. You have to record all results, but delay it until the discrepancy is solved. First step is obtain fresh sample from the donor unit or patient to rule out discrepancy due to contamination or unidentified samples. Repeat the test if additional investigations are carried out. Repeat cell grouping with fresh anti-sera, a different lot if possible. Perform a direct antiglobulin test on the cells to detect if cells are coated with antibodies in case of previous transfusion or AIH. Why? Because if cells are already coated with the antibodies, these antibodies will mask the antigen that we are interested in. So we may get false negative reactions. So always perform a DAT in case of discrepancy. And very important part is quality assurance of reagents, correct technique, careful observation, and interpretation of results resolve many problems. So, coming to group discrepancies. These are unexpected reactions in the reverse grouping due to a weakly reacting or missing antibody. So, weakly reacting antibody can have physiological causes like newborns or elderly patients. They have decreased expression of antibodies. Patients with leukemia or lymphoma. Then patients on immunosuppressive drugs for the obvious reasons, immunosuppressive the antibodies to the desired level. Patients with congenital or acquired agammaglobulinemia or immunodeficiency diseases, patients with bone marrow or hematopoietic stem cell transplants, patients whose existing ABO antibodies may have been diluted by transfusion of plasma or exchange transfusion, especially pediatric patients, because they have less total volume of the blood, and ABO subgroups. So, this is an example. Anti-A is giving 4+ reaction, anti-B is giving 0 reaction. A cell, this is our forward grouping. A cell is giving 0 reaction, B cell is giving weak reaction, and O cell is giving 0 reaction. So, there is a missing reaction or weak reaction in the reverse group. So, this is type 1 discrepancy, and forward interpretation is A, but reverse we cannot interpret. So first we should repeat the test with increased serum to cell ratio and incubation time. Why? Because ABO antibodies react optimally at cold temperatures, room temperature, 4 degrees Celsius to the room temperature. So we have to enhance the reaction. We want to enhance the reaction so that the agglutination will be stronger. So for that we can decrease the incubation temperature. So incubate the serum and cell mixture at 4 degrees Celsius. Also increase serum to cell ratio because antibodies are weak. If you increase proportion of serum, there will be more number of antibodies added to the cell. So that will also enhance our reaction. And if you increase incubation time, that will provide more time for the reaction. So these 3 factors we can enhance our reaction, and most of the times the discrepancy is resolved. And always include auto control. If auto control is negative, then and if you get 3+ reaction after increasing serum to cell ratio, increasing incubation time or decreasing temperature, you can always report it as A. So this is group 1 discrepancy. Second example of group 1 discrepancies is antibody. Earlier we saw the missing antibody or the weaker reaction. Now we see the additional antibody. So anti-A 4+, anti-B 0, A cell 1+, B cell 4+, and O cell 0. Here, interpretation of forward grouping is A, but the interpretation of reverse grouping, if we consider this as 1+ reaction, that will be O. So both are not matching. So we will repeat testing, including auto control and an antibody screen. So what is auto control? The patient cells and the patient serum, which we will put a reaction to identify whether there are any autoantibodies which have got spilled into the serum. So if your auto control is negative and antibody, what is antibody screen? We are screening the patient serum for identifying or seeing whether there is an alloantibody. Manju ma'am is going to take the next session on antibody screening. So if there is an alloantibody, irregular antibody. So what are irregular antibodies? If I am A, I am having anti-B antibody, that is regular antibody, that is expected antibody, that is naturally occurring antibody. But if I am having any other antibody other than B, then that is irregular antibody. And irregular antibodies are produced against the other blood group system antigens, like there are other blood groups like MNS, K, KIT, Dept. So if I am having anti-B antibody because I am A, then that will be regular antibody, and along with that I am having anti-KIT antibody, that will be my irregular antibody, anti-M antibody, that will be my irregular antibody, right? So M, N, P and Lewis, these are the antibodies which react at room temperature. So here, if your auto control is negative and antibody screen is positive, you should suspect an alloantibody, which is irregular antibody, which is reacting at the room temperature. So we have to go and screen and identify that antibody, then only you can resolve it discrepancy. If your auto control is negative and antibody screen is also negative, then here you can suspect a subgroup of A with anti-A1, because forward is A, reverse is also A if you don't consider this A situation. But there is a weak reaction in the A cell that can be because of anti-A1, which is produced by A2 individuals, because A2 individuals and A1 individuals both will give strong reaction in the forward grouping, 3+ or 4+. So in forward grouping you cannot differentiate A1 and A2. But if you see such kind of reaction which is there in A cell, it is 1 plus reaction. So there might be a possibility that that is an A2 individual who has formed anti-A1 and that is reacting at room temperature. So there is one more example. Example 1, anti-A4 plus, anti-B0, A1 cell plus 1 plus 4, O cell 0, autocontrol negative. The tentative group is A and that is again second example, anti-A4 plus, anti-B4 plus, A1 cells 2 plus, B cells negative, O cells negative and autocontrol negative. That is tentative group is A, AB, but that can be a case because in A1 cells you are getting a weak reaction. So that can be a case of production of anti-A1 in either A2 or A2B individuals. That can be resolved by using lectin. So use anti-A1 lectin. If the cells are reacting with A1, there is no possibility of A2. But if they are not reacting with A1, suspect A2. For that, again, you have to go for salivary testing. If you are suspecting A2, then go for salivary testing. See whether the H substance, A substance is secreted in the saliva, right? And next is elution and adsorption. We will come to it later. So these are the ways to resolve the discrepancy. At least we should suspect the discrepancy. Then irregular anti-IgM antibodies. If the patient is having anti-N antibody, it is reacting at room temperature. So there is reaction. In example 3, anti-A0, anti-B4 plus, A1 cell 4 plus, B cell 1 plus, O cells, even O cells are giving reaction 1 plus, and autocontrol is negative. So go for antibody screen, identify the antibody. There is a high possibility that you will get an antibody like anti-M, anti-L, which is reacting at room temperature. Coming to group 2 discrepancies, these are least common. They are unexpected reactions in the forward grouping due to a weakly reacting or missing antigen. What are the common causes? Subgroups of A and B, leukemia or Hodgkin's disease, wherein there is weakening of the antigens, the acquired BA phenotype, and antibody-coated red cells that are BA positive red cells. So here you are getting 2 plus reaction with anti-A, 4 plus reaction with anti-B, 0 with A cell, 0 with B cell and 0 with O cell. So there is a weaker reaction in the, actually there should be 4 plus reaction in the B cell listed. So here you can suspect there was a 4 plus reaction in the there should be a reaction in there should be reaction in the A cells. You should suspect a weak subgroup AX and AY, not even A2, because A2 will give a stronger reaction in anti-A. There can be a diagnosis of leukemia, Hodgkin's lymphoma, because there is a weaker. Actually, this was right. This is the example of second thing, that is leukemia, Hodgkin's lymphoma. The patient was earlier AB, but the A antigen has been weakened because the patient was of leukemia. And how to resolve testing after detailed history with increased incubation time or decreased temperature with different antisera, use of lectins to resolve the subgroup discrepancy, and confirmation by adsorption elation and saliva test. Then group 2 discrepancies wherein we have extra antigen. So here anti-A4 plus, anti-B2 plus, A cell 0, B cell 4 plus, O cell 0 and autocontrol is. So interpretation of forward is anti-A4 plus and 2 plus anti-B. So that will be AB, but the reverse it will be A. But the reaction with anti-B is weak. So we will consider the interpretation of forward grouping to be true and forward grouping to be discrepant. So this can be a case of acquired B in carcinoma of colon or rectum, intestinal obstruction or gram-negative septicemia. What this bacteria do, E. coli, they cleave the galactose, N-acetyl galactosamine, which resembles the galactose after cleavage by the bacteria. And galactose means B antigen. So the reaction here with anti is usually much stronger than with anti-B. Test the patient's serum with his cells. Anti-B in the patient's serum does not eliminate. If you resolve because of the E. coli, which cleaves the N-acetyl galactosamine, and the remaining antigen resembles the B antigen, and therefore anti-B antibody reacts with that. And how to resolve this discrepancy? When you suspect it, reaction with anti is usually much stronger than with anti-B. That is the case with our example. Test the patient's serum with his own cells. If you test the patient's serum with his own cells, in case of acquired B, anti-B in the patient's serum does not agglutinated red cells with acquired B antigen. So acquired B will not be agglutinated by patient's own anti-B. For the confirmation, you can test the saliva for the presence of A crystals. If the patient is a secretor, A substance is present but not B. Use acidified anti-B anti-serum. It will agglutinate only true B antigens and not acquired B antigens. This is how you can resolve that acquired B. Then BA phenotype is similar to acquired B. Reaction pattern is same. It is an autosomal dominant phenotype characterized by the A expression on group B red cells. The gene transfers small amounts of the A sugar to the H antigen. Sometimes certain anti-A reagents will detect this trace amount of A antigen. And how to resolve it? Test with another anti-A reagent from another manufacturer. And if not resolved by this, molecular testing is the last option. Right? Anti-red cells. When red cells are coated with antibodies, we mask the antigens on the surface of the red cells and give false negative results. Because antigens are already masked, so we get no reaction. IgM-coated red cells, if we want to elute the antibody which is there on the red cells and which is IgM, what we can do is 45-degree elution technique followed by warm washing or treatment of IgM-coated red cells with dithiobutol or 2-mercaptan. When the cases of IgG antibodies which have coated the red cells, warm reacting antibodies, IgM are cold reacting antibodies, IgG warm antibodies coating the red cells, we can treat the IgG coated red cells with the DAT and ABO protein on the test which have been eluted with the antibody. So what is elution and adsorption? Elution is the extraction of one material from another, usually by means of organic solvent. As applied in immunohematology, it entails the removal of antibody from coated RBCs. So all the RBCs of the patient or donor, not donor, mostly in patients, they are coated with the antibodies, and therefore we cannot interpret the reactions. There are false negative reactions, positive reactions sometimes. So what we have to do is, we have to detach that antibody from the cells of the patient to know the exact phenotype of the patient. Because the antibodies are masking the removal of such antibody from that RBC is elution. And what is adsorption? Removal of antibody from serum by adsorption to red cells carrying the corresponding antigen. For example, if I am having anti-E antibodies in my serum, anti-E antibodies which are there in serum, and my serum is being tested, and because of these antibodies which are interfering with the reactions, it is not possible to report my blood. What will I do? I will take the cells with no phenotype, that E antigen positive cells, and I will use to adsorb the anti-E antibody from my serum. So there is a procedure. This is basically adsorption. So that can be auto-adsorption or allo-adsorption. We will see it later. So what is the principle of elution? Interference. Basically, in elution, there is interference with the non-covalent binding process that hold antigen-antibody complexes together on the red cell surface. Because covalent forces are keeping the antigen-antibody together. Because they are the forces which hold them together. If we disturb this, there will be disruption of the antigen and antibody complex. Cell membrane can be disrupted by heat, ultrasound, freezing and thawing, detergents, organic solvents, or alteration in pH or temperature. So here is the illustration. Elution is the process of removal of antibody of the red cell membrane. It is destroyed in the process while the antibody is left free in the saline. So we have detached the anti-E antibody from the E positive red cells. In gentle elution, what is gentle elution? In gentle elution, we can keep the cells intact. We will not go into the details of this, but that is just to have an idea. So this is the way we can test the DAT positive cells also by detaching the antibody. What is adsorption? It can be autoadsorption or alloadsorption. Removing the antibodies in my serum with my own cells, that is autoadsorption, and removing the antibody in my serum with known cells of other individuals, alloadsorption. So cold reacting autoantibodies may mask the concomitant presence of clinically significant antibodies. Serum is adsorbed in cold with enzyme-treated autologous red cells that will remove most of the cold autoantibody. So in most of the AIHA cases, there is problem in the reporting of the reaction. There is agglutination with all the cells and all the, agglutination in forward and reverse also. So if we want to, the DAT is also positive in AIHA. So if we want to go for the real phenotype of the red cell, we can detach the antibody of the such DAT positive red cell, cold autoadsorption, and then such eluted cells, the cells from which the antibody has got eluted, we can test the cells again with this NTA, NTP and the reverse. Allogenic adsorption in the patient's genotype is unknown. So what are the cells selected for allogenic adsorption? Group O red cells of the phenotype R1, R1, R2, R2 and smaller. We will not go into the details of this also. One of these should be KID A negative and one should be KID B negative. At least one should be K negative. The cells can be treated with enzyme or ZZAP. Enzyme or ZZAP treatment will denature the other antigens, other nervous system antigens. These are the antigens which are not denatured, KID and KIL. That is why we have to select the cells native for this antigen. And when the phenotype is known, cells should match the patient phenotype. At least should have same RH and KID phenotype. Mix serum with antibody with red cells corresponding antigen. Incubate at an appropriate temperature. Anti-E antibodies have been adsorbed out of the serum and onto RLCs. So anti-E antibody was there in the serum. What we did, we put the known E positive cells into that mixture and we made the anti-E to be adsorbed on the cells. And that is how we have removed the anti-E from the test sample and then we can test the serum for our test of functions. Then group 3 discrepancies caused by protein or plasma abnormalities and result in the Role formation or pseudo-formation. Here NTA4+, NTP4+, A cell 2+, B cell 2+, O cell 2+, and even autocontrol is also positive. This is pan-agglutination. So there might be elevated levels of globulin, elevated levels of fibrinogen, plasma expanders, worsen JD in the border and basically globulins are interfering with the test. And that is also the Role formation, stacking of erythrocytes densely microscopically. So Role is the stacking of erythrocytes that adhere in a coin-like fashion, giving the appearance of agglutination. Resolve by washing the cells. If you are getting Role in the forward grouping, wash the cells with normal saline 3 to 4 times. Your Role will be resolved. And if you are getting Role in the reverse grouping, perform saline replacement technique. What is that? Reagent cells and patient serum centrifuge to allow the original antibody to react. Serum is removed and replaced by an equal volume of saline. Tube is mixed, centrifuged and re-examined for the agglutination. Role disperses but not true agglutination. So whatever serum was there in the mixture, we have removed it and we have replaced it with the equal volume of saline. And if we see if there is no agglutination, that means it was Role. But if there was agglutination, it was true agglutination, not Role. Coming to group 4 discrepancies, miscellaneous problems such as autoantibodies, alloantibodies mixed with agglutination as in chimera or cis-plate. So here NTA4+, NTP0, A cell 1+, B cell 4+, O cell 1+, and auto 1+. So in case of cold autoantibody, autocontrol is positive, so we are suspecting autoantibodies there. And forward interpretation is A. Reverse interpretation, B cell we are having strong reactions, so antibody is there in plasma. 1+ reactions are discrepant reactions. So we can suspect group A is cold and autoantibody. Here we can resolve by autoadsorption and cold reactions or pre-warm testing. Pre-warm testing is incubate the cell and fluid mixture at 37, cell suspension first incubate at 37 degrees Celsius. Serum also incubate at 37 degrees Celsius and paste all this at 37 degrees Celsius because cold antibodies will not react at 37 degrees Celsius. Mostly this will resolve not resolve by autoadsorption at 4 degrees Celsius. So here, from the serum, what we have to do first, autocells, the cells of the patient which are already coated with antibody. First, we have to elute the cells, elute that antibody from the cell, and such eluted cells we have to again use for adsorption and remove the antibody from the serum and then do the serum protein. This reaction will disappear. A cell, T cell, sorry, A cell, O cell, and auto T cell disappear. So that is how we resolve. Then cold alloantibody, same case, but autocontrol is negative. So that can be cold AB, group AB here with cold alloantibody. Cold means reacting at room temperature or 4 degrees Celsius. So mostly these are NTM, NTN, NTP levels. Perform pre-ground testing like discussed earlier, and do antibody screen and panel. Identify room temperature antibody. Repeat serum type with antigen negative reagent cells. What is mixed field delineation? Chimera is an individual with two separate cell populations, A cells and O cells. This is very rare. It can be artificial or permanent. As we see here, anti-A, we are seeing mixed field reaction because there is one population of cell which is giving reaction and there is other population of cells which has settled down. So there is no reaction. Anti-B, no reaction. Anti-D, positive reaction. Control is negative. A1 is negative and B is positive. So there is reaction with B cells. So we are suspecting the A group, but in A, anti-A, there is mixed field reaction. So this can happen, and A recipient is transfused with the, or stem cell transplant has been done and the recipient is A and the donor was O. So there is a population of cells of donor which is O and population of cells of the patient, that is A. So this is a transient chimera that will resolve once the engraftment of the stem cells in the recipient is complete. So we have to monitor this reaction throughout the transplant phase, and that is how we can resolve. If the patient has been transfused with group O and patient was A, this picture can be there, both the populations of the cells. So history is very important. Then fetal-maternal hemorrhage, the fetal cells go into the mother's circulation. You can also get this picture. Bone marrow transplantation as explained. Then the ABO group of the donor is different and the other is different. Intrauterine transfusion with O group cells and the fetus is A or B. Exchange transfusion in similar cases. One of the cell populations will live only for a short time, which is making this type of chimera transient phenomenon. What is permanent chimera? Linked means when an exchange of zero due to vascular anastomosis, both cell populations grow and both recognized as self. Dispermy, when the two sperm cells fertilize one egg, will result in two cell populations which exist throughout the life because both are recognized as self. What is this AB? Many of the times where it happens that father is AB, mother is O. So what is the expected blood group of the baby? Either A or B. Because one gene is inherited from one parent, the other from the other parent. Because mother is O, she is not having A or B gene. So baby has to inherit O gene only from the mother and either A or B gene from the father because father is AB. So baby cannot be AB. So baby can be AO or BO, so baby can be A or B. But in this case, baby is A. Why? Because the father is carrying both A and B genes on the same arm of the baby. So they are in the cis position. Normally they are in trans position on the opposite arms. But in such cases, father is having both the A and B genes on the cis position on the same arm of the chromosome, which the baby has inherited. And from mother, baby has inherited O gene. So the blood group of baby is A. So paternal, discrepancy is there. In that case, this has to be kept in mind. So how to resolve this CME? Patient history is very important. Molecular testing is the ultimate option of resolving. So grouping, forward, reverse. In forward grouping, there can be missing or weak reactions. Suspect AB subgroup or disease like cancer. Extra reaction, acquired B, DA phenotype or Role. Mixed field, O transfusion or bone marrow transplant. Reverse, missing or weak reaction. Young, elderly or immunocompromised patients which have decreased levels of antibody. And if extra reaction is there, there can be cold autoantibody. old alloantibody, Role, and anti-A1 So next part is remaining, that is compatibility testing. It is also called pre-transfusion testing. Set of procedures that brings the clinician's order of the right blood product and dose for the patient. So it starts from this right blood product order and dose for the patient. The purpose of pre-transfusion testing is to select blood and its components so that they will have acceptable survival when transfused and they will not cause the destruction of the recipient's red cells. So what are steps in pre-transfusion testing? Positive patient identification is very important to avoid the long blood review. Selection of the blood samples of the patient. ABORH blood grouping of the patient. RBC antibody screening on serum or plasma sample of the patient. Comparison with previous records. Selection of appropriate blood components. Performance of the compatibility testing. Labeling of the unit with details of the product and patient identification information. Generation of compatibility report that is to be given along with the blood product. So if patient has a history of blood transfusion, his previous transfusion records must be checked for IIMSR group, unaffected antibody or antibodies, any problem in cross-matching, any transfusion reaction. And if there is discrepancy that is found in previous records and fresh sample, fresh testing, a fresh sample should be requested and tested to confirm the correct blood. And if there are no records, there might be error in our reporting because this sample might be wrong with you. In that case, ask for a second specimen at a different time and retest on the same. If both match, then only will confirm. Abiotyping has to be done. Cell serum discrepancy is noted if any and should be resolved. And if the blood requirements are urgent and discrepancy is yet to be resolved, urgent O group unit should be selected for the cross-matching in case of emergencies. RH typing has to be done as explained. Antibody screening has to be done. And if screening is positive, antibody has to be done. And in case of identified antibody, antigen negative blood preferably or cross-match compatible blood should be given. And if antibody is identified, you should go for antigen phenotyping. What is antigen phenotyping? If you have identified anti-KL antibody, take the patient's cell and test it with anti-K antiserum. Anti-K antiserum is known anti-K serum, and the patient should be negative for anti-K. So that will confirm your antibody that is identified. So antigen phenotyping should be done. Then selection of component and testing. Once the recipient testing is complete, stable unit needs to be selected. You have to go for routine checks. ABORH group has to be done. Check for TTI screening status. Very important. Every time you are selecting a unit for cross-match, go back and check the serology of the unit. Check the expiry date. Any visible hemolysis, color change, clots or any leakage. After selection, the unit should be rechecked with the segment available with it for ABO and RHD group, and same should match over the donor level tested over the unit. The tubing segment attached with the blood unit should be used for testing. Always select first priority ABO identical antigen negative unit, and in group AB patients, if you have transfused A group or B group, suddenly don't change it to the from A, suddenly don't change it. In more than one unit, the is given in a continuous transfer. The decision to change back to specific blood should be based on the presence of or absence of the antibodies in the serum. A or B. Then, red cell components, choose identical first. O group RBCs are the universal. AB is the universal plasma. Go for RHD positive for positive patient. Go for RHD negative. So baby blood group, in case of neonates less than 4 months, is a classical transfer of the IgG antibodies from mother to baby. So cross-match has to be done with mother also along with the baby. And the compatible unit with mother and baby both should be. So if baby blood group is O and mother's blood group is O, blood group is O. If baby is O, mother is A, if mother is B or AB, is not compatible. So always go for OB. identify to RH negative patients who are males and beyond menopause females in case of emergency, provided there is no anti-D antibody formed. And whenever there is impossible to identify the specificity of available antibody, even if having antibody and we are not able to identify the specificity because we don't have a cell panel or there is an emergency transmission requirement, patient serum should be cross-matched to the several units of same ABO RHD type to select the compatible units of blood. Not possible to, if there is no possibility of finding compatible units of the blood, we have tested several units getting the compatible unit. Patients' relatives, especially siblings, should be tested as they have a higher probability of being compatible. And if we find compatible unit, immediate unit, and they will be transfused. FFP should be ABO identical, the recipient's blood cells are compatible. In neonates, ABO identical plasma should be preferred. No consideration for RHD matching is not important in FFP because that is not any cellular component and RHD is present in the recipient does not require ABO RH grouping except in neonates. In neonates, because volume is small, we are giving group identical or compatible cryo, but in adults not giving. Platelet concentrate as far as possible ABO RH type specific the recipient. In case of shortage, type specific RDPs can be given without visual red cell contamination. And if you want to transmit across the group STP, especially O group STP to D group recipient, plasma reduce it, remove the plasma out of it, or replace the plasma with platelet additive solution that becomes compatible. And infants with age of 1 year should be given only identical platelets. So compatibility testing, we all major cross-match and minor cross-match. Major means patient serum, donor cells, and minor donor serum and patient cells. So immediate screen means we are incubating the patient serum and donor cell at room temperature to find the ABO incompatibility because that will detect only IgM antibodies and it is important to prevent the ABO mismatch. And immediate cross-match is very important because it detects the clinically significant IgG antibody. So anti-globulin cross-match has to be performed even if you omit the immediate screen. That is the cross-match which will only detect the significant antibody. So in emergencies, if clinician requests that the life transfusion is life-saving and we cannot complete the transfusion testing, give group 4 X cells and group AB plasma appropriately on the receipt of the signed written request of the treating physician stating that the clinical condition of the patient is sufficiently urgent to require the release of blood before completing ABO and RHD tests and compatibility testing. And after you have issued the blood, complete your standard compatibility test and if there is any incompatibility detected, promptly inform the physician to stop the transfusion. So there may be false positive results in the transfusion because of prolate formation, passively transferred antibodies due to transfusion of platelets or IVIG and antibodies present in the medium. And negative result may be because of technical error, loss of potency of the reagents used, failure to add reagents and equipment failed. So how to interpret when the antibody screen is negative and the cross-match is compatible at the immediate screen phase? There is incorrect ABO grouping of the patient because if we have the donor cell is A and the patient serum is having anti antibodies and if the patient is C, incompatible, immediate screen cross-match will be incompatible and therefore we have got the cross-match positive. So that was an error because of ABO mismatch. Then A2 or A2B individuals with anti-ABO antibody as we saw, anti-ABO antibody is react to the room temperature, react at room temperature and therefore the cross-match will be positive. Other room temperature reacting antibodies, cold auto antibodies and low antibodies. We have to search accordingly and then select the unit which is negative. Negative antibody screen with incompatible antiglobulin cross-match. So antibody screen is negative but AG cross-match is positive. So the cells of the donor can be DAT positive. First do the DAT of the donor. Antibody reacts only with cells with strong expression of particular antigen. सेल पॅनल मध्ये जे अँटीजन्स होते, सेल पॅनल मध्ये जे सेल होते त्याच्यावरचे जे अँटीजन्स आहेत त्यांच्यावर तेवढं स्ट्रॉंग एक्सप्रेशन नव्हतं, पण डोनरच्या सेलवर स्ट्रॉंग एक्सप्रेशन expression only. That is why the patient antibodies reacting with the donor cell. And such antigens are RH with the P, which should dosage. Dosage means homogeneous expression will cause strong agglutination, heterogeneous expression will cause no agglutination. Antibody reacts with an antigen present on the indigenous donor cells but not on the screening cell panel. If the antibody screen is negative and only one donor is incompatible, then antibody in the patient serum is likely to be detected. So, go for cross-matching with other units.
Sanita, we request that you understand this.
So, can I open it actually? Yes.
Please, you come to the conclusion.
So, whatever the result, you have to go one by one. Mathematical calculation has to be done and then arrive at selection of the unit. So, last part is labeling and issue of the blood. That also has been discussed. Proper labeling is very important. Visual inspection of the unit is very important before issuing, and the report has to be given along with the blood examination. Thank you so much.
Quite an extensive lecture actually leads to our this particular talk, I guess, but it's a very good refresher for residents and consultants alike, for all of us actually. Immunohematology is ruled by laws just like traffic, and just like traffic we have some unexpected antibodies, just like in the traffic also we have unexpected antibodies, and here also we have unexpected antibodies. But I hope unexpected antibodies here will be tackled not like the other, but thank you.
Thank you, ma'am, for this illustrious talk and sharing your valuable experience. This was a detailed talk, but if any queries from audience side, I request it. Now I request the chairpersons to felicitate our speaker, Dr. Pranita, ma'am. Now I request Dr. Pathology, sir, to felicitate our chairperson. So after the successful completion of our second session, we are moving on to our inauguration ceremony. A warm welcome to everyone assembled over here for the inauguration of our ceremony, for the inauguration of our CME blood transfusion. I, Dr. Sheetal, take the privilege to welcome you all on this beautiful event at our prestigious institute, Indian Institute of Medical Sciences and Research. We welcome all the distinguished honorable guests, all the faculty members and delegates to this program. I take the opportunity to invite our dignitaries to the dais, our respected Dean Sir, Dr. Azhar Ahmad Siddiqui. Respected CA Sir, Dr. Ilyas Sir. Medical Director, respected Dr. Kadri Sir. Our MMC observer, Dr. Muhammad Abdul Sami sir. Our honorable guest for the event, Dr. Bopre sir. And our respected HOD, Dr. Duba ma'am. Let us start our inaugural function with the recitation of Holy Quran. I request the second year MBBS student to recite the Quran verses.
وتواصوا بالحق وتواصوا بالصبر صدق الله العظيم.
Bismillah. The word asar can be translated as slowly dripping, lightly drip, losing drop by drop. In the same way, every human is facing an unavoidable loss of time. Loss can be defined as losing an opportunity, and the one who are calm, patient, attentive, grateful, faithful will never lose an opportunity. Jazakallah.
Thank you. Now I request HOD Dr. Tuba ma'am to felicitate our respected dean sir. I request Dr. Tuba ma'am to felicitate respected Dr. Ilyas sir. I respect Dr. Tuba ma'am to felicitate respected Dr. Kadri sir. Now I request our dean sir to felicitate our honorable guest. I request Dean sir to felicitate our respected MMC observer Dr. Mohammad Abdul Sami sir. I request Dean sir to kindly address the audience.
Good morning, respected dais and dignitaries of the dais. There are my teachers sitting in the audience also here from JIIMSR and my colleagues also. And it's a surprise, usually I am last. And you asked me to open the hearing this time. Anyway, I hope that I'm enjoying the academic pace. The topic itself is interesting. Usually we had a topic very subject specific, but this time the pathology department has come up with a new and good innovative topic, blood transfusion practices. Because nowadays we know that this is becoming a new science, and we have even postgraduate courses also in this. I hope that our department will also come up with a proposal for postgraduate course in blood transfusion. Nowadays it is coming up in some of the colleges, so we hope that Madam will come up with a plan in a year or so we can also start with the same course. Because MD transfusion medicine is in very few colleges, I think. I don't know whether it's in NGM or not. My friend is sitting there, so it's not there yet. So we can start, Madam. And I hope that keeping an eye on this, many new things are coming up. Previously, when we were students, we were told that O negative is universal recipient, irrespective of any test, we can use a blood. Universal donor, and AB positive is universal receiver. But nowadays, so many changes have come up with cross matching and other things. So we should upgrade our knowledge. And
our UG students are about 25% of them they pass out with distinctions. We have the first batch of PG students who have already passed with flying colors this year, and our departments, pathology departments, get involved in OTT PG. There is one session called which goes on. So even our department contributes a lot of cases in this particular session. So to begin with my word of thanks, I would like to first thank the Almighty, without whose permission nothing is possible at all. At the same time, I would like to thank all the delegates. We had overwhelming response for registration of this particular CME. Then I would like to thank all the faculties from the colleges. I would like to say a few names. I would like to thank Dr. sir, Bhopre sir, then Patwatkar sir, then Manjushri madam, then we have Bhale sir, Sachin Kade sir, Mahendra Singh Chauhan sir, and Pranita has given such a nice lecture coming from outside. But at the same time, we have our senior faculty here, Gauli sir, Faisal sir, and speakers from our institute itself, like Damle sir, Pune sir, and all, for participating in this particular CME. And at the same time, I would like to thank my entire department because it worked very hard and for this particular CME. I would also like to thank some important names like Dr. Jawad Hashmi, Dr. Mohammad Shafiq, IIMSR. So thank you all for coming here, and I hope you all enjoy all the particular sessions. Thank you so much.
Thank you, ma'am. So we will start with our first session. To chair the session, I invite respected Dr. Bhopre sir and respected Dr. Kokatkar sir. Chairperson for this session, Dr. Bhopre sir, does not need any introduction, but as a professor, we are going for it. He was professor of pathology for 26 years and dean for 6 years in various government medical colleges, including JIIU Aurangabad. He worked in Department of Pathology as well as blood bank. He started trauma care center, dialysis, IIMSR, model labor room, cancer hospital, and so many other facilities. He was also head of pathology department at this institute. At his credit, he has more than 30 publications in national and international journals. Our second distinguished chairperson is Dr. Kokatkar. He is presently working as professor and HOD in Department of Pathology at Government Medical College and Cancer Hospital, Aurangabad. He carries a vast experience, teaching experience of 26 years. He has many stars, research projects and publications to his credit. He is also MMC accredited speaker and member of Board of Studies for Dental at MHS Nashik. I welcome you both, sir. The speaker for this session is respected Dr. Manusha Kulkarni ma'am. She will talk on Combs test and irregular antibody screening. I welcome ma'am on the dais. I request the chairperson to introduce the speakers.
Welcome to this session. Hello. Welcome to this session. I think Dr. Manjusha doesn't need any introduction because she is the one who started blood bank services in a very nice and proper way and very well. She's, I'm not reading out anything which has been provided to me. I know her as an undergraduate student, very sincerely. She is originally of Department of Pathology of Government Medical College, Chhatrapati Sambhajinagar. I have worked with her, and her keen interest in immunohematology, I think, took her to what nowadays we call it as blood transfusion services. I hope all of you eager to listen to her with her enriched career of very good experiences of blood transfusion services. I call upon her to start her daily life.
Respected chairpersons, teachers in front of me and dear delegates. I am very fortunate to have Dr. Professor and Dr. Gopalka sir, who are my teachers, as a chairperson. The topic is post-test and irregular antibody screening. Dr. Sontakti had covered almost all the things in antibody detection, ABO grouping, RH typing, clinical significance, and what should be done to issue a unit of blood quotation. Actually, she should have given 2 hours to talk on both the topics. You all know what is antibody. It is a glycoprotein, immunoglobulin, it is formed by lymphocytes in response to foreign antigen, and specifically recognize and bind to a particular antigen. We know immunoglobulins, IgM structure. It's a pentameric molecule with bioimmunoglobulin units paired together by JIIU. It has 10 antigen binding sites. So it is capable of causing visual agglutination in saline cells, incapable of transfer across placenta, can activate complement and cause intravascular red cell hemolysis. The IgG structure is a monomeric immunoglobulin, 2 antigen binding sites produced after second exposure to an antigen, not capable of producing visible agglutination of sensitized red cells suspended in saline. Requires anti-human globulins to produce visual reaction. Responsible for delayed extravascular hemolysis and sensitized red cells. Can transfer across placenta, can cause hemolysis, disease of fetus and newborn. Antibodies to red cell antigens, as she has covered, expected are anti-A and anti-B, unexpected antibodies are there with the result of red cell stimulation after transfusion or hemolytic disease of newborn. Clinically significant antibodies, usually IgG, react at 37 degrees centigrade and with indirect antiglobulin testing. It shortens the survival of are associated with hemolytic transfusion reaction and hemolytic disease of newborn. How the antibodies are detected? The test to detect unexpected red cell antibodies is called as antibody screen. Antibody screen determines whether an antibody to a red cell antigen has been made. Antibody screens are performed to detect antibodies in patients needing a blood transfusion, pregnant women, patients with suspected transfusion reactions, and blood and plasma donors. The presence of antibody may be indicated by following serological tests. A discrepancy is the result of cell and serum ABO grouping, a positive test for unexpected antibodies, a positive direct Coombs test, and incompatible major cross-match. Performing an antibody screen. The method can be manual, semi-automation, or automation. Patient plasma or serum is incubated with screening cells at room temperature and 37 degrees centigrade. Reagent RBCs plus patient serum is used. After incubation, the IIT is performed indirect using AHG reagent. This will detect any IgG antibody. The screening cells are single or pooled donor O cells, commercially available or can be prepared in-house. Why group O cells are used? because anti A and anti B won't react. Screening cells come in set of 2 or 3 vials each. These cells have been phenotyped for most commonly encountered and clinically significant RBC antigens. There are almost more than 35 blood group systems, but all those are not clinically significant. RH, MN, S, Lewis, K, clinically significant blood group systems. There are some potentiators which are used in antibody detection and identification to enhance the antigen-antibody reaction. Saline may only enhance if incubation is for long time. I remember 30 years back we were using only saline cross-match, so we were using 45 minutes incubation. Low ionic strength solution in bovine serum albumin, polyethylene glycol, proteolytic enzymes. How these help in potentiating the reactions? Albumin reduces bomb antibodies, not sensitive for antibodies other than RH, KIT, Lewis, P, and ABO. Low ionic strength solutions also reduces zeta potential. The incubation period is reduced to 10 minutes. Lower ionic strength allows better reaction, sensitive, quick, and it's economical. Polyethylene glycol removes water concentrated antibodies, enhances more autoantibodies, does not react well with insignificant antibodies, increases sensitivity. Enzymes, cold and warm autoantibodies, eliminates reactivity of MNS and F5. We do manually do Coombs test from negative results to 1+, 2+, 3+, and 4+ reactions. And hemolysis is also a positive reaction. How to interpret agglutination or hemolysis? Positive test results, antibody identification is needed, evaluation of antibody screen. What phase lead reaction occurs? IgM at low temperature, insignificant cold antibodies. IgG reacts at 37 degrees centigrade. The clinical significant antibodies we do it by IIM. Factors influencing sensitivity, we all know cell serum ratio. If antibody excess is there, the chance of false negative results are there, that is Kozov phenomena. If antigen excess is there, false negative reactions, it's a post-zone phenomena. Temperature, incubation, and pH also matters. These are commercially available screening cells. Immediate screen, there is no reaction. 37 degrees centigrade, there is no reaction. And in anti-hemoglobin, the 2+ reaction in second type of screening cell. If the AH is negative, then Coombs control cell must be added to confirm the negativity of the test. This is the IgG antibody, single specificity. This is an example to in immediate screen, there is no reaction at 37 degrees centigrade. 2+ reaction is second type of screening cell, and in both anti-human globulin test is 3+. It's an IgG antibody with multiple specifications. Means in both the screening cells, it has come positive with AH. The example, the third one is the anti-human globulin test is positive in both the cases. IgG antibody, it may be allo or it may be autoantibody. Antibody screening is very effective in detecting antibodies. If negative, then the cross-match should be compatible. Antibody screening tests are designed to detect significant RBC antibodies, but they cannot detect antibodies. Antibody screening tests may also yield negative results when the titer of concentration of antibody drops below detectable limits. Antibody screens use 2 or 3 types of screening cells to detect if antibodies are present in the serum. If antibodies are detected, then they should be identified. What do we need to identify? Antibody identification is an important component of the compatibility testing. It will identify any unexpected antibodies in the patient's serum. If a person with an antibody is exposed to donor cells, in the corresponding there are chances of transfusion reaction. So, it is needed to identify the antibody. Still, the facility is not there in our region. But if we come across some particular antibody, we should send the sample to immunohematology center at Mumbai. Antibody identification, history of patient is very important. Why the blood centers insist on complete requisition form is for those things. Patient's history, age, name, sex, diagnosis, transfusion history, pregnancy history, medication, because mixed cell population from a previous transfusion can remain for up to 3 months. Some diseases are associated with antibodies. Some antibodies occur at a high frequency in some races. Technique of antibody screening and identification: saline, enzyme, albumin, indirect antiglobulin test, column agglutination technology, and solid phase technology. Test patient serum with their own red cells, that is autocontrol. Autocontrol is incubated with antibody free or antibody panel. If the screen is positive, then antibody panel, and if it is positive, then direct home test to be performed. Autocontrol cells are important to determine whether the antibodies are directed against patient cells or transfused cells. So it is very important to do not forget the check cells, means IgG coated sensitized cells, to confirm the result of the test of direct antiglobulin test. The manual test has some limitations. So nowadays the AHG is performed by column agglutination technology. Columns made of gel or glass beads. Reaction chamber at the top of column to incubate red cells and serum. Columns pre-dispensed with antiglobulin reagent for direct and indirect home states. Centrifugation after incubation separates agglutinated as well as unagglutinated red cells. No washing is required for AHG testing. Technology is suitable for automation. The advantage is stability of the final reaction phase can be read by several individuals and can be documented by taking a photograph. The columns are made of same. This is a picture of gel packs and gel centrifugation. Actual gel technique is measured volume of serum, RBCs, or both are dispensed into the reaction chamber. Cards standardized and there are. So you should start from the manual testing. Low ionic solution at 37 degrees centigrade, 1 drop of suspended in red cells plus 1 drop of patient serum, mix and incubate for 15 minutes. Centrifuge and take for agglutination. Record the results as previous. To summarize, if an unexpected antibody is detected in patient serum or plasma, it must be identified. Once identified, the clinical significance must be determined. If the antibody is clinically significant, antigen negative donors must be found and cross-matched for the patient. The Coombs cross-match must be done. If the antibody is not clinically significant, it is not necessary to provide antigen negative blood, but the donors must be compatible by Coombs cross-match. Knowledge of the incidence of antigen is useful for determining how many units of blood to screen or cross-match for the patient with antibodies. Intrinsic red cell antigen, hemolytic transfusion reactions, hemolytic disease of fetus and newborn, drug-induced antibodies, passively acquired antibodies from donor plasma derivatives as well as immunoglobulins. Non-specifically absorbed proteins, for example, hypergammaglobulinemia, high-dose intravenous immunoglobulins, or modification of red cell membrane by some drugs. Complement activation due to bacterial infection, autoantibodies, or alloantibodies. Antibodies produced by passenger lymphocytes, for example, in transplanted organs. The key points are: the DNA is used to determine whether red cells have been coated in vivo with immunoglobulin complement or both. DAT is used primarily for the investigation of hemolytic disease of newborn, AIHA, and drug-induced immune hemolysis. The DAT should be used to determine whether a hemolytic anemia is of an immune etiology. A positive DAT may or may not be associated with hemolysis. Performance of DAT on post-reaction specimens is a part of initial investigation of a transfusion reaction. The DAT results may be positive if sensitized reactions have not been destroyed or may be negative if hemolysis and rapid clearance have occurred. The DAT is performed by testing freshly washed red cells directly with the antiglobulin reagent containing result is invalid, possibly indicating spontaneous amplification from heavy coating of IgG or rare form reactive IgM. The invalid DAT result could also be due to IgM cold autoagglutination that were dissociated from routine washing. A positive DAT result alone is not diagnostic of hemolytic anemia. The interpretation of significance of positive results requires hematopoietic progenitor cell or organ transplantation, administration of IVIG or intravenous anti-D. Autoimmune hemolytic anemias are subdivided into major types, that is warm, cold, mixed, and PCHD, characteristic cold hemoglobin. Drugs may also induce hemolysis. There are some few cases which we have faced. 5 years back, 26 years female came to us with 7.1 grams of hemoglobin. Blood group was O positive, as noted, because the blood group was done by either slide method or only forward method. So it was reported as O. And the patient transfused with O positive blood. Transfusion reaction has occurred. Patient developed hemolytic reaction, hepatorenal failure, and then the patient came to us for O positive unit of blood. This history was at the periphery. Then we did forward as well as reverse. And we came to know that in anti-A, anti-B, anti-AB, the reaction was negative. A cell, B cells showed positive. It is like O, but O cells also showed agglutination, and RH was positive. We did anti-H testing. It was probably Bombay phenotype. So we laid 3 Bombay phenotype donors and the uneventful transfusion cells given to the patient. Patient was recovered. The second case was 16-year female with 7.2 grams of hemoglobin. She was reported as B positive, and she was a diagnosed case of autoimmune hemolytic anemia. If we know that the case is a diagnosed case of autoimmune hemolytic anemia, as ICT is positive, we did 5 cross-match, but every cross-match was 3 plus incompatible. But with the consent of clinician, transfuse the patient with this incompatible unit. So it's minimally incompatible unit we are given. The third case was a 50-year 6 hemoglobin, blood group was O negative. The diagnosis was AML. Why the diagnosis is important? Because it affects the results of DAT and ICT. ICT positive, DCT positive. We did compatibility testing for 5 units, and the least incompetent unit was here. Autocontrol was positive for this patient, as it was a known case of AML. Even after screening for all these things, video grouping, RH grouping, or typical antibodies, PAT, ICT, and all those things, the most important thing is in blood transfusion is, we already covered transfusion, transmitted infections also. The rational use of blood is most important. Whenever, I remember Dr. M.D. Agrawal used to say, do not use blood whenever it is necessary. Use it only when it is absolutely necessary. Since last 40 years of transfusion, from whole blood we started. Now we have 13 components which are come with the whole blood unit. That is packed cells, leukodepleted cells, saline wash cells, random donor platelet, concentrates, pooled platelets, fresh frozen plasma, cryoprecipitate, aliquots for creatinine, cryopool plasma, and all the cellular components which are inactivated. Means even after screening all those things, we have a choice to reduce the reaction by using such components also. And biopheresis also, we can use single donor platelets, single donor plasmapheresis, therapeutic plasmapheresis, leukapheresis, cytopheresis, peripheral blood stem cells. Nowadays, instead of using bone marrow, peripheral blood stem cells are used for bone marrow transplant. That also we can give to the patient, and irradiated cellular compounds. This slide I am showing because all these things are available with us, and even after doing all such proper screening of donor, proper testing and storage of atypical antibodies grouping, proper screening of transfusion transmitted infection with nucleic acid testing also, the blood should be rationally used. Thank you. Thank you for patience.
Thank you, Michael, for such an enlightening lecture and very interesting cases. Any queries from audience?
For antibodies, आपण DAT केली पाहिजे DCT आणि DCT केली तर त्याची प्रोसिजर काय त्याला ते ऑलरेडी कम असतं त्याला गरज आहे का अँटीबॉडी स्क्रीनिंग केली पाहिजे आणि बरेच लोक DAT पण करतात
हे साधारणपणे पेशंटची रिक्वायरमेंट आली की केलीच पाहिजे.
आणि त्याला ते ऑलरेडी कम कोल्ड ऍक्टिव्हिटी कम त्याला काही वार्म करून वगैरे
But I mean, what happens in UAT with this problem of strong suspicion of immunohemolytic anemia, immunohemolysis, but DCT is negative. So what should be done?
DCT is not always positive in.
But it's therapy, further therapy will depend on that. So most of the time it is negative. So is it?
मैं जानता हूँ, बाकी सब जो बैठे हैं, उनमें से PG स्टूडेंट्स MD पैथोलॉजी कर रहे हैं, ब्लड बैंक में काम करने वाले, ब्लड सेंटर में काम करने वाले, ब्लड बैंक में काम करने वाले सिर्फ 2 ही लोग, आप भी ठीक है, तो यूजी स्टूडेंट्स, यूजी ओके, ठीक है, तो the topic given to me today is transfusion, recent advances in transfusion practice, and it's 11:35. We should finish it within 30 minutes. Yeah, so that should be better. अच्छा, right. तो हमारे उम्र के सब लोगों ने ये मूवी देखी, है ना? हाँ, अमोल अकबर हाँ, right? 1977, right? ये 3 लोगों का ब्लड उनकी माँ को जाता है और फिर पता चलता है कि उनकी माँ और एक साथ तो ऊपर कैसे जाता है मुझे पता नहीं चला.
That was the year when I got admission for MBBS. I completed my 12th as a student of first batch of 12th and I got entry into medical college.
तो यहाँ से हमारा ब्लड ट्रांसफ्यूजन शुरू हुआ था जो मनमोहन देसाई को समझा था और उसके बाद में हम लोग यहाँ पर आए हैं. सॉरी, हाँ, ये रिसेंट एडवांसेस है. यहाँ पर हम लोग ब्लड बैंक कहते हैं, है ना? अभी उसको ब्लड सेंटर, हमें पार्टियां बदल रहे हैं, तो ब्लड सेंटर हो गया. इसके आगे सेलुलर थेरेपीज होते हैं, राइट? क्योंकि कॉम्पोनेंट्स कर रहे हैं हम लोग, राइट? सीधे सीधे होल ब्लड को भी देता नहीं, क्योंकि उसका हम फ्रैक्शनेशन करते हैं. इसमें का जो 55% होता है पानी, ऑलमोस्ट 50%, एंड प्लेटलेट्स, ये सब अलग अलग जगह काम में आता है. ये इसकी यूजेस है, राइट? तो ये कहानी अगर हम शुरू करते हैं 1492 से, I'll not stop at every slide. I'll keep the slides if you want, right? तो ये इस तरीके से शुरू हुई है.
Country is not working the screen.
Yeah, it's not working. जेम्स बटलर, ये जो रिसेंट ट्रांसफ्यूजन दिया था एक ऑब्स्टेट्रिशियन, राइट, ये रिकॉर्डेड है। इसके बाद में आते हैं जिनकी हम जयंती मनाते हैं, कार्ल लैंडस्की, 1901 में उन्होंने ए, बी और ओ ये ब्लड ग्रुप जो अभी चल करके 35 ब्लड ग्रुप हो गए हैं मेन, और उसके सब ग्रुप्स आ गए। और 1902 में स्ट्रूली ने ए बी नाम का ब्लड, राइट। इसके बाद में कूम्स टेस्ट 1935-42, इसके बाद में 1952 में हमारे यहाँ बॉम्बे ब्लड, राइट, इंडिया में। और इस तरीके के इंडिया के लोगों का कॉन्ट्रीब्यूशन ब्लड ग्रुप में काफी, ये डायरेक्ट ट्रांसफ्यूजन है, डोनर और रेसिपिएंट, राइट। और ये है ब्लड की बैग, बहुत मॉडर्न है, एयर कंडीशन है, हवा आती जाती है, ठीक हो, राइट। इस तरीके से डोनर और पेशेंट्स नजदीक नजदीक आकर के ब्लड ट्रांसफ्यूजन दिया जाता है, राइट। हिंदी सब लोग समझते हैं। तो दिस इज सिंस 1926 से लेकर यहाँ तक हम आए हैं। भारत में जो बड़े बड़े नाम हैं, जॉली सर, गुप्ता सर, मालवंकर, रन्ना, और हमने जब से शुरू किया था तब सर भी जानते होंगे बोतल में ब्लड लिया गया, राइट। तो इसमें कभी कभी ब्लॉक होकर के अंदर जाता नहीं था वगैरह वगैरह, तो ये बोतलों से निकल करके प्लास्टिक में भले ही दुनिया में बहुत तबाही मचाई हो, ओशंस भरे पड़े हैं, पर ब्लड ट्रांसफ्यूजन में प्लास्टिक की वजह से बड़ा फायदा हुआ है। तो राइट, हमको प्लास्टिक बैग्स मिलते हैं। ब्लड कलेक्शन इन बैग्स यूएस गवर्नमेंट ने 16 में परमिशन दिया था, जबकि यहाँ हमारे यहाँ आते आते करीब करीब 88-92, राइट। ये प्लास्टिक बैग्स पहले बड़े महंगे हुआ, अभी धीरे धीरे वो अभी उसमें बहुत सारे सिस्टम्स आए, राइट। आपने कभी डोनेट किया है ब्लड? किसने ब्लड डोनेट किया? वेरी गुड, वेरी गुड। तो एक को एक बहुत सारे बैग अटैच होते हैं इंटरनली, ताकि इनके कंपोनेंट्स अंदर ही अंदर सेपरेट हो, ब्लड कभी भी बाहर के एटमॉस्फेरिक एयर से कांटेक्ट में नहीं आने देते, राइट। ताकि बाहर की हवा जो कंटेमिनेटेड होती है, एयर क्वालिटी इंडेक्स अपना अभी 190 के आसपास है, राइट। दिल्ली में 400 से ज्यादा है। ये सब बाहर की चीजें अंदर नहीं जाना है। जो हमारा एक क्लोज सिस्टम है, वेन्स के अंदर, आर्टरीज के अंदर जो ब्लड फ्लो हो रहा है, उसको एक 16 इंच की नीडल से टैप करके हम लोग ब्लड लेते हैं प्लास्टिक बैग में, उसमें 50-55% प्लाज्मा बगल बाजू करते हैं, वेटलेस बगल में बाजू भी करते हैं, इंटरनली स्पिन लेकर, राइट। सो टॉप एंड बॉटम सिस्टम्स भी है। ये एडवांस एज स्टोरेज सिस्टम्स, इससे आगे भी और अच्छे अच्छे फीचर्स आए हैं। ये हैं कुछ माइलस्टोन्स। पहले हम लोग अभी आराम से ब्लड ग्रुपिंग एंटीसिना वगैरह खरीद लेते हैं, बनाते हैं, पहले बनाने में भी मुश्किल था। वो एंटीजन हॉर्स में या रैबिट में डाल करके उस पर जो एंटीबॉडीज निकलते थे, अभी हमने कोविड में एक्सपीरियंस किया। क्या एक्सपीरियंस किया कोविड में? जिसको कोविड हो चुका है, कन्वालेसेंट फेज में, और जिसने एंटीबॉडीज बनाए हैं, उनका प्लाज्मा लेकर के हमने उनको दिया जिनको अभी कोविड हुआ, राइट, राइट। कन्वालेसेंट प्लाज्मा हमने ट्रांसफ्यूज किया, राइट। तो ये पहले से चलता आ रहा है, राइट। ये इन हाउस प्रिपरेशन हुआ करते थे रिएजेंट्स, अभी मोनोक्लोनल होते हैं, एब्रिडोमा टेक्निक, मोनोक्लोनल टेक्निक जानते हैं ना आप सब, राइट। तो ये यहाँ से लेकर अभी ब्लड ग्रुप एंटीजन्स, प्रणीता मैडम ने काफी इलैबोरेटली बताया होगा, लेकिन जैसा एबी को एक ब्लड ग्रुप सिस्टम है, वैसे 30-35 अलग ब्लड ग्रुप सिस्टम, ये सिर्फ नाम के लिए नहीं। एक मिनट इस पर इसलिए स्पेंड करना चाहूंगा कि रिसेंटली पिछले 2-3 महीनों में ऐसे केसेस आए हैं जिनके पास बहुत सारे आर्टिफिशियल यानी अनकॉमन एंटीजेंस हमने डिटेक्ट किए। वी डिड इट विद थैलेसीमिया पेशेंट्स में एलोइम्यूनाइजेशन बहुत होता है, राइट। हमको पता था कि कैपिटल सी, स्मॉल ई वगैरह में एलोइम्यूनाइजेशन होता है, पर यहाँ पर था डफी ए एंड ही हैज डेवलप्ड एंटीबॉडीज अगेंस्ट डफी बी, है ना। सो जो भी ट्रांसफ्यूजन दे रहे थे वो कॉम्पेटिबल नहीं हो रहा, तो उसके ब्लड ग्रुप का डफी ए नेगेटिव ब्लड उसको देना है, तभी उसको ट्रांसफ्यूजन विल बी इफिशिएंट इफेक्टिव, राइट। तो ऐसा ब्लड ग्रुपिंग किस करते हैं, पहले हम लोग स्लाइड मेथड पे करते थे, राइट। अभी भी मद्रास मेडिकल कॉलेज में मैंने देखा था, वहाँ पे फोटो निकाला था, एक छोटी सी सफेद टाइप पे एक बार एक की ब्लड ग्रुपिंग करते हैं, काफी अपनी जो ट्रेडिशन है वो प्रिजर्व करते हैं वहाँ पर, राइट। बट देन दे आर विद द लिमिटेशन, इस पे एग्जैक्ट ब्लड ग्रुप पता नहीं चलता, उतनी सीवियर उतना रिएक्शन रीड नहीं हो सकता है। न्यूअर टेक्निक जैसे कि मैडम ने बताया होगा, ये आए हैं जिसमें माइक्रोप्लेट ग्रुपिंग मेथड है, यानी प्लेट्स ऐसे आते हैं कि जिसके ऊपर एंटीजन्स कोटेड होते हैं। आपने उसका पेशेंट का ब्लड हम लोग किसमें देते हैं, प्लेन या सैचुरेटेड, ईडीटी वाले हाथ पर एक भी नहीं, ओके एक है, मतलब प्रैक्टिकली आप काम कर रहे हो। ईडीटी में ही देना चाहिए ब्लड, राइट, ईडीटी में दोगे ना, ठीक है, राइट, ठीक है। तो ईडीटी में हम लोग देते हैं और ये ब्लड ग्रुपिंग के कार्ड्स ए बी A1 A1 A2 भी होता है, राइट। सब ग्रुप्स पता है ना आपको, ए के सब ग्रुप्स है, बी के सब ग्रुप्स है ना। ये माइनर ग्रुपिंग्स भी है, एमएनएस के डब्ल्यू वगैरह वगैरह ऐसे कई, राइट। और ये माइक्रोप्लेट है, हम लोग मॉलिक्यूलर ग्रुपिंग पे गए, राइट। बहुत सारे डिस्प्यूटेड पैटर्निटी या कहीं से फॉरेंसिक इसमें मॉलिक्यूलर ग्रुपिंग, या हमारे यहाँ कोई रेयर ब्लड ग्रुप है जो कॉमन एंटीजन से उसके एब्सेंस या अनकॉमन एंटीजन का प्रेजेंस, रेयर ब्लड ग्रुप। आई रिपीट, एब्सेंस ऑफ कॉमन एंटीजन्स या प्रेजेंस ऑफ अनकॉमन एंटीजन्स, इट्स रेयर ब्लड। इसकी एक रजिस्ट्री की करते हैं, करना चाहिए, राइट। कि इनको अगर दूसरी बार ब्लड लगता है तो उसी तरीके का ब्लड उनको दिया जाए। अभी क्रॉस मैचिंग गवर्नमेंट स्टेट क्या करते हैं, हमने एक और मूवी में देखा, इस बार नाना पाटेकर साहब, ये हिंदू का खून या मुस्लिम का खून, पता किसका खून, राइट, देखा था ना, देख लेना कभी गूगल। तो इस तरह की क्रॉस मैचिंग हम लोग मेडिकल कॉलेज में करते थे जब शुरू था, इमीडिएट क्रॉस मैच ऑन द स्लाइड। अभी बहुत सारे एडवांसेस आ गए हैं इसमें, जैसे रेड सेल्स अलग करके, जैसे मेजर क्रॉस मैच हमने बताया है कि इसमें जिनको हम दे रहे हैं रेसिपिएंट, उसका मेजर पार्ट क्या है, लिक्विड पार्ट, तो इट इज उसका मेजर पार्ट से हम लोग क्रॉस मैच करते हैं। माइनर पार्ट जो दे रहे हैं मोस्टली हम लोग आरबीसी देते हैं, राइट। तो उसमें ब्लड ग्रुप एंटीजन्स उसके ऊपर होते हैं, एक एक ब्लड सेल्स के ऊपर करीब करीब 7 मिलियन से 10 मिलियन एंटीजेनिक साइट्स होते हैं। एक फुटबॉल ग्राउंड के ऊपर जितनी घास लगती है उतने एंटीजेनिक साइट की आरबीसी के ऊपर, दैट इज व्हाई दे प्रोड्यूस विजिबल एंड बड़ा रिएक्शन, अच्छा जो आंखों से दिखता है ऐसे रिएक्शन प्रोड्यूस करते हैं, राइट। दीज आर माइक्रोप्लेट। अब इसमें ऑटोमेशन बना है, राइट। सब पहले दाढ़ी बनानी पड़ती थी, अब बनती है ऑटोमेटिक, राइट। तो ऐसे ऑटोमेटिक बहुत सारी चीजें होती है, जिसकी वजह से पहले हम लोग ग्रुप देखने के लिए एक एक दो दो दिन लग जाते थे। ट्यूब के रैक्स में ए बी आर एच, फिर एंटी बी एंटी ओ, ऐसे सब देख करके लिखने में कल का फ्रिज में रखो, दूसरे दिन देखो, ऐसे होता था, मैन्युअली होता था। और अभी फटाफट बैच एनालाइजर से 100 ब्लड ग्रुप 1 घंटा भर में होता है, राइट। तो दिस ऑटोमेशन ये डिसएडवांटेज है। इसके अलग अलग है, जेट टेक्नोलॉजी में लो तो डायमंड है वगैरह वगैरह है। सॉलिड फेस टेक्नोलॉजी जिसमें ईएम टेक्नोलॉजी है, कोई यूज करता है, कोई कुछ अलग टेक्नोलॉजी यूज करता है, पर सेंसिटिविटी और उसकी स्पेसिफिसिटी मोर देन 99.99%। जैसे एबिलिटी और ये उसका टेस्ट करते हैं, स्पेसिफिसिटी कितने 1:250 हो में भी उसका रिएक्शन पॉजिटिव हम लोग करते हैं क्वालिटी कंट्रोल कंट्रोल रिएजेंट्स, राइट। सो दिस इज टीटीआई टेस्टिंग में क्या क्या हुआ है। HCV was not compulsory, अभी HCV कंपल्सरी, राइट। वैसे एक एक करके टीटीआई टेस्टिंग में एडवांसेस हो गए हैं, और उसमें अभी सर लेक्चर देने वाले हैं, उसमें बताएंगे कि अलग अलग जनरेशन के इलाइजास आए, एंजाइम लिंक इम्यूनोसॉर्बेट एसिड, फर्स्ट जनरेशन, सेकंड जनरेशन, थर्ड जनरेशन और फोर्थ जनरेशन, राइट? तो फोर्थ जनरेशन में क्या करते हैं, क्या टेस्ट करते हैं? एंटीजन एज वेल एज एंटीबॉडीज, राइट? फॉर एग्जांपल HIV का फोर्थ जनरेशन किट अवेलेबल है, नैको रिकमेंड करती है कि फोर्थ जनरेशन ही लीजिए। इसका मतलब HIV जो वायरस है उसके जितने भी G41, G20, G24 एंटीजन है उनको भी है कि नहीं है टेस्ट करेंगे, और इसका एंटीबॉडीज तो प्रोड्यूस नहीं हुए हैं ये टेस्ट करेंगे। बराबर है? यू आर विथ मी? आवाज आना चाहिए, रेस्पॉन्स जना रहे हैं आप लोग, नॉन रेस्पॉन्सिबिलिटी। तो यू नो द बेसिक कि कोई भी चीज जो हमारे शरीर से फॉरेन है, यानी हमारे शरीर से हमारे अपने, अगर इफ इट इज इंट्रोड्यूस इनटू योर बॉडी इट विल प्रोड्यूस एंटीबॉडी, राइट? थोड़े से एक ब्रीफ पीरियड के बाद फिर एंटीबॉडीज विल बी विजिबल, दे कैन बी यू नो काइंड ऑफ फाउंड इन योर ब्लड, कोई भी। इसी की वजह से हम लोग वैक्सीन देते हैं कि जो एटीन्यूएटेड है या किल्ड है, ताकि आप लोग उसमें एंटीबॉडीज, हम लोग एंटीबॉडीज प्रोड्यूस करें और वो ऑर्गेनिजम्स का, कोविड की वैक्सीन लिए है, जो वैक्सीन लेकर के हम लोग उसका प्रतिकार शक्ति, इम्यूनिटी बढ़ाएं, राइट? तो दीज आर ऑल द टीटीआई टेस्टिंग में एडवांसेस बहुत सारे हुए हैं, जैसे फोर्थ जनरेशन आया है, तो टीटीआई हम लोग, और एक केबिल्यूमिनेसेंस नाम का एक एनालाइजर आया है, उससे भी करते हैं। फिर नैट आया है, काफी दिनों से नैट है यहाँ पर, और इसके आगे पैथोजन रिडक्शन टेक्नोलॉजी आई, राइट? वी हैव अ स्लाइड, वी विल गो थ्रू इट। HbSAg में भी ऐसा है। HbSAg, how it is different from other TTI testing is, we are testing antigen, surface antigen. ब्लड कंपोनेंट्स में बहुत सारे, ये पहले पुराने मशीन्स थे, ऐसे कंपोनेंट्स या ऑपरेशंस हुआ करता था, बट अभी कंपोनेंट्स में बहुत सारे डेवलपमेंट हो गया है। इस तरीके के कंपोनेंट मशीन है हमारे पास, इस तरीके के सिस्टम्स है जिसमें हम लोग ये सेपरेट कर पाते हैं अच्छी तरीके से। प्लाज्मा में रेड सेल्स नहीं होने चाहिए, तो रेड सेल्स में प्लाज्मा ज्यादा नहीं, सो दिस इज एडल्ट्रेट। हमको जो चाहिए, इसीलिए ब्लड बैंक और ब्लड सेंटर आर गोइंग फ्रॉम ब्लड बैंक टू सेलुलर थेरेपीज, वी आर गिविंग सेलुलर कंपोनेंट्स व्हेनेवर इट इज रिक्वायर्ड, राइट? लेकिन एक चीज है, बहुत सारे मेहमानों के साथ अनचाहे मेहमान भी आते हैं, यानी जब नहीं चाहिए, these are leukocytes, right? So they are our defense mechanism. हर बार वो रूटीनली डोनर या रिसिपिएंट को वो जरूरी नहीं होते, देना नहीं चाहिए, उल्टा निकाल देने की जरूरत। यूएस में एक 86 से 90 तक जितने लोग रहे थे, वहाँ मैड काउ डिसीज हुआ था, तो उन लोगों को ब्लड लेते नहीं, क्योंकि मैड काउ डिसीज के लिए कोई टेस्ट नहीं करता, या वेरिएंट ऑफ CJD। ये जब ऐसे बहुत सारे ब्लडबोर्न पैथोजन है, टीटीआई में हम लोग टेस्ट करते हैं 5 पैथोजन, राइट? HIV1 and 2, HPV, SC, VDR, मलेरिया। इसके अलावा और बहुत सारे हैं, HTLV1, HTLV2, साइटोमेगालोवायरस, पारो वायरस वगैरह वगैरह वगैरह, जो ब्लड से जा सकते हैं। ये वायरस से, बैक्टीरिया की लिस्ट, राइट? पैथोजन ये प्रोटोजोआज है, राइट? जो एक के ब्लड से, यानी डोनर के ब्लड से इफ नॉट स्क्रीन प्रॉपर्ली, तो दूसरे रेसिपिएंट के ब्लड में जा सकते हैं। इसीलिए कहा है मैडम ने कि सबसे अच्छा ब्लड वही है जो फ्रिज में फ्रेम करके अच्छी तरीके से रखना है, राइट? सेफेस्ट वही है, राइट? तो दिस कंटामिनेटेड और कंटामिनेटिंग ल्यूकोसाइट, शायद और कुछ कंट्रीज में ड्राइव्स बनते हैं जिसमें फिल्टर नहीं लगे होते, कैनेडियन, ऑस्ट्रेलियन, यूके, यूएस, हर जगह पे सिर्फ इनलाइन फिल्टर्स वाली ड्राइव की यूज करते हैं, जिसमें से ल्यूकोसाइट्स फ्री स्टोरेज भी निकाल दिए जाते हैं। ये उसका फोटो है कि ये ल्यूकोसाइट जो है यहाँ दिख रहा है, वो उसके वायर्स में जाकर के स्टक हो जाते हैं। दे आर नॉट, जैसे हम लोग चाय पत्ती छानते हैं उस तरीके से ये ल्यूकोसाइट्स छानते हैं, राइट? GBSD अभी सबसे पहला पिक्चर हमने देखा था, उनके माता जी को GBSD नहीं हुआ, फर्स्ट डिग्री रिलेटिव का ब्लड, हाँ, क्योंकि बिकॉज ये ल्यूकोसाइट्स, ये दे शेयर कॉमन एंटीबॉडीज, राइट? anything which is introduced into your body is a foreign element, and the body tries to develop antibodies against it. 15 दिन 3 हफ्ते बाद में इसको पता चलता है कि यार ये ल्यूकोसाइट्स जो बाहर से आए हैं, चलो इनको भी मार देते हैं। तो वो मारने के चक्कर में उसी तरीके के अपने ल्यूकोसाइट्स भी मारना शुरू कर देता है बॉडी, एंड यू गेट TAGBS, राइट? इट्स ऑलमोस्ट 100% फेटल इन एनी अच्छे से अच्छे सेटअप में भी ये TAGBS। आई नो वन ऑफ आवर अकाउंट्स पर्सन जिसका बच्चा इसे है, राइट? तो इसके लिए माता जी को अपना खून या पिताजी को बच्चे का खून ऐसे नहीं देते, फर्स्ट डिग्री रिलेटिव अवॉइड कर सकते, या उसको हम लोग इरेडिकेट, राइट? बट देन सिर्फ फिल्टर नहीं किया, इरेडिकेट करना। जब इरेडिकेट करते हैं तो उसका न्यूक्लियस, उसका DNA वो पूरा डिस्टॉर्ट हो जाता है, so that it is not live and capable of producing an immunological response. Right? These are various kinds of irradiation. प्लाज्मा के बहुत सारे यूजेस है, और आजकल प्लाज्मा बहुत सारे लोग यूज करते नहीं है, फ्रैक्शनेशन को देते हैं ताकि ज्यादा पैसे मिलते हैं वहां से और पटाख से देते हैं। तो फ्रैक्शनेशन नहीं, ह्यूमन ब्लड है और ह्यूमन सोर्स ने डोनेट किया है, कुछ उसकी इच्छा होती है कि हम किसी के काम आए, तो वी आर अ मीडिएटर ब्लड सेंटर, सो दे शुड गिव फर्स्ट टू द एलिंग पेशेंट्स, राइट? ऑफरेसिस का मतलब है टू टेक अप, राइट? हमने देखा है हमारे होल ब्लड में रेड सेल्स है, प्लेटलेट्स है, ग्रैनुलोसाइट्स है, इनको बहते रहने दे सकते हैं एक एक्सियल फ्लो में, और एक ऑफरेसिस नाम की मशीन से हमें जो चाहिए वो हम लोग बाहर निकाल सकते हैं, राइट? कंटिन्यूअस फ्लो वाले ज्यादा मुंह से इसमें ब्लड घूम रहा है और उसकी स्पेसिफिक ग्रेविटी के हिसाब से सबसे हेवियर जो चीज है जो है रेड सेल्स, वो सबसे नीचे रहेंगे, उसके ऊपर रहेंगे व्हाइट ब्लड सेल्स, उसके ऊपर प्लेटलेट्स और उसके ऊपर प्लाज्मा। अब ये सब घूम रहे हो तो आप ऊपर से स्ट्रॉ डाल के जो चाहिए वो आप ले सकते, राइट? जैसे आपका जूस हो थोड़ी देर के लिए रख दिया तो ऊपर वाला क्या रहता है, पानी पानी रहता है, और नीचे फिर घुमा के ले सकते हैं ना। तो दिस इज कंटिन्यूअस फ्लो ऑफरेसिस मशीन, जिसपे हम जो चाहिए वो निकाल सकते हैं। इरिथ्रोसाइट्स निकाल लो तो इरिथ्रोसाइट ऑफरेसिस हो गया, ल्यूकोसाइट्स हुआ, प्लेटलेट्स निकालो तो प्लेटलेट ऑफरेसिस हुआ, सिर्फ प्लाज्मा निकालो तो प्लाज्मा ऑफरेसिस। इसमें अगर पेशेंट की यूज कर किया आपने, अगर ये डोनर का किया तो फेरेसिस हुआ, निकालिए। लेकिन कोई पेशेंट्स है जिसके अंदर बहुत सारे ल्यूकोसाइट्स है, कोई ALL है, AML, तो बहुत सारे ल्यूकोसाइट्स है, कीमोथेरेपी देने से या समझ लीजिए फैमिलियल हाइपरकोलेस्टेमिया या कोई फॉर्म एंटीजन एंटीबॉडी कॉम्प्लेक्सेस है जो आपको निकाल सकते हैं, तो वो थेराप्यूटिक ऑफरेसिस भी कर सकते हैं। हमारे यहाँ फैसिलिटीज अवेलेबल है औरंगाबाद। GBS जो है उसके अंदर ये बहुत इफेक्टिव, हम लोग IVIG देने से सस्ता और इफेक्टिव ट्रीटमेंट है। ये करते करते आदमी की जो ग्रुपिंग आइलिड्स होते हैं वो ठीक हो जाते हैं, ऐसे पेशेंट्स ठीक होते हैं। सो ये सब एडवांसेस हमारे ब्लड सेंटर से थे, सेलुलर थेरेपी, एंड नाउ हम लोग क्लिनिकल साइड में भी जा सकते हैं, वहाँ जाकर के पेशेंट ठीक कर सकते हैं। मेदांता वगैरह जैसे अपने हॉस्पिटल से या जहाँ की मेडिकल की ब्लड सेंटर से, यहाँ पर पेशेंट की एक अलग लाइन लगी हुई है, वो उनका थेराप्यूटिक ऑफरेसिस कर रहे हैं, प्लेटलेट ऑफरेसिस कर रहे हैं। ऑन्कोलॉजी जहाँ ज़्यादा वहाँ पे प्लेटलेट्स बहुत जल्दी ज़्यादा लगते हैं, राइट? तो प्लेटलेट ऑफरेसिस एक अलग तरीके से चलता होता है और पेशेंट का ऑफरेसिस भी अलग। तो ऑफरेसिस प्रोसीजर इन कॉम्पोनेंट यूज, राइट? अभी हम लोग ऑपरेशन थिएटर में जाते हैं, तो रेड सेल साल्वेज कैसा कर सकते हैं, तो उसकी कुछ मशीन जो ब्लड जा रहा है ऑपरेशन में वो हम लोग बाहर निकाल करके उसको सेंट्रीफ्यूज करके ठीक से धो के उसे सेल डिब्रीज वगैरह बाजू में करके ये मशीन वापिस उसको दे सकते, राइट? रिड्यूस, रिसाइकल, रीयूज, यहाँ भी वो काम कर रहा है। सो दिस इज ब्लड बैंक, कुछ दिनों तक चलेगी, उसके बाद में फार्मेसी स्टोर पे ब्लड मिल जाएगा, ऐसा लगता है, बिकॉज ब्लड इज कवर्ड अंडर ड्रग्स एंड कॉस्मेटिक एक्ट, राइट? So pharmacist is the best person टू डिस्पेंस, ठीक है। जब तक हम लोग अपना दिमाग लगाते रहेंगे, नया नया करते रहेंगे, तभी एम्प्लॉयड रहेंगे, राइट। तो ट्रांसफ्यूजन मेडिसिन इज समथिंग विच इज अ हाइब्रिड ऑफ लैबोरेटरी एंड क्लिनिकल प्रैक्टिस, जो हमने अभी देखा थेराप्यूटिक, राइट। तो एडमिनिस्ट्रेटिव रोल्स इंक्लूसिव ऑफ रेगुलेशन, कॉस्ट, राइट। पहली बार रिजर्व करने के लिए या इसके लिए ब्लड ट्यूब में आ गया सैंपल, तो हमने क्रॉस मैच करके रख दिया, लेकिन जब इशू आता है तब और उसको सैंपल लेके आना है, राइट। तो उसका भी ब्लड ग्रुप करते हैं, इफ इट मैचेस देन द प्रीवियस क्रॉस मैच बैग इज गिवन, अदरवाइज फिर से काम। तो रॉन्ग ब्लड ट्यूब, राइट, मिस लेबलिंग वगैरह वगैरह जो इश्यूज है, यानी ब्लड बैंक से ज्यादा क्लरिकल एरर्स की वजह से लोग मर गए। So there is a list of these things which are grouped serious hazards of transfusion. उसकी लिस्ट होती है, तो उसमें क्लरिकल एरर्स की वजह से, मिस आइडेंटिफिकेशन ऑफ पेशेंट की वजह से बहुत सारे पेशेंट्स की जान जाती है, एक का दूसरे को जाता है। तो इसको हम लोग ओवरकम करने के लिए पेशेंट को रिस्क ट्रायल्स भी देते हैं, राइट। एक ने तो ऐसा किया कि वो बैग जो है वो वहां से सील करके भेज देंगे, वो डिजिटल लॉक करके, और जब तक वो पेशेंट का बारकोड स्कैन करके और इसका बारकोड स्कैन करके मैच नहीं होगा तो उसका ढक्कन ही नहीं खुलेगा। गुड थिंग ना। सो सॉफ्टवेयर के एडवांसेस की है इससे ब्लड बैंकिंग में बहुत सारे अच्छी चीजें। सो WHO ने भी काफी रिकमेंडेशन दी है, उसके हिसाब से ये स्लाइड मिली है हमको। 1901 से पहले जैसे हमने देखा कि अच्छा कोई आदमी दिख रहा है, उसका ब्लड लेके दे दिया, उसके बाद में एबीओ ब्लड ग्रुपिंग ने बताया, तो एबीओ ग्रुपिंग करने लगे। उसके बाद में इम्यूनोमेटोलॉजी आ गया, तो RH पॉजिटिव नेगेटिव, कुछ दिनों बाद वो समझ के जिनको दिया करते थे निकले कुछ बॉम्बे ब्लड ग्रुप वाले, राइट। तो ऐसे पता चला। फिर किसी के इन्फेक्शियस मार्कर्स, वो लोग पहले एंटीबॉडीज टेस्ट करते थे, HIV के एंटीबॉडीज फॉर्म होते होते 45 दिन लग जाते थे, 1.5 महीना लग जाता है। HCV की तो और 2 बार एंटीबॉडीज फॉर्म। अगर इस दौरान वो आदमी डोनेट करता है, तो फिलहाल मैट नाम की कोई टेक्नोलॉजी है जिसमें हम लोग डायरेक्ट वायरस टेस्ट, PCR नाम की एक टेक्निक आई 1960, इसका हमने बहुत बड़ा यूज किया है कोविड में, राइट। रियल टाइम PCR, गिव मी DNA सीक्वेंस एंड आई विल क्या बोलते हैं उसको, proliferate it billion times, give me a DNA sequence in the morning and I will proliferate billion times by the afternoon, ऐसा बोलते हैं जन बोला, राइट। तो यहाँ इसकी टेक्नोलॉजी के बहुत सारे इम्प्लीकेशंस और उसका फायदा हम लोग ले रहे हैं। तो ये मॉलिक्यूलर टेक्निक्स आ गए हैं PCR टेक्नोलॉजी वाले, और पैथोजन रिडक्शन, कुछ अल्ट्रावायलेट लाइट से या कुछ B6 रेबोफ्लाविन या मिथिलीन ब्लू, इनके सॉल्यूशन वो कमर्शियली अवेलेबल है, जिसकी वजह से हम लोग पैथोजन्स को मार सकते हैं if at all there are, right? So this is all about the advances that we have made. जैसे मैं बताया कि सेल एसोसिएटेड वायरसेस है, जैसे साइटोमेगालो वगैरह वगैरह, ये वायरसेस दैट कैन बी ट्रांसमिटेड बाय, लेकिन बैक्टीरियल कंटैमिनेशन का रेट, इसीलिए उसको गोल गोल घुमाना है ना, पहले बीटाडिन से फिर स्पिरिट से, ताकि उसके ऊपर का जो बैक्टीरिया से, एंड ब्लड इज अ वेरी गुड मीडियम फॉर ग्रोथ ऑफ एनी बैक्टीरिया, तो उसको पहले ठीक तरीके से कलेक्ट करना है। और आजकल जो ब्लड कलेक्शन मॉनिटर है वो पहले से पिंच हुआ वाला है, ताकि उसकी हवा भी अंदर नहीं जाए, राइट। वंस यू एंटर द वेन और आपको लगता है तो देन यू प्रेस एंटर, तो अंदर जाएगा, राइट। तो इस तरीके से ये सब एडवांसेस हुए हैं। केमिल्यूमिनेसेंस एक अच्छी स्टेबल रिएक्शन है, इलाइजा से ज़्यादा अच्छी है। उसमें वेरियस एंटीजेंस दैट कैन हाई सेंसिटिविटी है, वाइडर लीनियर रेंज है और स्टेबल है। इलाइजा इज एन फ्लैश रिएक्शन, मेरा केमिल्यूमिनेसेंस का जो लाइट है, ग्लो है, दैट कैन बी मेजर्ड फॉर सम पीरियड ऑफ टाइम, दैट रिमेंस स्टेबल, राइट। तो ये बैक्टीरिया एक बहुत बड़ा है। अगर कोई बैक्टीरियल कंटामिनेटेड ब्लड किसी को दे दो तो रिसिपिएंट सेप्टिक शॉक से मर सकता है। सो यू हैव टू वेरी केयरफुल अबाउट दिस सेप्टिसीमिया। और ये कल्चर कर सकते हैं, 1% कल्चर करना कंपलसरी है हमारे लिए, राइट। ये इनिशियल 5 ml में ही बैक्टीरिया ज़्यादा होते हैं ऐसा पता चलने की वजह से एक डाइवर्शन पाउच दिया होता है उस बैच पे, जिसमें इनिशियल ब्लड उसमें जाता है और बाद में आप लैब कर दो तो बाकी है, और जो इनिशियल ब्लड है वो भी वेस्ट नहीं हो सकता है, आप टेस्टिंग के लिए ले सकते हैं, राइट। सो प्रोटोजोआस, मलेरिया, चागास डिसीज, ट्रांसमिटेड, राइट, प्रायॉन्स भी है, राइट। तो ये हमारा ब्लड सेफ्टी का जो प्रोग्राम है भारत में, वो नेशनल एड्स कंट्रोल प्रोग्राम के अंतर्गत 3 ये किया है, तो 2012 तक इसके अंतर्गत कुछ ब्लड बैंक्स को उनमें एनरोल करके उनको गवर्नमेंट मदद भी करती है बैग वगैरह। सबसे बड़ी बात है हमारे पास हर साल एक न्यूज आती है, रक्ताची कमतरता, शहरा मध्य रक्ताचा को तोड़ा। हमारे कुछ लोगों में बहुत सारे दोस्त हैं, दे देते हैं बेचारे बाद में। तो ये जो है ओवरकम द शॉर्टेजेस, जैसे दिवाली के आसपास है, मई के आसपास है, तो उनको ब्लड बहुत शॉर्ट मिलता है, क्योंकि हमारे पास 2-3 MIDC है, फिर भी कहीं पे भी ब्लड बनता है नहीं, क्षेत्र में नहीं बनता। तो ह्यूमन सोर्स ही है, तो ह्यूमन सोर्स के लिए हम लोग ज़्यादा से ज़्यादा उनको मोटिवेट करेंगे, उनका भरोसा जीतेंगे और भरोसा कायम रखेंगे, तो हमको ये सोर्स से ब्लड मिलता है, राइट। इसके स्टोरेज में पहले 30-32 दिन स्टोर किया करते थे, उसका अंदर सोल्यूशन जो था वो CPD के बाद CPD A, A1, A2 करके अभी लोग ऑलमोस्ट 42 डेज रेड सेल्स हम लोग रख सकते हैं 220 डिग्री सेल्सियस पे। और अगर फ्रोजन हो रेड सेल्स निकालने के बाद फ्रीज करके रखा, जैसे रेयर ब्लड ग्रुप्स, तो दैट कैन बी स्टोर्ड फॉर इयर्स आल्सो, राइट। सो दिस इज वेन टू वेन। हमारा जो इनपुट है वही आउटपुट, सिर्फ उसके कंपोनेंट सेपरेट किए अलग अलग। तो जितना अच्छा इनपुट रहेगा, रॉ मटेरियल जितना अच्छा रहेगा, उतना फिनिश प्रोडक्ट्स हमारा अच्छे रहेंगे, राइट। तो इसमें अलग अलग जगहों पे अलग अलग मॉनिटरिंग सिस्टम्स है। क्वालिटी एक आया है सिस्टम, जिसकी वजह से आप हमारी ब्लड बैंक को एग्रीगेट कर सकते हैं, एनालाइज कर सकते हैं। इसके 5-10 चैप्टर्स है, उसमें हर एक चीज़ को माइन्यूटली उसके इंडिकेटर्स के साथ दिया है ना। हर एक को ऐसा लगता है कि मैं तो अच्छा ही लिख रहा हूँ, लेकिन सामने वालों को पता होता है कि जो चाय पी है उसका रिजल्ट, राइट। तो थर्ड पार्टी असेसमेंट करके हम लोग ऑडिट करते हैं, कंफर्मेंस देखते हैं, जो स्टैंडर्ड्स लेट डाउन है कि उसके हिसाब से आपकी ब्लड बैंक, आपकी गतिविधियां ठीक चल रही है या नहीं, और सर्टिफिकेट, राइट। अगर आपकी सर्विस बेटर हो तो ज़्यादा डिमांड होंगे, हायर प्राइस रहेगा आपका, एंड रेपुटेशन बढ़ेगा और बेटर पेशेंट ट्रीटमेंट हो। और अगर ना हो तो ये सब चीज़ें, राइट। सो एरर्स क्या क्या हो सकते हैं, जैसा ब्रीफली हमने बात किया, सैंपल कलेक्शन में, आइडेंटिफिकेशन में, रिव्यू ब्लड ग्रुपिंग में जो एरर्स नहीं होंगे, मैडम ने काफी एलेबोरेट किया है। इंफॉर्मेशन टेक्नोलॉजी, हर एक चीज एक कंप्यूटर है, आपका मोबाइल कंप्यूटर है, आपका सिस्टम एक कंप्यूटर है, तो उनकी ऊपर हमारी डिपेंडेंसी दिन प्रतिदिन बढ़ती जा रही है। अगर आपका नेट न हो तो आपका सॉफ्टवेयर नहीं चलेगा, क्योंकि क्लाउड बेस्ड है, राइट। तो इसकी जो लिमिटेशंस है या डाटा सिक्योरिटी है, these are going to be the important problems or important stress or points which you can look into in the future. ये एडवांसेस अगर एक स्लाइड में रखना चाहो तो ये स्लाइड ज़्यादा अच्छी है। टेस्टिंग मेथड्स, मॉडिफाइड कंपोनेंट्स, थेरेप्यूटिक यूजेस एंड ब्लड सब्स्टिट्यूट्स, ये सब चीज़ें हम लोग, ये स्लाइड हम यहीं रखे जा रहे हैं, आपके कंप्यूटर में आप बाद में ले सकते हैं। सर आपका नाम जो मांगता है उनको दे दीजिए, मेरा कोई अधिकार नहीं, राइट। ये इनएक्टिवेशन ऑफ पैथोजेंस जो है, ये इसके कुछ मेथड्स हैं जैसे हमने बताया, राइट। हीट ट्रीटमेंट, सॉल्वेंट, नैनो फिल्ट्रेशन, सोलरेंट वगैरह वगैरह। ये इस तरीके से जो ये DNA लाइव है बिफोर एलिमिनेशन, ये इस तरीके से हो जाएगा। ये इसका आगे के जो एडवांसेस है वो होंगे 2 फील्ड में, ट्रांसफ्यूजन इम्यूनोलॉजी which deals with manipulation और प्रोडक्शन ऑफ स्टेम सेल्स। इस स्टेम सेल्स क्या है ये तो स्लाइड्स पे देखेंगे, और ट्रांसफ्यूजन ऑन्कोलॉजी, राइट। ये हमने सब हेरिडिटरी डिसीजेस में, थैलेसीमिया में हम लोग काम कर रहे हैं काफी दिनों से, जो प्रिवेंट किया जा सकता है। आपके यहाँ काफी थैलेसीमिया के पेशेंट्स आते होंगे ब्लड लेने के लिए, हर 20 दिनों में आना पड़ता है बेचारों को, तो उनको हम लोग फ्री ब्लड देते हैं, हमने लिख के लगाया सामने। काफ़ी पेशेंट्स को फ्री देते हैं। सिकल से थैलेसीमिया हेमोफीलिया नहीं होना, इसके लिए हम लोग काम कर रहे हैं। 15 मिनट में उसका HB इलेक्ट्रोफोरेसिस करके देते हैं ताकि A2 फ्रैक्शन 3.5 से ज़्यादा हो। तो ऐसे बहुत सारे लोगों को डायग्नोस किया है। रिसेंटली हमारे कैंट में कैंप हुआ, तो वहाँ के जो CEO थे वो खुद थैलेसीमिया माइनर थे, पता नहीं होता है। मर्चेंट हमारे यहाँ आए थे, तो उन्होंने फर्स्ट बोन मैरो ट्रांसप्लांट स्पॉन्सर किया। उनकी कहानी है, वो सवेरे सवेरे एक दिन उनको फोन आता है लंदन से, बेटी जो डिलीवर होने वाली है उसका, बोलते डैड डू यू नो योर थैलेसीमिया माइनर। ऐसे कैसे गया सर? डैड यू हैव बीन लेक्चरिंग थ्रू आउट योर लाइफ अबाउट थैलेसीमिया, लेकिन मुझे तो सब मालूम है थैलेसीमिया बड़ा भी है, बट दैट इज नॉट, मालूम है तो नहीं होगा ऐसा, राइट? थैलेसीमिया बड़ा भी है, बट दैट इज नॉट, मालूम है तो नहीं होगा ऐसा, राइट? So you have to test and that has to be done only once in your life. एक साल के बाद कोई भी आदमी अपना स्टेटस जान ले सकता है। हमने एक कॉलोनी में टेस्ट किया है, एलिजिबल 15 साल से लेकर 45 साल तक के लोगों में 22%। हमारे सर ने भी किया था एक स्टडी 2017 में बिंदुसरा, हाँ, तो त्यावेळेस 17 to 18% ऑफ दैट कम्युनिटी वाज पॉजिटिव फॉर थैलेसीमिया माइनर। 17 to 18 यानी 4 में 1, क्योंकि हमने एक ग्रुप थोड़ा छोटा लिया है जो एलिजिबल है, जिनकी शादी हो सकती है और इनके बच्चे थैलेसीमिया मेजर हो सकते हैं, एंड दैट इज अ प्रिवेंटेबल डिसीज। दुनिया में बहुत सारे कंट्रीज ऐसे हैं जहाँ पे लॉ बन गया है, नए थैलेसीमिया पैदा नहीं होते। हमारे यहाँ 12,000 ऑफिशियल, अनऑफिशियल कितने होते होंगे अपना अपना गिनते हैं, कितने पैदा होते। हमने पिछले 2-2.5 सालों में 19 नए थैलेसीमिया देखे, जो 3 महीने 6 महीने 8 महीने के ब्लड लेने आते हैं, जिंदगी भर के लिए ब्लड लेना पड़ता है, लेकिन वो प्रिवेंट कर सकते हैं। ऐसे ही जो पेरेंट्स हैं उनको एजुकेट करने के बाद हमने 45 अबॉर्शन किए जो थैलेसीमिया मेजर पैदा हो सकते थे, वो नहीं होने दिए, और उनके दूसरे बच्चे अच्छे हैं, राइट? उनकी कहानी बड़ी अलग है, अजब है, प्रिवेंट कर सकते हैं। सऊदी अरेबिया, लखनऊ में हमने जब ये पिछला लेक्चर किया तो वहाँ पे खाने के तो बोले मैं सऊदी अरेबिया में गवर्नमेंट के लिए काम करता हूँ, हमारे यहाँ एक प्रोटोकॉल है कि 3-4 महीने जिसको शादी करना होता है वो एप्लीकेशन देता है, गवर्नमेंट से उसकी टेस्ट होगी आपके लिए, अगर दोनों थैलेसीमिया माइनर हो तो हम शादी नहीं करते, ये लोग अलाउ होता है। 15% ग्रीस में पॉपुलेशन थैलेसीमिया है माइनर, लेकिन वहाँ पे नए थैलेसीमिया पैदा बिकॉज ऑफ लेजिस्लेशन, तो हम भी कर सकते हैं। सो दिस कैन बी प्रिवेंटेड। मोनोक्लोनल एंटीबॉडीज और एजेंट्स काफी स्पेसिफिक होते हैं, ये हमने देखा है। ब्लड देने का सब्स्टिट्यूट यानी इरिथ्रोपोइटिन, TPO, ये सब देख करके हम लोग अवॉइड कर सकते हैं, मतलब अवॉइड कर सकते हैं, जिसके साथ हीमोग्लोबिन है, ब्लड देना जरूरी है, लेकिन उसका घूमना फिरने की ज़्यादा ये नहीं है, एक्यूट नहीं है, क्रॉनिक है, डिफिशियंसी एनीमिया से। तो इंस्टेड ऑफ गिविंग ब्लड वी कैन रिसोर्ट टू फार्माकोलॉजिकल कंपाउंड्स। ये एडवांसेस हो सकते हैं, जिसको कहते हैं यूनिवर्सल डोनर, जैसे सर ने कहा वो नेगेटिव यानी डीन साहब ने कहा कि यूनिवर्सल हम समझते थे, तो यूनिवर्सल नहीं है वो, बॉम्बे ब्लड ग्रुप को नहीं रखते, इट टू सेल्स। तो ये ऐसे कुछ सेल्स बन सकते हैं जो यूनिवर्सल सेल्स हैं, राइट, जिनके ऊपर कोई एंटीजेंस। सो creating O negative blood from spare embryonic stem cells could help do away with the shortage, right? तो ब्लड सब्स्टिट्यूट से जिसके ऊपर काफी दिनों से काम चल रहा है, तो रियलिटी में आ जाएगा। ब्लड बैंक को सेल बैंक हमने देखा है। सो आगे की ब्लड सेंटर्स शायद ऐसी हो सकती है, मॉडर्न और सेलुलर थेरेपीज वाली, और स्टेम सेल्स वहाँ पर हम लोग हर जगह पे टेंडन्स के इससे लेकर जोड़ों में बाल बढ़ने के लिए वगैरह वगैरह हर जगह हम लोग यूज कर रहे हैं ना, प्लाज्मा स्टेम सेल्स वगैरह वगैरह। तो कोई थेरेपी, कोई स्टेम सेल्स की वजह से, यानी हम लोग बहुत सारे लोग उनके फोन आते हैं, अरे यार हमारे फैमिली में है, हम लोग इसके स्टेम सेल्स प्रिजर्व, जिनमें हम लोग स्टेम सेल्स यूज कर सके, राइट? टू विल बी एम्प्लॉयड इन स्टेम्स, राइट? सो टू एस्टैब्लिश नेशनल लेवल कॉर्ड फॉर ब्लड बैंक्स, राइट? तो सिर्फ ब्लड बैंक में कॉर्ड बैंकिंग भी कर सकते हैं, सेलुलर रेसिडुअल डिसीज को ठीक करने में वायरस स्पेसिफिक कोई CME हमारे यहाँ पे क्यूटेनियस T-सेल लिम्फोमा के लिए हमने देखा है कि उसके T-सेल्स को लेकर के ऑपरेसिस में अल्ट्रावायलेट रेज लेकर के दे आर रीट्रांसफ्यूज सो दैट वो T-सेल लिम्फोमा क्योर हो सकता है। इस तरीके से भी ब्लड सेंटर्स कैन बी ऑफ यूजफुल। जीन थेरेपी जो कि ऐसे लगा था कि डिस्टेंट ड्रीम है और इट्स रियलिटी अभी काम कर रही है। एक वायरस के थ्रू वो जीन थेरेपी कर रहे हैं, अमेरिका में ट्रायल्स अभी जारी है, जो शायद एक अच्छा क्योर हो जाएगा थैलेसीमिया और अदर डिसऑर्डर्स के लिए, राइट। सो ये एंटीबॉडी थेरेपीज है। सो साइंस हैज गॉट लिमिटलेस पॉसिबिलिटीज। फ्यूचर यूनिवर्सल कंपोनेंट वगैरह वगैरह ये सब चीजें आई थिंक I'll stop here with ISBT 128 बाउंड्रीलेस ब्लड यानी इसके ऊपर सभी चीजें हैं जो आपको चाहिए कि कहाँ से निकाला है, किसका है, कौन से टेस्टिंग किया है। इस तरीके से बारकोड रीड करने से आपको पता चल जाएगा और ये यहाँ से वहाँ हम लोग रोज हमारा स्टॉक अपडेट करते हैं कि महाराष्ट्र में, औरंगाबाद में, इस ब्लड बैंक में इतने ब्लड। तो अगर कोई कैलामिटी आती है, डिजास्टर होता है, मैन मेड, ह्यूमन, वायरल, जो भी हो, तो यहाँ से हम लोग कॉम्पोनेंट्स उठा करके और जहाँ जरूरत है वहाँ दे सकते हैं, राइट। सो दिस वुड बी द फ्यूचर। आई थिंक आई ट्राई टू गिव जस्टिस। अगर आपको कुछ प्रश्न हो तो अभी या ऐसा होता है वैसा करेंगे। थैंक यू।
Thank you, Mahendra, for those simplified words. I have one question. That is there any change in blood transfusion practices after COVID?
I would try to answer it, but there are things you can add to it. Except for the convalescent phase, there is not much of a change after COVID. If you are specifically referring to something like, you want some specific?
One thing was during COVID,
Yeah.
there was very much deficiency of the blood.
Yeah.
Okay, so there was scarcity. So was there some changes in donor selection, and are those changes continued?
Would you like to answer? That's the only thing.
As far as scientific things are concerned, one question has been added, as I would say. But definitely donor motivation level has gone down. Because that was the period when social media was very influential. आणि त्याच्यामुळे काय झालं की लोकांना कळालं, कन्व्हॅलेसेंट प्लाझ्मा थेरपीमुळे लोकांना कळालं की आपण पण काहीतरी मदत करू शकतो. त्याचे मोटिवेशन आहे ते डोनर्समध्ये वाढलं, तर अवेअरनेस वाढला, आणि स्पेशली यंग पॉप्युलेशन आणि सायंटिफिक नॉलेज जे आहे त्याच्याला इंटरेस्ट जो आहे तो पण वाढला. सो मोटिवेशन डेफिनेटली हॅज अफेक्टेड आफ्टर कोविड अँड दॅट इज अ गुड थिंग, पॉझिटिव्ह साईड फॉर इट.
And one thing is single donor platelet donation is also increased because of plasma donation.
I will add to this scenario. I was the nodal officer for plasma crisis in COVID for Marathwada region. I think motivation has led to such a concept that everybody demanded that post-COVID plasma. And since I am a student of pathology, I know immunohematology. Okay, so everybody knows that because this plasma contains antibodies, isn't it? These antibodies have their own shelf life, their own titer in the convalescent period. And how far they are effective in very critical phases, I don't know, but there are many criticisms regarding this COVID plasma therapy. And to me, it appears that previously also this was going only the animal product was used, like in snake bite or rodent bite, and this is a human product. So everybody pointed that I should get a COVID conversion. So that was the biggest sort of chaos going on because of your excess motivation. Thank you.
Because plasma therapy was so much in that time, and therefore, because of compulsion, you can say, blood banks have started apheresis, and after that, convalescent plasma has been taken off by FDA, but SDB at least people are providing, so that is a good point.
Actually, this plasma drive, I think, was similar to just injecting remdesivir.
Yes, it was useless.
Because we understand that plasma itself has got so many properties.
Government always believes that this is useful. Some clinicians come up with the political power and they decide for us which goes on heavily in the Maharashtra and people are suffering.
No, but positive aspect as she has narrated, the population became aware of plasma apheresis. And therefore, I think that SDP and therapeutic aspects have increased now. That's the positive outcome. Always there may not be only negative aspects.
First 48 hours are important. Have you noted any COVID period for that?
So you will go on.
Thank you.
मुझे ऐसा लगता है बाबा जी के पास एक मैडम लगी है, उनकी हमारे पति काफी झगड़ा करते हैं और उनके लिए कुछ दवा दी बाबा जी कुछ देते हैं मुझे मुझे दवाते चबाते हैं निकल
आता भूक लागली
बस पता नहीं हुआ तो आती है वाह संभाल ये आपने दिया क्या आपका मुंह बंद रहेगा तो
There is one thing, if again there is an epidemic or pandemic, if such thing happens, then is there any way that some stringent criteria for donation can be developed?
Because these antibodies they are specific to react with the antigens from which they are produced. So this is a rational. It was a known fact की जनरल एका ह्याच्यामध्ये डेव्हलप आणि किंवा त्याच्यामध्ये सर्वायवर्स असतात त्यांचं ब्लड आपण दिलं त्यांना तर दॅट प्रूव्ह दॅट इट डिपेंड्स ऑन हाऊ मच दे लास्ट फॉर हाऊ मच डोज
There are strict criteria for donors.
Can you dilute
them in an epidemic or pandemic? So that you get adequate number of donations.
There is one more talk before lunch, so you decide.
Patil sir as chairperson. Dr. Bhavesh sir is professor and HOD in Biochemistry of our institute. He is teaching biochemistry since 1989, professor since 2001. He has many papers presented at the national conference. Dr. Patil sir is professor in our department. He earlier worked in Pondicherry Medical College and Sri Aurobindo Institute of Medical Sciences, Indore. His areas of special interest are quality control in hematology and coagulation and transplant. I welcome you both, sir. Our speaker for the next section is respected Dr. Umesh sir. He will be speaking on pediatric blood transfusion. I request the chairperson to kindly introduce the speaker.
Dr. Ume is a HOD in pediatrics in our college. He is a very well-read person, very efficient, very active in his treatments. Not only he is a good friend, so this is out of experience which we get while traveling from Aurangabad to college. Yeah. Invite him to present his topic.
Thank you, Bhavesh sir. Thank you, Patil sir. Thank you. So my talk will be practical-based, clinical-based scenarios. Okay. So I want all these to be more interactive in this. So before that, even if everyone does HPLC and thalassemia minor test, so purpose of this CME will be solved. You know, as discussed, so 15% of the population in India overall and high community 25% of they carry thalassemia minor gene. And nobody can recognize. Like, do you know Abhishek Bachchan is thalassemia minor? Do you know Amitabh Bachchan is also thalassemia minor? Okay, so nobody can read your case and your PS and reticulocyte won't tell you you are minor. You need to do HPLC. Okay, so first take home message is like get HPLC of each and every one individual done at earliest. Okay, so blood transfusion medicines have long way. Like you must have seen in Hindi movie Amitabh and Shashi Kapoor giving, they are sitting side to side and giving blood directly to their mother. Okay, so in these movies this doesn't happen in real life. Somewhere, blood transfusion is considered as an organ transplant. Okay, so we use very judicially whenever required. It's not randomly you are collecting and give. क्या लग रहा है? थोड़ा weakness है, जब blood does not like. So indication are very specific. Okay, so I will take you to one clinical scenario. I would like that PGs to answer this. So 3-year-old child presented to pediatric OPD, irritability, not doing well, looking pale. His weight is 12 kg, means he is growing well for his age in percentiles. So GC is moderate after heart rate 92, 24. He is pale, severe, looking pale. So that is a cross finding, no sinus. So there is no serious involvement. When I examine this child, liver spleen are not palpable. 3-year-old child, air entry clear, symptom immunosuppression, and CBC report of 3.4 gram. How to approach this case? What you should do? So first of all, immediately admit this child. There is no fever, there is no infection. So admit. What else you will do after admission? So child presenting for the first time. क्या करना है इसको? So urgently do CBC, blood grouping, cross matching, okay, and see the peripheral reticulocyte and HPLC. These are the basic report I need immediately, okay? Because what happens, you know, the child may go in a congestive cardiac failure. So once the baby goes in a complication, it's very difficult to recover the child, okay? So remember one thing: the child presenting for the first time, sample should be collected before starting the therapy, okay? So this is the child who can give me some time to act, okay? So this is semi-emergency, I can say. So next is Another case, different clinical scenario. So 4-year-old presenting with breathing difficulty, breathlessness, fever cough since 3 days, pela, irritability, late weaning, only meal. We get a kid, 3-year-old child, he is totally on meal, कुछ भी नहीं खाया अभी तक. So this is late weaning is a common practice. Weight is 7 kg, so he is having malnutrition. So GC moderate afebrile, heart rate 142, RR 62, severely pale, IIMSR edema is present. So how does management and treatment differ between those two cases? Okay, so any comments? Is so this child needs emergency care. That's why my residents are always behind pathology people. Urgent report I need, urgent blood grouping I need, urgent cross-matching and urgent transfusion. Because if I don't manage this case urgently, he may land into complication. So this is a preventable complication. So he has severe anemia, congestive cardiac failure, respiratory infection, added he may be nephrotic. Okay, so this is a medical emergency. I would be happy to transfuse him within a 30 to 60 minutes, preferably as far as possible. So this is a dire emergency. Okay, so another child, he may give me a day or so, but this child, if I don't manage within an hour, so it's a preventable complication and nobody will be able to justify this fee. Okay, so as discussed, so many things are already being covered, so I will only try to focus which points are not being covered. It's integral, it's a component of pediatric therapy. At all ages, infant and older children, they need a transfusion, and one need to remember there is a specific physiological requirement. Okay. So what are the normal hematological parameters? So pediatric is not half and 1/4 of the adult; it's always per kg, milligram per kg, gram per kg, ml per kg, and so on. Okay. So this is the age child; they are more sensitive. If you see hemoglobin level, okay. So birth, newborn, 6 months, 1 year. See, all parameters are different. So they are more polycythemic. Their hemoglobin concentration is more. And you know the reason, placental circulation dependent, okay, so they need a higher hemoglobin level, and physiologically it will go on falling, okay. So these are the normal physiological range, okay. So what are the transfusion thresholds? Means at what lower level you need a transfusion, okay. So it's not always pediatric is like a specialty branch, neurology specialty branch. So this was a level like less than 4 months infant, more than 4 months. So they need a transfusion at a relatively higher level. So infant, preterm baby, 12 gram, 11 gram, for me that baby is anemic. Okay. But if it's more than 4, up to 7 to 8 gram level also I can wait for the transfusion. Okay. Same is the level with the platelet 50,000, 30,000, 20,000. Okay. So these are the thresholds by which, so this is the limit by which I can wait, and below that I need to transfuse them. So different types of the blood available: whole blood, cellular component, RBCs, platelet, granulocyte, concentrate, plasma, FFP, cryo, stored plasma, plasma derivative, albumin. You need this in cases like hypoalbuminemia stage, like a nephrotic syndrome, to build the albumin level, IG coagulation factor. So it's not like give whole blood specific. Dr. Chaval is I think not there. So if they make more money, that is, we are happy with that, because they are giving me a specific product. The patient को factor 8 चाहिए, so they are giving factor 8. So this is my requirement. Okay. So blood, you know, what are the contents can be reconstituted if not available, should be preferably 7 days old. And in this, what are the indication? Whole blood. These are the limited indication: exchange transfusion, surgery, massive transfusion, trauma, and if component is not available, you can use this. What are the different rates of available? I need to choose. Okay. So patient is anemic. What are the common indication? 2 indication. And by the way, I would like to tell you, my department is using around 50 to 60% transfusions from the whole institute. So we have the maximum transfusion because I have thalassemia unit. So around 25 to 30 thalassemic kids are registered, and we are giving them a free transfusion. So we have one more source of Dr. Chavan, so we will be giving us a free blood if required, if not available with us. Okay. So back cell, apheretic, eradicated, frozen, early. So whatever the criteria, that will be much more, isn't it? Okay. So this product will be the choice. So in neonate and newborn and infant also, what are the indications? First of all, if it lies in the threshold level, the resolution of symptom of anemia and improvement of the tissue oxygenation. So these are the guidelines updated from so there is a blood loss. Okay, so more than 25% blood loss means that is already in shock. So that child needs a bolus dose infusion. Okay, so maintain hemoglobin more than 7 gram. If patient has any add-on like cardiorespiratory, CNS, ECMO, ventilation, so I will be happy to maintain his hemoglobin level more than 12 gram percent. Okay, about that, and one more update in a pre-surgical patient. What I read yesterday is like SB up to 7 they can be safely operated. Okay, so initially we used to take 8 and more than 8, so up to 7 hemoglobin in pediatric population. One thing, pediatric population tolerate anemia very well. Okay, as I said, hemoglobin 5 grams and their patient is comfortably playing. Mother didn't even notice. So reason is that most of them they don't have underlying any chronic disease like renal disease, blood disease, cardiovascular disease. Many of them. So they are nutritional. So they develop over a period of a year. So that's why they are well compensated. So they tolerate well. Okay. And infant less than 4 months, as we discussed in the threshold. So 12 gram, 10 gram. So depending upon the underlying condition or not. So these are the guidelines for them to transfuse. Okay. So two common indication for me is in our center is nutritional anemia and thalassemia. So these are the two. See, out of 25 cases, suppose I transfused last month, so 20 will be thalassemic and 4-5 will be of a severe nutritional anemia. So what are the factors that I will consider before giving transfusion? So patient symptoms, signs and compensatory capacities. Like the second case, the presence of underlying cardiovascular, vascular, central nervous system disease, where I will the threshold will be much lower. The cause and anticipated course of anemia, a chronic anemia, trauma, bleed, that will be emergency. Okay. So alternative therapy is the receiving will be that will be add-on. So blood group for the nuclear transfusion. So ABO incompatibility is quite. ABO antigen they are less antigen. RH incompatibility, RH negative they are as such less. The reason you know ki RH negative is less prevalent in our country, but we do get cases because we did around 4 to 5 exchange transfusion in our setup. So if RH incompatibility, give RH negative blood, ABO incompatibility, AB group cross match with the baby's blood group, cross match with the matter, that would be the best choice for exchange transfusions. So again, pediatric platelet transfusion. So all factors, as I discussed earlier, the patient is healthy, sick, underlying disease or not. So these are the factors. So 15,000, 10 to 50,000 is the threshold in children and adolescents. But if infant is there, the threshold is little bit of a higher. That will become 1,50,000, 20,000. So any complication, bleeding and further complication. Okay. So these are the indication of the plasma. DIC, massive transfusion, isolated conjunct factor. If specific factors they are not available, okay, already being discussed. Cryopreserve indication again, when specific factor is not available, hemophilia, von Willebrand disease, conjunct deficiency of the factors. Okay, so this slide, what are the adverse event or side effect? So one thing is likely. What is preventable? So what is preventable is likely one should be very much serious. So this is, as I said, the organ transplantation means it is a serious event. Okay. So check patients. What's happening nowadays is likely residents they are busy in so many of the activities, so they neglect. They try to neglect. So even if it is issued, at the same time you will be having 2 to 3 bags. So check that, check recipient, write proper notes. Okay. Monitor for not for 4 hours, so at least monitor for half an hour. Okay, then prepare the site properly so as to prevent infection. If these basic steps you take, so you can prevent so many of the complications. Okay, so the important adverse add here is like in a thalassemic child, unit of blood they will give around 200 milligram of elemental iron overload to the baby. Okay, so this iron load is going to cause a problem. Okay, So there will be IIMSR and iron overload will be there. Okay. So at particular point, they need a regular monitor. So this is unavoidable. Okay. So you need to so that's it. Transfuse them, maintain their hemoglobin level more than 8 gram% whenever possible. So time limit for transfusion. So what is time limit? Okay. So as far as possible, transfuse early. Okay. And finish within 4 to 5 hours whenever possible. At the same time, you should not be rapid. Okay. So you should not be more likely so as to prevent complication. Like you are pushing within 30 minutes, this should not happen. Okay. So start early, let it get warm, and transfuse it. Okay, properly. So as to prevent further any complications. So this is all. Thank you so much. Any questions that can be answered and discussed? Yes, sir.
In pediatric age group, if there is blood loss because of trauma or because of some major surgical procedure, we have to estimate the exact amount lost and replace it by the same amount.
Yes, sir.
But if there is hemoglobin deficit, you want to operate a patient and his hemoglobin is 5 grams, 6 grams. There are certain formulas for correction of that. Like one formula says weight of the child, hemoglobin multiplied by hemoglobin deficit, multiplied by 3 for access and multiplied by 6 for whole blood.
Yes, sir.
Are you following particular formula or?
Sir, that will again depend upon in adolescent and these kids blood volume is around 60 to 90 ml per kg. Okay, so that will depend upon the baby specific. Okay, so our target, as you said, the acute blood loss. So depending upon the mild, moderate, or severe, or so you will calculate. We are not following any particular formula, but 1 unit of blood in a given channel, say like suppose 10 kg. So 5. So we are giving 10 to 15 ml per kg of taxane maximum. That is should be able to raise hemoglobin by 2 to 3 gram%. Okay. Yeah.
Any other questions? Thank you, sir.
Thank you very much, Monisha, that the way you and sincerity with which you presented, that speaks of your association, close association with the children pediatric department. Thank you, sir. 2 to 3 questions.
Yes, sir. So I will answer.
One is about you told about, and that was interesting for me. And how frequently we can use that. The use of transfusions. So how commonly we use erythropoiesis. And the second is whether platelet transfusion, the criteria of count, platelet count is important, or the clinical condition of the patient is important.
So first question is erythropoietic is like we are not that frequently using, but a role comes in a patient like CRM. Okay. Patient who is having chronic renal failure, where there is a direct role of erythropoietic. In other cases, like as I told earlier, so the cases number 1, 2, or 3, 4, 5 cases are nutritional anemia and thalassemia. So these are the most they are occurring, and to surprise of everyone. So almost we are undergoing one study. So 50% of the children they are anemic. Almost 50% of the children are anemic, and surprisingly, sir, the cases which I showed per year, around 5 to 6 cases of a severe anemia, means hemoglobin less than 5 grams, they are coming to us. So it's very, very common. Okay. So erythropoietin dose is very limited. We are not using here, even if we have a pediatric nephrologist, but selected condition. And number 2 question, sir, you asked regarding the platelet count. So as I said earlier, parameter for the transfusion, they will be the same for blood, platelet, and other conditions. Okay, number 1 parameter is whether the child is sick or not, child is symptomatic or not. So even if these guidelines are arbitrary, so you need to have a clinical judgment. Okay, so suppose a child who is 2-year-old who is bleeding, and even if platelet count is 1 lakh, so I will transfuse it. So finally, it will be a combination of the factors, not a single factor. Okay, so I would like to transfuse at a higher level if the child is symptomatic, or I can wait. So I like to mention here, see dengue, we are managing so many cases of the dengue, and the count 10 to 20,000. There are so many cases without any single platelet transfusion. We have managed successfully so many dengue cases. The reason, it is not like that we are taking more risk because they were not symptomatic, they were not bleeding. There was a strict watch too early for any symptom of a bleeding. On the other hand, if the same case whose count is suppose 60,000, but there is a slight bleeding, so I will like manage aggressively with the platelets. So it's always a combination of the factor rather than a single factor.
Thank you. Sir, you have mentioned the chelating agents, use of chelating agent in thalassemia. How much does it really help? In relation to increase in lifespan.
So they are definitely helpful, like Keflor, there are oral, they are injectable. And luckily, what's happening is these agents they are available with the government institute like civil hospital, government medical college. So we are in process sooner or we may go with registered thalassemia unit. So they are definitely prolonging the life of a child. If the serum creatinine level goes more than 1500 nanograms, so that is indication for starting chelation therapy. So oral chelating agent they are available free of cost if they are not included, and they are definitely like the thalassemic kid. They are fourth decade, fifth decade up to that decade they are living. Otherwise, what used to happen is when we were PGs, so 10, 15 years used to be the maximum life of those kids. But nowadays, up to 4, 5 decades, they are surviving very well just because of the modern practices and availability of a chelation therapy.
Thank you. Thank you.
Now I request the chairperson to present. Organizing committee members to please gather near the dais for a group photo of the CME. And after that, we can disperse for a lunch, which happens out on the first floor of the same building.
please. Take one photograph and then you go for lunch. Are you? Someone wait and go for. Get one photograph. I will try. I know pictures of. This is.
Please, all of you, please gather fast.
Everyone. इधर आप पीछे आओ सर come fast.
ये चेयर को भी अरेंज कर देना। ये पीछे की जगह में इसमें से आगे की बुशरा आनंद आप लोग भी अभी चलो खाना खाएंगे एंड जल्दी से खत्म करके यहाँ आना है सेशन को मैं आ रही हूँ। हाँ ठीक है।
हम निकाले बैठ उसके बैठ निकाले सुकालो लाओ
वो वाटर ले नीचे हुए ये दर्द में कौन कौन बोलिए
नीचे नहीं काटने के, उधर ले लेने को, वो वहाँ से खुद देते फिर वो। बाकी कोई भी नहीं उठाऊंगा। ले ले उधर।
आप यूज करके कह सकते हैं कि आप नाम यूज कर सकते हैं
नहीं कोई उसको यूज कर सकता
पेन ड्राइव डालेंगे
बहुत वेग है मैं आपसे शेयर करूँ मेरे को खुद को सर मेरे को ना कभी भी एक्सरसाइज करते हैं आप स्ट्रेनस एक्सरसाइज बोलेंगे ये व्हेन यू आर रनिंग और समटाइम्स यू आर वॉकिंग यू डू समटाइम्स यू गो फॉर अ ट्रेक आप कहीं जा रहे हो सो सर आई टेंड टू वॉमिट
चलने का अनुभव होता है पहले
बीच में मिडिल ऑफ इट
वॉकिंग में या ट्रैवलिंग में
ट्रैवलिंग में नहीं मोशन सिकनेस नहीं इट इज नॉट एट ऑल मोशन सिकनेस इट इज अगर घर पे भी सर थोड़ी देर के बाद में वापस एक्सरसाइज करके आई एम नॉशियस और समटाइम्स आई कैन वॉमिट आल्सो
और एक ऑप्शन
इट्स अबाउट अ ईयर
ये पहले पिछले
इससे पहले सर व्हेन आई वाज इन 9th ग्रेड तो तब मेरे को मॉर्निंग सिकनेस बहुत अजीब वाला था कि मेरे को एवरी टाइम व्हेन आई एम ब्रशिंग माय टीथ आई यूज्ड टू वॉमिट एंड समथिंग इट इज लाइक आई एम
पोजीशनल होता है
नहीं इतना नहीं हुआ
ये फुल लेस है
सर मेरे को
डीएस
डीएस तो नहीं है मेरे को बट सर मेरे को साइनसाइटिस रहता है हाँ एलर्जिक ही बोलेंगे उसको सर मेरी ना बहन की शादी के टाइम से बढ़ा है इससे पहले होता था बट इतना सीवियर नहीं होता था तो अभी मेरे ऐसे बोले मेरा मैं इसमें बोल सकती हूँ अगस्त से सर मेरा अभी तक ऐसे लगता नहीं है क्लियर हुआ मतलब साइनस वो सप्रेस भी नहीं हुआ
ये फिटनेस अगर अभी नाक और ये कर बहुत सवाल नहीं होते तो दोनों डिस्ट्रेशन की ओपन बंद
नहीं बंद पता नहीं बट डॉक्टर मैंने लास्ट टाइम जब बताया था ये तो उन्होंने बोला कि कुछ भी मसला नहीं इट्स वेरी क्लियर क्लीन एवरीथिंग बट आई फील लाइक इट्स नॉट
रिफ्रैक्शन अपनी बैंक में ग्रेड वगैरह कुछ है
नहीं
क्योंकि ये जो दो भी लगता है ऐसा लग रहा है कि इट्स रिलेटेड टू ये पोजीशनल में एक्सरसाइज कर रहे हैं जा रहे हैं कि ऊपर नीचे तो ये हो सकता है कि बैलेंस की वजह से ये हो सकता है रश ये ये पेन आपने अपन ये वाले कैसे
हाँ सर उसमें डाले ना
ऐसा है कि
फोन पे नजर रखो
जी
सर मैं वो फोन में आपने क्या हाँ मैं क्यों फिर से शुक्र है वीडियो पे आके
इसलिए ही करना है कि मेरा
नहीं आप दे देंगे तो सब सुना देंगे ना तो मिला लेंगे अब ये
सर जो स्टार्टिंग वाले फॉर्म्स थे ना फीडबैक उसको कुछ कलेक्ट हुए थे और बाकी जो बचे थे मतलब वो बड़े थे हम सारे सुनने के बाद ही फीड फॉर्म
ठीक है
ये बैठ
ये इससे हाँ बैठ सर अरे दीजिए सर
ये भी देखना
और ना सर साइड से इधर पड़ेगा लेकिन पॉइंट का लाइट स्क्रीन पे नहीं आ रहा
ये उधर लगा आउट हो गया
ऐसा
ये रिलेटेड है कुछ ऐसा मीनियर्स वगैरह तो नहीं ऐसे सीवियर तो नहीं होता मीनियर्स से
ट्रबलिंग
ये रिलेटेड मोस्ट प्रोबेबली इज ये रिलेटेड
नहीं
ये उसमें कुछ नहीं है तो सेकंड पॉसिबिलिटी ऐसा है
सर मेरे को लगता है तो मैनेजर
सर ऑलरेडी फाइनल मेन से माइग्रेन का चांसेस दूसरा हो
माइग्रेन है सर
माइग्रेन एक दूसरा पॉसिबिलिटी है तीसरा पॉसिबिलिटी है कि साइकोलॉजिकल डर वो हमेशा बढ़ गया कि मुझे होता है ये तीन में से एक की पॉसिबिलिटी ज्यादा है लेकिन फर्स्ट पहला देखो पहले ये करो आपको फिर दूसरा HP TLC पेटेंट नाम है B12 सीरम B12 विटामिन D
विटामिन डी से मेरा पिछले साल कम था
तो एक फिर से एक बार कोर्स कर लो
चलेगा सर मेरा कैल्शियम भी हमेशा कम रहता है और सोडियम भी थोड़ा लोअर साइड रहता है
ना सिग्निफिकेंट कम है आयरन कैल्शियम कम रहता है
नहीं मेरा मतलब एकदम ऐसे है कि सर शायद मेरे को ऐसा लगता है आर्बिट्री मेरा कम होगा मेरे लिए शायद वो कम है बट वो मुझे लगता है कि नॉर्मल रेंज में ही है मतलब इट्स लाइक जस्ट अबाउट द एज मिनिमम
एक काम CBC इलेक्ट्रोलाइट और कैल्शियम आयरन कैल्शियम ऐसा करके एक करा दो
थायराइड में अभी 6 मंथ्स बैक कराया था विद इन मीन
इतना ही रोलिंग कर लो और ये करो ये
हाँ चेंज करें ये स्लाइड शो में यू कैन चेंज फॉरवर्ड करिए सर पॉइंट क्या है इसका नहीं सर तो ये और क्या लेकिन है ये
नहीं वो हाँ वो क्या है उसका ये जा रहा है हाँ उसको कम नहीं कर सकते
मेरा एडवांटेज ये है सर कि लाइट वेट बनने का नाम हां इसमें को इसका एडवांटेज ये है तो वो प्रोजेक्ट जो है तो लाइट वेट फॉर्म
वो अगर ये बंद कर दिए तो ये वाले
नहीं जरूरत नहीं सर
मतलब वो आ सकता है शायद फिर पॉइंटर
फिर कैसा फोटो में कैसा लाइट नहीं आ सकता स्पीकर का फेस नहीं दिखा
एक बार फोटो निकाल के नहीं कर नहीं इसलिए कि वो पॉइंटिंग करना ना वो ऐसा इस पे आ रहा है एक बार बंद करके देखते तो कैसा वो उधर सर मुझे ना वो वहाँ पे बैठ खड़ा रहेंगे मुझे हाँ वो बंद करके ये दो बंद करके ये हाँ फिर आता है उसका ये कम नहीं होता रिजल्ट
वो इरफान को मालूम सर आपने को
इरफान फोन करो कल इरफान को फोन करो मतलब रिजल्ट सेंड कंप्लीट नहीं है आधे टाइम में फोन हमें पर वो हो रहा नहीं है our system information update setting or आपने कितनी आया उसमें I will come here. I will ये तो कुछ नहीं करना है सिर्फ ये निकाला यहाँ आ जाएगा क्योंकि it's very difficult to see थोड़ा comfort होना चाहिए हेलो ये कैसा आ रहा है ये तो ये नहीं आ रहा ना सिग्नल इसको और connected, yes, later. Because later switch was हम लोग जो है जैसा है एक तो हम आपको दिए हुए दिस व्यू विल बी एक को देखिए हम भी क्या रहे हैं तो देखने वाले और इसको फुल कर दो ये पूरा सा present you as slides. ये इधर ये वाला है नहीं वो नहीं ये स्क्रीन नहीं नहीं ये नहीं चाहिए वो तो इधर से नहीं आएगा नहीं ये पहला सेक्शन है
All of you are sitting down now. Sitting down.
इमेजेस नाही करत ते आवश्यक आहे.
For our coming next two sessions, I would like to invite Dr. Kaisar sir and Dr. Gauri sir to be our chairperson. For the session, I invite our speaker on stage, Dr. Sachin Sulami sir. The topic for his talk on rational use of blood and blood components. Dr. Gauri sir was ex-professor actually in IIMSR. First physician to join IIMSR since day one. Key role in establishment of medicine department, ex-civilian surgeon administration on the After retirement, still working as professor emeritus in medicine. Dr. Kaisar sir is a professor of surgery at IIMSR. Worked in Saudi Arabia as pediatric surgeon for 25 years. Joined the institute on 1st July 2011 and have 38 publications in various national and international journals. So could you please introduce Dr. Sir?
Good afternoon. I welcome all delegates in post-lunch session. Dr. Sachin Salanke sir probably doesn't need any introduction. Presently, he is head of medicine department of our college. As you know, he is very dynamic and enthusiastic physician. He is fully devoted teacher in our college, our institute, and all our PGs are very lucky to have him back in our college. He has worked very enthusiastically in GMC Aurangabad, GMC Ambajai, private medical.
Blood transfusion snake bite, food poisoning. If university start asking questions on these issues, which are very common and important, so probably student will read it and that will help to manage patient better.
and that will help to reduce the complications related to blood transfusion in future in practice. Thank you, Madam. Madam for giving opportunity to speak. Actually, blood, there is very complex relationship between the humans and blood is there. Since आप देखेंगे माइथोलॉजी से लेके लिटरेचर जो सोच सकते हैं, जब से इंसान है तब से ब्लड के साथ में का रिश्ता जो है बहुत ही कॉम्प्लेक्स रहा है. एक साइड से उसका बहुत ही दूसरे साइड से उसको टॉनिक बोल के देते हैं. मतलब कुछ लोग ऐसे कि ब्लड लेना ही नहीं है हमको, कुछ लोग ऐसे हैं नहीं टॉनिक है और हमारे डॉक्टर ने बोला है तो लेना ही है, तो कमजोर हूँ लिया तो बहुत भाग जाऊंगा मैं. मतलब ऐसे दो एंड्स हैं. सो ये दो एंड होने की वजह से वी हैव टू बी रैशनल. व्हाई? बिकॉज यू आर द डिसीजन मेकर whether to transfuse or not. That's why it is important to be rational. If we say in day-to-day personal life also, we use the name of blood very easily. है ना? जैसे कि day-to-day life में अपन दोस्त है, क्या होते हैं अपन? दोस्त के खून के रिलेटेड बोलती है ना अपन, अरे इतना खून मत पी, है ना? ऐसा फैमिली लाइफ में भी बहुत खून पीती है या बहुत खून पीता है, दोनों भी मतलब चलता है. शादी वाले लोग समझ गए होंगे. दूसरा है अपना सोशल कल्चरल बिलीफ्स आर आल्सो वेरी हाई. मतलब जो अभी जो बोला मैंने कि ब्लड इज अ वेरी बैड थिंग टू, उसको भगवान का दर्जा है, ऐसे दोनों तरफ से उसको ये दिया हुआ है. इसके बाद में देखेंगे कि जियोग्राफिकल भी है. जियोग्राफिकल हम वो एरिया से है ना, हम वो कंट्री से है, हम वो रीजन से है, तो हमारा खून प्योर है, हम प्योर है, मतलब जो ये है, या फिर हमारे इंसेस्टर्स, हमारा खून का रिश्ता है, ऐसा अभिमान से बोलते हैं, है ना. मतलब ये हर जगह आपको मिलेगा. जियोग्राफिकली, हिस्ट्री वाइज, एवरीथिंग ब्लड हैज वेरी इंपॉर्टेंट. इवन इन साइंस आल्सो, फॉरेंसिक साइंस टू डिटेक्ट क्राइम्स वगैरह वहां पर भी आ जाता है. मूवीज में तो खून बोले तो पिक्चर से नाम से लेके आपको डायलॉग्स तक आ जाएंगे. धर्मेंद्र का एक फेमस डायलॉग है, वो सर डैश डैश मेरे तरफ खून पी जाऊंगा, है ना. पिक्चर के नाम खून भरी मांग. मतलब जितना सोचेंगे उतना खून और पिक्चर का रिश्ता आपको मिल जाएगा. तो ये ऐसी चीज है कि उसको आप मतलब यहाँ से वहां तक जाएंगे तो खून से रिलेटेड कुछ ना कुछ आपका दिमाग में चलेगा. शायद इसीलिए है कि जो अपन है वो कॉन्शियसनेस की वजह से है, ऐसा मुझे लगता है ना. अपन है तो कॉन्शियसनेस है. कॉन्शियसनेस को कौन न्यूट्रिएंट्स प्रोवाइड कर रहा है? ब्लड. प्रोबेबली ब्रेन ऑलवेज रिमेंबर्स ब्लड, क्योंकि वो उसका पोषिंदा है. सो blood transfusion was tried before 1900 also, but because of ABO compatible group were not detected, so many reactions were there, were not that much successful. After Jalna, who is called as the father of transfusion medicine or father of blood and blood products, ऐसा भी बोल सकते हैं. 1900 में एक स्टूडेंट, मेडिकल स्टूडेंट था, मेडिकल स्टूडेंट के हैसियत से उसने किया था. पहला 1818 में जेम्स जो एक ब्रिटिश ऑब्स्टेट्रिशियन था, उसने बीपीएच का पेशेंट एक मैनेज किया था सक्सेसफुली बाय, वो शायद वो लेडी जो होंगी यूनिवर्सल रेसिपिएंट होंगी, वो एबी रहेंगी, और उसमें बहुत सारे ब्लड देने के बाद कुछ क्रॉस मतलब हीमोलाइसिस ये हुआ नहीं होगा, बाय चांस हुआ होगा. सो व्हाट इज रैशनल? तो ये जो मूवी है आप देखता होगा, अमर अकबर एंथोनी एक साथ सभी तरफ से ब्लड ले रहे हैं और माता जी को दे रहे हैं, है ना. तो ये तो सब्जेक्टिव असेसमेंट है लोगों का. इट्स सब्जेक्टिव. I never come upon any of my discoveries through the process of rational thinking, अल्बर्ट आइंस्टाइन. क्योंकि हर जगह पे रैशनल बोलने का क्या मतलब है? बस यही है, इसके आगे कुछ नहीं, इसके आगे नहीं तो क्या हो जाएगा? सब कुछ खत्म, डिस्कवरी ही बंद हो जाएगी, है ना. तो यहाँ पे आपको ये रैशनल इस कॉन्टेक्स्ट में लेना है कि ये जो गाइडलाइंस है, these are the guidelines which we have to apply rationally in context of patient's overall clinical situation and condition. We have to individualize it. किसी का फाइनल वर्ड नहीं है कि मतलब ये करना है तो यही करना है, ऐसा नहीं है. You have to be situationally adjust. Depends upon your patient clinical profile, depends upon your infrastructure, supporting system, skill available. मतलब multiple factors से आपको उसको modify करना. Guidelines ये अल्टीमेटली आपको मॉडिफाई करने के लिए ही रहता है जब आप अप्लाई करते हैं प्रैक्टिकली. तो जैसा कि रैशनल लॉ में जैसा कि रूल है, सिग्नल नहीं तोड़ना, जिसको क्या बोलेंगे ऑब्जेक्टिव है, जिसको किसी में कोई दो राय नहीं हो सकती ना, क्या हो सकती है, सिग्नल नहीं तोड़ना चाहिए. इसको अपन बोलते हैं कि रैशनल, कंप्लीट रैशनल है. लेकिन ये जो चीज अपन देख रहे हैं वो कंप्लीट रैशनल नहीं है. ये जो अभी तक का एविडेंस है उसको अपन को रैशनली अप्लाई करना है, day-to-day learning from that and modifying it. So to be or not to be famous, इसका ना क्या ना शेक्सपियर का कॉमन ये है. वो कंफ्यूजन है, रहेगा ही, मेडिकल फील्ड है ही कंफ्यूजन. आज जो है कल वो रहेगा नहीं, कल जो होगा वो परसों होगा नहीं, और जो आज है वो शायद फिर से आ सकता है ना. रिवॉल्यूशनरी, डायनामिक, इट इज अ डायनामिक प्रोसेस. So we have to modify ourselves. What are our objectives in rationalization? We have to see whether that patient which are giving the blood, whether it is really needed or not, whether it is really indicated or not. It should be clinically indicated. I think there should be reasonable assessment should be done by at least 2 physicians before transfusing the in elective patient, not in emergency condition. Emergency condition में आप 2 physician को बुलाते बैठेंगे तो जाएंगे, लेकिन in elective situations. And always weigh the risk and benefit. See, blood product is ultimately a biological product. It is not free of hazards. It has many transfusion. Madam will take the reactions and hazards of that. I will not go in details of that. But it is very hazardous if you wrongly give, wrong time पे, wrong patient में, है ना, wrong diagnosed patient में दे देंगे, तो कोई भी चीज wrong कर देंगे ना, तब complication ज़्यादा बढ़ते हैं. ये तो आपने भी किया होगा. अगर आपने किसी को थ्रोम्बोलाइसिस की जरूरत नहीं है और स्ट्रेप्टोकाइनेस दिया तो प्रोबेबली पेशेंट ब्लीडिंग चांसेस विल बी वेरी हाई. तुमने एकेटी ट्यूबरकुलोसिस को दे दिया और ट्यूबरकुलोसिस नहीं है तो हेपेटाइटिस होने के चांसेस ज्यादा है. इसलिए ब्लड ट्रांसफ्यूजन रिएक्शंस 2 चीजों से बहुत ज्यादा होती है. एक तो ह्यूमन एरर्स, जो फॉर्म भरना आना, और जो एक्टिव पेशेंट आइडेंटिफिकेशन है वो प्रॉपर नहीं करने की वजह से होते हैं. और दूसरा जो अभी जो बोला मैंने, हाँ, नॉट अप्लाइंग टोटल क्लिनिकल जजमेंट. ये 2 चीजों की वजह से कॉम्प्लिकेशंस होते हैं. ये 2 चीजें अच्छी करें, डॉक्यूमेंटेशन प्रॉपर आइडेंटिफिकेशन, and you should be sound in your back of mind. You are giving blood to the correct patient for correct cause. What are the risks? I will not go in detail of that because madam will cover it. These are the some risks with associated with blood transfusions. Already, our Jalna sir has already taken this transfusion-related infections, viral, bacterial, parasite infections, or they are allergic and immunological reaction, febrile reaction, non-immunological, anaphylaxis, death, and transfusion-associated circulatory overload. It is one of the very common complication is there. The transfusion associated lung injury, especially when you are doing massive transfusions like in postpartum hemorrhage, patient with massive electrolyte abnormalities like hypocalcemia because citrate, and that leads to ultimately hypocalcemia, bleeding, hyperkalemia because blood which is stored for prolonged time in blood bank, the RBC potassium comes out from the RBC, so potassium is on higher side. But generally, if patient is not having CKD or patient's potassium handling mechanism physiology is good, generally this will not cause hyperkalemia. Because once you give this, so whatever extracellular potassium is there in the donor's blood, that immediately shifted to the recipient's RBC. That's why most of the time it will not the major problem. But it can be the problem when the recipients have problem with kidney. So these are the complications. Commonly, if you see if you see this transfusion associated circulatory overload, है ना, so that means this patient develop overload means ये पेशेंट को एक तो जरूरत नहीं थी या फिर जरूरत से ज्यादा दिया है या फिर उसके अंडरलाइन कोमॉर्बिडिटी कंडीशंस अच्छे से असेस नहीं किए हैं, है ना, तो इसके वजह से ये हो जाता है। फिर फीवर जनरली मतलब उसमें तो ये नहीं है, जनरली अपने पास अभी पीआरबीसी यूज करना चाहिए, लेकिन शायद अभी भी अपने इधर सभी तरफ मैक्सिमम पेरिफेरी में वो मिलता नहीं है। इसकी वजह से फेब्राइल रिएक्शंस आर वेरी कॉमन बिकॉज़ द व्हाटएवर पीआरबीसी दो वी सेड इट एज अ पीसीबी बट इट कंटेन्स सम क्वांटिटी ऑफ WBC also. That's why you should use liquid-depleted PRBC or क्या बोलते हैं irradiated PRBC. Then mostly 1 in 1,000 is the death from medical error. 1 in 1,000 related to blood transfusion. And aeroplane lightning fatalities death is in the 1 in 1 million. Such a big difference is there. So we have to be very careful in blood transfusion, right? Then these are the risks: 1 in 1 million for HIV, HCV, 1 in 1 lakh for HPV. So there are series of rightly diagnosed patient, right product or right component. If patient is anemic, need only RBC, transfuse only RBC. If patient's HB is normal, platelet is less, transfuse, if bleeding, transfuse platelet only. Don't give the thing which is for the patient. Means specific component to be required component should be transfused for right reasoning. Means जो अभी back of mind में अपन reasoning बोल रहे थे overall assessment करके right in PT forms, correctly write everything, patient identification everything, और आपको personally जाके patient को confirm करना चाहिए before giving the blood transfusion. फिर paper देखा, blood transfusion form उधर आया वाला blood bag देखा, वही बैठे nursing station पे उधर से ब्लड बैग आए, ब्लड बैग का जो फॉर्म आया उधर से वो देखा, पेपर पे देखा और उठे ही नहीं आप तो वो जाके कहीं पर भी लग सकता है। इसलिए तुम पेपर, पेशेंट, ब्लड बैग तीनों को आप कंफर्म किए बिना ट्वाइस, इट इज बेटर टू कंफर्म बाय 2 पर्संस और वो भी सेपरेटली, दोनों एकदम जाके देखेंगे एक साथ, सेम माइंड रहेगा। एक को पहले जाके देखो, दूसरे ने दूसरी बार जाके देखो, नेम, ID number, everything check it because names are very similar, और आपको तो पता है पेपर पे क्या क्या नाम रहते हैं, मतलब नाम का अगर अपने पेपर के अगर पेपर देखे तो एक लिटरेचर तैयार रहेगा नाम। So right recipient identification, right place means there should be some supporting system should be there to tackle the complications if are there. जैसे anaphylaxis है, febrile reactions है, आपको पूरा इंफ्रास्ट्रक्चर वहां पे होना चाहिए कि दो चीज मैनेज करने के लिए। राइट टाइम मींस दो टाइम और डे का भी राइट टाइम। जनरली नाइट में नहीं ट्रांसफ्यूज करने का, जितना हो सकता है उतना, ऐसा नेशनल गाइडलाइंस, इंडियन नेशनल गाइडलाइंस बोलती है। और पेशेंट के लिए राइट टाइम बोले तो उसका क्लिनिकल, मतलब क्लिनिकली जब भी लगता है तब राइट रेट टू प्रिवेंट दैट सर्कुलेटरी ओवरलोड एंड दैट राइट ड्यूरेशन, करेक्ट ड्यूरेशन पे ही जाना चाहिए, राइट मॉनिटरिंग है ना, और राइट मैनेजमेंट ऑफ कॉम्प्लिकेशंस। वो नहीं आएगा क्योंकि ये सब राइट करने के बाद शायद वो राइट मैनेजमेंट ऑफ कॉम्प्लिकेशन करने की जरूरत नहीं पड़ेगी, उसके बाद हुआ तो दैट इज आवर बियॉन्ड आवर कंट्रोल है ना। So we know कि at a time 5 to 7 liters of blood is there in the body, out of which 55% is a plasma, 44% red blood cells and 1% constitute WBC and platelets. ये तो बता देंगे आपको मैडम कैसे कैसे ये करते हैं, मेरा मतलब मुझे ज़्यादा समझता भी नहीं है और मुझे इतना ये भी नहीं है, बता देंगे आपको कौन से टेस्ट करते हैं। हेपेटाइटिस बी, हेपेटाइटिस सी, एसटीएलवी, सिफिलिस, एबीओ और आरएस टाइपिंग भी करते हैं। शायद मलेरिया पैरासाइट भी देखते हैं आपने, इधर रैपिड मलेरिया पैरासाइट मतलब आरएनटी करके देखते हैं क्या पीएस करके देखते हैं? आरएनटी ये एलाइजा में कैसे करते हैं? ये कंपोनेंट्स हैं ब्लड के, होल ब्लड, पीआरबीसी, प्लेटलेट, केपीपी, क्रायोप्रेसिपिटेट, these are the commonly used components. There are so many components, मतलब परफॉर्मिंग कॉम्प्लेक्स कॉन्सेंट्रेट है, फिर इंडिविजुअल कोएगुलेशन फैक्टर्स है, फिर आपके कुछ ऐसा पेगिलेटेड एल्ब्यूमिन वगैरह ऐसे बहुत सारे ये है लेकिन कॉमनली ये 4 अपने को क्लिनिकली लगते हैं। एल्ब्यूमिन it is maybe used in subset of patient clinically indicated. ये generally PRBC का volume, the whole blood is generally not used, but if it is there, it is of around 350 to 500 volume depends upon the कितना लिया आपने। अच्छा आवाज नहीं बराबर आ रही नहीं घूम जाएगा depends upon the how much blood patients मतलब donate करते हैं how much blood has taken उसके ऊपर भी है और वो additive डालने के बाद ये सब बनेगा around 350 to 500 ml हो जाता है। CPDA जनरेशन 1 2 to 6 डिग्री ये बताओ नहीं मैडम बता देंगे ना हाँ तो PRBC जो है PRBC बता देना 300-350 ml कम वॉल्यूम है क्योंकि इसमें से आपका क्या निकल जाएगा प्लाज्मा और WBC निकल जाएगा तो रह जाएगा सिर्फ RBC वो कि 44% रहता है टोटल आपके ब्लड के काउंट का। FFP 200 to 300 ml प्लेटलेट RDP जो है रैंडम डोनर प्लेटलेट वो 50 to 75 है रैंडम डोनर बोले तो अलग अलग डोनर से लिया हुआ है जनरली 4 या 6 लगते हैं तो अपन 4 डोनर से एक एक प्लेटलेट ले लेते हैं उनमें से तो एक पैक का जनरली 50 to 75 ml रहता है इसका स्टोरेज जो है शेल्फ लाइफ 3 to 5 days है FFP का 1 year है because it is stored at -40 degrees Celsius or at least -30 degrees Celsius right frozen just like frozen fresh frozen plasma और जो ब्लड है CPDA 1 का वो 35 डेज के लिए है और PRBC जो है PRBC 42 डेज तक भी रहता है अगर वो साइक्लोन अगर यूज करते हैं प्रिजर्वेटिव में आपके पास साइक्लोन है क्या CPDA साइक्लोन और क्रायोप्रेसिडेंट 10 to 20 ml 1 year और SDP बोले तो सिंगल डोनर प्लेटलेट मतलब एक ही डोनर से लिया वाला प्लाज्मा और फेलिसिस टेक्निक से लिया वाला रहता है तो एक ही पेशेंट का रहता है और ये ड्यूरिंग अभी ये तो वॉल्यूम ये हो गया अभी ट्रांसपोर्ट में क्या है यू कैन ट्रांसपोर्ट दिस होल ब्लड फॉर नेक्स्ट 24 आवर इफ यू आर मेंटेनिंग द टेम्परेचर बिटवीन 1 to 10 डिग्री सेल्सियस पैच सेल भी वैसा नेक्स्ट 24 आवर्स के लिए आप ट्रांसपोर्ट कर सकते हैं लेकिन 1 to 10 डिग्री सेल्सियस कंफर्म आप टेम्परेचर रेगुलेशन रख सकते हैं तो ही फ्रेश प्रेजेंट प्लाज्मा ट्रांसपोर्टेड इन फ्रोजन स्टेट वो थॉ करने के बाद ट्रांसपोर्ट नहीं करना चाहिए वो फ्रोजन स्टेट में ट्रांसपोर्ट करना चाहिए प्लेटलेट कॉन्सेंट्रेट दे आर ट्रांसपोर्टेड एट रूम टेम्परेचर बट लेते जाते वक्त उसको कांस्टेंटली एजिटेट शेक करना पड़ता है तो क्लम्पिंग ऑफ प्लेटलेट्स इज गोइंग टू हैपन क्रायोप्रेसिडेंट -30 डिग्री सेल्सियस फॉर 1 ईयर इसको ट्रांसपोर्ट का वही फ्रीज फॉर्म में ट्रांसपोर्ट करना पड़ेगा उसको मतलब जनरली ये जो बाकी जो है PRBC और ये छोड़ के अराउंड 30 मिनट्स में देते हैं ऐसा समझ लो बट इट विल बी डिपेंड्स अपॉन द हाउ मच इमरजेंसी इज देयर टू गिव द प्लेटलेट टू गिव द FFP सपोज एक मैसिव हेमोरेज का पेशेंट आ गया तो वहां पे आपको FFP 10 to 50 ml पर केजी पर आवर के हिसाब से देना पड़ेगा और वही अगर सिंपल पेशेंट है जस्ट टू प्रिवेंशन यू कैन गिव 1 to 3 ml पर केजी पर आवर so it is depends upon how much need is there how much time is there available for you है ना कितना इमरजेंसी है करेक्ट करना उस हिसाब से आपको वो ये हो जाएगा और ब्लड जो है तो जनरली और 4 आवर्स 3 to 4 आवर्स जाना चाहिए ये इनिशियली जो 15 मिनट है वो 1 to 2 ml 1 to 3 ml पर आवर के हिसाब से अपना पहला 15 मिनट रखना है उसके बाद में एज पेशेंट टॉलरेट you can give depends upon the overall clinical condition of the patient and underlying comorbidities but it should not at any level it should not cross more than 4 hours as possible अगर वो ट्रांसफ्यूज नहीं होता है जल्दी तो हाफ आवर टू 1 आवर तक आप रख सकते हैं और बाद में मतलब अगर ट्रांसफ्यूज नहीं हुआ पेशेंट को तो वापस ब्लड बैंक को देना है तो हाफ आवर में देना चाहिए हाफ आवर टू 1 आवर में सब कुछ है अगर टेम्परेचर मेंटेन कर रहे हैं so this is PRBC two sources are there either it is prepared from whole blood bag by centrifugation or by IIMSR apheresis machine and other special types of PRBC irradiated RBC or liquid depleted RBC wash RBC volume reduced RBC these special type of PRBCs are required in very subset of patient जैसा कोई ट्रांसप्लांट का पेशेंट है ट्रांसप्लांट पे जाने वाला है तो it is better to give this special type of PRBC rather than giving this thing. प्रेगनेंसी है इसमें, जिसमें आपको लगता है कि कॉम्प्लिकेशन वी कैन नॉट मतलब अफोर्ड टू हैव कॉम्प्लिकेशंस, तो उसमें स्पेशल टाइप के आइडियली तो सभी वैसे ही चाहिए, अगर नहीं होता है तो कम से कम सबसेट ऑफ पेशेंट को यूज करना चाहिए। ये भी ब्लड ग्रुप का सबको पता होगा, इसमें नहीं जाता मैं किसको कौन सा एक, इसमें एक ध्यान देने जैसी बात है, ये भी जो है इट इज अ यूनिवर्सल रेसिपिएंट, वो है जो है यूनिवर्सल डोनर, किसके लिए? पीआरबीसी के लिए। लेकिन वही देखेंगे तो आप मतलब ऊपर वाला कुछ देता है तो कुछ लेता नहीं। तो यहाँ पे देखिए, अगर आपको एफएफपी देना है तो यूनिवर्सल रेसिपिएंट इज ओ, और एफएफपी देना है तो यूनिवर्सल डोनर इज हाँ ए बी, उल्टा है उसका, क्योंकि उसमें एंटीबॉडीज रहती है तो उल्टा हो जाता है। मतलब कहीं ऐसा ना हो जाए ऊपर वाला सोचा होगा कि वो वाले ही ज्यादा ए बी वाले ही ज्यादा क्यों खुश हो जाए, तो ए बी वालों के लिए भी तुम्हारे लिए एफएफपी है। ये तो सब पता है, मैं जाऊंगा नहीं डिटेल में, फर्स्ट चॉइस सेकंड चॉइस बताना है। तो ये पॉजिटिव के लिए फर्स्ट चॉइस इज ए पॉजिटिव और ए नेगेटिव, सेकंड चॉइस इज ओ पॉजिटिव और नेगेटिव। ओ पॉजिटिव बी पॉजिटिव के लिए बी पॉजिटिव और ओ पॉजिटिव, राइट? क्योंकि वो अगर के वो डोनर है यूनिवर्सल, उसको दे सकते हैं, कोई प्रॉब्लम नहीं, नेगेटिव और पॉजिटिव। सिर्फ ये जो है नीचे वाला ध्यान में रखने का, आपको ए बी नेगेटिव के लिए ए बी नेगेटिव, ए नेगेटिव, नेगेटिव वाले पेशेंट को नेगेटिव देने का, इतना ही ध्यान में रखना। नेगेटिव वाले पेशेंट को पॉजिटिव नहीं देने का। आवाज नहीं आ रही? अच्छा, नेगेटिव वाले पेशेंट को नेगेटिव ही देने का, ये अच्छा है। Avoid unnecessary transfusion, especially when alternate treatment is available. Specifically समझो IIM थेरेपी, एक आयरन डेफिशिएंसी का एनीमिया का पेशेंट है, आपका 7 HB है, हीमोडायनामिक स्टेबल है, CCF में नहीं है, ज्यादा सिम्टम्स नहीं है, तो give IIM rather than going for blood transfusion. विटामिन B12 मेगालोब्लास्टिक एनीमिया है, तो मेगालोब्लास्टिक एनीमिया rarely requires blood transfusion because response to vitamin B12 and folate is very fast. Within 5 weeks, patient's HB will get normalized from 4 to 9. Such a rapid response is there. That's why never give, as far as possible, blood to megaloblastic anemia. Decision should be taken in context of clinical status and comorbidity. Transfuse only required blood component, not the whole blood. Hemorrhage and external transfusion. These are the indications specific for that. No consent of fresh blood transfusion. Avoid single unit transfusion unless clinically rational. सिंगल यूनिट देना नहीं है, लेकिन क्लिनिकली रैशनल, जैसा कि समझो अपना एक इश्चेमिक हार्ट डिसीज का पेशेंट है, उसका HB 7.5 है, तो वहां पे अपने को थ्रेशोल्ड क्या है 8 की, तो वहां पे एक देने के बाद आपका कितना हो जाएगा 8.5। तो यहाँ पे सिंगल ट्रांसफ्यूजन इज जस्ट और रैशनल। अदरवाइज सिंगल यूनिट का ये मत करो। डायग्नोस एंड ट्रीट द अदर कॉजेस ऑफ डिस्निया, मतलब एनीमिया पेशेंट है, उसको CCF है, मतलब वो प्रोमिनेंट सिम्टम एनीमिया की वजह से है कि CCF की वजह से, वो देखो अगर CCF की वजह से है तो वो पहले वो ट्रीट करो, और सिम्टम रिजॉल्व होते हैं तो फिर विदाउट ब्लड एनीमिया मैनेज करो। ऐसा रिड्यूस हेटेरोजेनिक एनीमिया, रिपीटेड ब्लड लेना, कलेक्ट करना, और हर मतलब आया कि पूरा टिक 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 करके मत भेजो, अपने को बहुत इंस्ट्रक्शन आते हैं वालों से कि मत भेजो ऐसा पूरा टिक करके, तो इसलिए क्योंकि ये वन ऑफ द इम्पोर्टेंट है। वो all available pre-operative perioperative measures must be taken for blood conservation. मतलब pre-operative perioperative जो measures रह सकते हैं, मतलब estimated blood loss सर्जरी में कितना हो सकता है, कितने आवर्स की सर्जरी को, क्या अंडरलाइंग कॉम्प्लिकेशंस है, उस हिसाब से प्रिवेंटिव मेजर्स पहले से ही लेने चाहिए। जैसे कि कोई ड्रग चालू है, इकोस्प्रिन है, अनइंडिकेटेड है, स्टॉप कर दो। It is reasonable to discontinue low antiplatelet drugs if without coronary artery syndrome, do not transfer under reduced pressure. ये बहुत बड़ा प्रॉब्लेम। फिर से डॉक्टर बोल के जाते हैं तुम्हाला रक्त चढावं लागते, त्याशिवाय शक्ती येणार नाही। इथं आले की ते आपलं काय म्हणजे डॉक्टरनं रक्त द्यायचं सांगितलं, आपण नाही म्हणलं की त्यांना डाऊट येतो, कारण पेरीफेरीचा डॉक्टर त्यांचा फॅमिली डॉक्टर असतो, त्यांना त्यांचं बरोबर वाटतं। त्या प्रेशर खाली इवन प्लेटलेट्स सुद्धा बरेच दिवस अंडर प्रेशर अंडर हे ट्रान्सफ्यूज केले जातात। No need of active arming of blood is needed unless massive transfusion is required. Routine use of pre-medication is not required. RBC should be
started within 30 minutes after discharge from the blood bank and should complete in 4 hours. वो तो पता है मुझे. Or non-essential night transfusion should be avoided. Megaloblastic anemia and iron deficiency can be treated with iron and B12. Better to avoid in this nutritional level. These are the restrictive liberal strategies. These are some references for that. You see, these are the meta-analysis studies were done. Cochrane review meta-analysis studies there. Consensus is there. So from this, see, if HB is less than 7, you can transfuse the blood with some exceptions. अभी यहाँ पे क्या exceptions आएंगे? Iron deficiency anemia है, megaloblastic anemia है. सिर्फ 7 है कम तो मत दे दो अगर asymptomatic है. अगर वो anemia की वजह से symptomatic है, severely मतलब cardiac symptoms है उसको, dyspnea है, syncopal episodes है, palpitation है, tachycardia है ना? तो ही उसको ट्रांसफ्यूज करो. अदरवाइज देने की जरूरत नहीं है. लेकिन इट इज अगर 7 के नीचे आपने ट्रांसफ्यूज कर दिया तो कम से कम आप उसको आपको सम एक्सटेंट डिफेंड कर सकते हैं कि 7 के नीचे तक. इफ इट इज बिटवीन 7 to 10, सी whether it is acute coronary syndrome, acute myocardial infarction, then transfuse because we have to maintain the HB around 10 because for perfusion. If it is not that acute coronary syndrome नहीं है तो hemodynamically stable है patient. अगर hemodynamically unstable है, cardiac respiratory symptoms है, तो then you can transfuse even in between the 7 to 10 also. But in which patient who is hemodynamically unstable? Hemodynamically stable patient को 7 to 10 के बीच में ट्रांसफ्यूज नहीं करने का है. और जो hemodynamically and respiratory cardiac वजह से symptoms नहीं है और 7 to 10 के बीच में है, तो उसके लिए स्पेशल जो सबसेट ऑफ ग्रुप ऑफ पेशेंट रहते हैं. जैसा पेशेंट आईसीयू में थोड़ा क्रिटिकली इल है पर hemodynamically स्टेबल है, तो उसका जो थ्रेशोल्ड है वो 7 है. और जो प्री एग्जिस्टिंग कोरोनरी आर्टरी डिसीज, प्री एग्जिस्टिंग इज इश्चेमिक हार्ट डिसीज ऑलरेडी, एक्यूट मायोकार्डियल इंफेक्शन नहीं, इश्चेमिक हार्ट डिसीज, तो उसका ट्रिगर है और थ्रेशोल्ड लेवल है 8 के नीचे आप ट्रांसफ्यूज करो. फिर नॉन कार्डियक सर्जरी के लिए 8 एंड कार्डियक सर्जरी के लिए 7.5. सो if you see this, so asking from surgeon about 10 really is not that much justifiable. So sir, between 8 to 10 you can safely go if that procedure likely will not cause much more hemorrhage. Prolonged duration नहीं है, कुछ complicated नहीं है, ज़्यादा duration मतलब कुछ सर्जरी है जिसमें आपको पता रहता है कि इसमें hemorrhage के chances है, तो उसमें आप थोड़ा threshold कम करके भी दीजिए. लेकिन जिसमें प्लेन सर्जरी अपेंडिक्स कम है, 8 HB है, इलेक्टिव है, फिर भी इट इज जस्टिफाइबल टू गो विद दैट HB. और अगर 10 के ऊपर है तो इट इज ओनली नीड टू गिव व्हेन देयर इज रैपिडली डिक्रीजिंग इन हीमोग्लोबिन. जैसा कि ट्रॉमा का पेशेंट है, GI ब्लीड है, सीवियर PPH है, आपका हीमोग्लोबिन 10 है लेकिन आपको सामने ब्लीडिंग ऑनगोइंग दिख रही है और आपको पता है कि 1-2 घंटे बाद ये शॉक में ये फास्ट कम होता हुआ हीमोग्लोबिन रहा, तो गिव देयर कि whether it is 10 or not, it is not the question. If not, then unlikely need unless there is some extra hemodynamic 10 gram is the trigger threshold, pre-existing 8, coronary artery disease, acute myocardial infarction 10, ICU hemodynamically stable 7, gastrointestinal bleeding 7 gram, hemodynamically stable और gastrointestinal bleeding hemodynamically unstable or ongoing bleeding, trigger is 10. Here patient is stable and bleeding has stopped. No, ऐसा है तो उसका 7 है. Cardiac surgery 7.5, oncology 7.8. There are exceptions for restrictive therapy. मतलब हर बार restrictive जा नहीं सकते. Severely symptomatic patient, hemodynamically unstable patient, acute myocardial infarction, ongoing GI bleed, hemorrhage तो बताया. Thalassemia, sickle cell anemia, individualized depends upon complication and clinical status. Here you cannot apply the word because thalassemia में क्या रहता है कि उसका ट्रिक उसमें 2 इम्पोर्टेंस रहती है. एक तो उसका ऑक्सीजन भी मेंटेन रखना पड़ता है और उसका बोन मैरो का फंक्शन जो है बोन मैरो हाइपर फंक्शनिंग रहा तो क्या रहता है थैलेसीमिया में बोन मैरो अगर मतलब ऐसे हेमेटोपायसिस ज्यादा होने की वजह से जो बोन के जो स्पेसेस है वो बढ़ जाते हैं ना, उसका जैसा आप बोलते कि चिपमंक फेसिस ये वो है ना, तो ज्यादा एरिथ्रोपोइसिस होता रहा तो पेशेंट को डिफॉर्मिटीज हो जाएगी, है ना, तो वो ना हो इसलिए 10 के अराउंड हीमोग्लोबिन रखना जरूरी है वहां पे. Their aim is not to stabilize the patient hemodynamically. Their aim is to prevent the excessive production of RBC from the bone marrow in response to decreased hemoglobin. Sickle cell anemia, again, it is not depends upon the only hemoglobin level. It is the rapidity with which it is fall and complications whether associated there or not. बता देता हूँ. Sickle cell anemia में if transfuse if HB drop by 1 to 2 gram per deciliter from its baseline, right? Because the sickle cell, suppose sickle cell number is more than 40%, then it will be difficult. Or signs of cardiovascular compromise. Leukocyte depleted packed RBC is recommended. जिनको भी repeated blood transfusion लगता है ना, thalassemia, sickle cell, उनको better है कि leuko depleted दे दो, क्योंकि alloimmunization के chances कम हो जाते हैं. तो और जो कि सिकल सेल के कॉम्प्लिकेशंस है, वाजोअप्लेसिक क्राइसिस, एक्यूट चेस्ट सिंड्रोम, स्ट्रोक, फार्मा-19B19 इन्फेक्शन, इसमें आपको ट्रांसफ्यूज करना ही करना है irrespective of what is the hemoglobin level, except it should not be more than 11 के ऊपर नहीं जाना चाहिए because it can cause hyperviscosity. HB target is individualized for each patient who needs regular blood transfusion for chronic anemia, as seen in pneumonia. Extended transfusion in severe cases, use of cheretic agent when required. PRPC in CKD patient, not on hemodialysis, threshold for transfusion considered in context with anemia symptoms. If anemia is symptomatic, 7 is the again same principle you can apply there. Then on hemodialysis, HB less than 7. Specifically who is not receiving erythropoietin and oropharase, मतलब iron, IV iron, मतलब पहली बार ही आया तुम्हारे पास 7 ग्लोबुलिन, आप उसको आप oropharase पे erythropoietin पे रखेंगे तो टाइम लगेगा उसको इम्प्रूव होने के लिए. तो आपको तो पहला डायलिसिस से आपको तो HB 9-10 रखना चाहिए, तो तब दे सकते हैं. उसके बाद में it should be as far as blood transfusion should be avoided even in hemodialysis also. Better to correct HB with erythropoietin and oropharase. Persistence of anemia symptom, correction of other causes of cardiac arrhythmia, and erythropoietin and iron is the important treatment that will reduce to you proper dose, with proper spacing of erythropoietin, with adequate replenishment of iron. The 50% reduction in blood transfusion is there in all patients of hemodialysis. In thalassemia, transfusion is used to maintain the hemoglobin level, reduce the symptoms of anemia, and least somewhat suppress the extramedullary hematopoiesis. Suggested higher pre-transfusion hemoglobin levels, typically 9, 10, 9.5, 10. क्योंकि 10 के नीचे गया तो extramedullary hematopoiesis होने के नीचे chances बढ़ जाएंगे. फिर folic acid, iron chelating agents, prenectolamine depends upon the clinical condition and requirement. Neurological injury, stroke, traumatic brain injury, cancer, including hemodialysis, transfusion dependent MDS, palliative care, इसमें exactly data available नहीं है, मतलब full data available है, लेकिन यहाँ पे 7 to 8 is the criteria, मतलब वो यहाँ पर भी restrictive ही है, but again it has to be individualized because वहाँ पे कोई ऐसी बड़ी studies नहीं है जो आप apply कर सकते हैं clinically directly. RBC transfusion in pregnancy required only in severe symptomatic anemia when IV IR would not sufficient. As well as possible, avoid blood transfusion. Hemodynamic instability due to blood loss, along with HB threshold, consider symptoms, speed of development of anemia and risk factors. And then decide whether patient needs to. अगर patient का सीजर करना है कल और HB है आज 6, तो आपको blood transfusion देना पड़ेगा. So कितना टाइम है आपके पास, उसके हिसाब से भी आपको ट्रीटमेंट डिसाइड करना पड़ेगा. अभी 67 year old with history of coronary artery disease, undergoing CABG in past, CKD stage 3, hypertension, diabetes, diabetes, fever, cough, diagnosis commonly hemoglobin is 8.2, no evidence of active bleeding, and patient is having shortness of breath. During hospitalization, multiple blood were drawn for investigation. After 4 days, patient's symptoms are improved.
Now he is of febrile 70, BP is normal, respiratory normal, saturation normal at room air, and patient planning to discharge and hemoglobin is 7.3. What is the best approach to manage this patient? पेशेंट निमोनिया के लिए एडमिट हुआ था, असिम्प्टोमेटिक होगा, अभी डिस्निया नहीं कुछ नहीं, उसका HB 8 था, ब्लड निकाल के उसका 7 के पास आ गया है, अभी डिस्चार्ज होने वाला है, रेस्पिरेटरी रेट नॉर्मल है, पल्स उसका सैचुरेशन भी नॉर्मल है ना, और पेशेंट क्लिनिकली इंप्रूव है। क्या पॉसिबल, क्या करना चाहिए? ABCD फोनो फ्रेंड क्या डी डिस्चार्ज एंड फॉलो, क्योंकि पेशेंट स्टेबल है हेमोडायनामिकली, है ना, और 7 के ऊपर है, पेशेंट हेमोडायनामिक स्टेबल है, जो उसके सिम्टम्स थे वो निमोनिया की वजह से थे। यू आर ट्रीटेड निमोनिया, ही इज इंप्रूव्ड सिम्टम, बिकॉज़ मतलब अगर उसके सिम्टम इंप्रूव हो गए तो एनीमिया की वजह से सिम्टम्स नहीं थे उसके, है ना। FFP most commonly misused, dose 12 to 15, rate of administration I told you already, adverse events are same, anaphylaxis and viral and bacterial infections. Indications are massive bleeding, trauma, obstetric PPH, DIC or correction of vitamin K deficiency and warfarin reversal if is not available, and TTP and patient with congenital factor 5 deficiency and alternative treatment option is not there. Routine prophylactic PPB transfusion is not required just to raise the just to correct the INR value. अगर INR 2 है तो उसके लिए कुछ भी मत दे दो, जब तक क्लिनिकल ब्लीडिंग नहीं है तो मत दे दो। Requires only when actress bleeding, especially who are undergoing invasive procedures. अगर INR 2 है और आपको pleural tap करना है, LP करना है, तो आप उससे पहले दे सकते हैं। अगर कुछ करना नहीं है तो फिर नंबर ट्रीटमेंट करना है। Replacement fluid during TTP, HVS, cardiopulmonary bypass surgery. Do not use FFP for volume replacement in the patient who are not bleeding. Do not use FFP for nutritional purpose like hypoproteinemia. Do not use, उसमें प्रोटीन बहुत रहता है बोल के दे दिया FFP. Do not use prophylactic FFP for invasive procedure with normal or mildly deranged INR. Plasma product, better to give vitamin K in that case अगर borderline है तो. Plasma products should not be used as a source of albumin or nutrient as a volume expander. ABO matching is required, so this is the ABO matching which is required. ये इसमें डिटेल नहीं जाऊंगा मैं, ये तो है पूरा मतलब RBC प्लेटलेट FFP क्रायो, इसका कैसा लगेगा उस हिसाब से है। तो ये ABO का तो ठीक है, यहाँ पे ये जो है ना मोर और लेस प्लेटलेट और FFP का जो है क्रायो का वो सेम ही है। ये उसके हाफ लाइफ है FFP के। प्लेटलेट्स वॉल्यूम 200 टू 1 यूनिट प्लेटलेट रेजेस द अराउंड 5000 से प्लेटलेट बढ़ता है 1 RDP से। अगर 4-6 RDP दे रहे हैं तो अराउंड समझो 25 to 30,000 से बढ़ जाएगा ऑन एन एवरेज। इट विल बी डिपेंड्स अपॉन हाउ मच द वॉल्यूम एंड हाउ मच टाइम हैज, मतलब पहले दिन का प्लेटलेट है या 5वें दिन का है उसके ऊपर भी रहेगा। और HDP देने से ऑन एन एवरेज 40 to 70,000 बढ़ जाएगा। HDP is better because it is drawn from single donor, so alloimmunization chances are less. जब भी आपको पॉसिबल हो सकता है HDP ट्रांसफ्यूज करो, स्पेसिफिकली डेंगू पेशेंट में और प्रेगनेंसी में, क्योंकि नेक्स्ट जब भी उसको कुछ लगेगा तो alloimmunization के बहुत चांसेस रहेंगे। सो ट्रांसफ्यूज विद इन 30 to 60 मिनट्स, एजिटेट करते रहना चाहिए प्लेटलेट को। और इंक्रीमेंट विल बी, अगर ये DIC है तो इसमें इतना ऑब्वियस इंक्रीज नहीं मिलेगा आपको। और there is a platelet refractoriness is also there if you do unnecessary platelets. Indications: thrombocytopenia is bleeding is the
department, so we have a lot of things to learn from them. And because they give us so much energy, we want to see them very often in all our programs, educational activities. So thank you so much, sir, for coming today and setting our energy.
The last session of the CME, last but one of the most important topic. I request Tuba ma'am she'll speak on adverse effects of blood transfusion. I request Chairperson Dr. Gauri sir and Kessler sir to please be seated as Chairperson for the session.
At the outset, I congratulate Dr. Kumar Madam to arrange a very useful and innovative CME. She is the founder HOD of Pathology Department in our college. First pathologist and first HOD, inaugural HOD.
Thank you so much, sir.
She is graduated and co-educated from IIMSR Badnapur.
Yes.
So, I request you to start doing.
Thank you, everybody. So many graduate students are there from GMC, MGM. I thank all the HODs for allowing me over here. Now, today, this particular session is basically very commonly a question. Okay, for UGs, PGs, even for PGs of MD medicine. We'll just run over it. Okay, we'll not go in detail with it because many of the things are being told by so many speakers earlier. Okay. So let us go through the basics of this. So everybody should know that blood transfusion is actually very safe procedure. Very rarely there are complications, there are adverse effects. Okay, and these adverse effects, which are undesirable responses, should be directly related to blood transfusion itself. Otherwise, we will not call them as adverse effects. Okay, so we have to rule out other conditions, and then we have to come to a point that these particular reactions are because of transfusion itself. Alright? And they are many times difficult to diagnose because a lot of symptoms are overlapping and like other conditions also. As I said, mostly mild reactions occur, even if they occur very rarely, mostly mild reactions occur. Only few reactions, very, very rare reactions are. But remember, if we are not careful enough, then there will be unnecessary deaths because of blood transfusion. So we need to identify the blood transfusion and treat it, investigate it so as to save the patient's life. Okay? So early diagnosis is very important and reporting of these particular transfusion reactions. Whenever you get a blood bank from the blood bank, you have a form along with it, which is a transfusion reaction form. That is very important. If you suspect any transfusion reaction, you should fill that form and send it. Okay, so that we can identify the risk factors and we can prevent them in future. Alright. So actually, we should train about these blood transfusion reactions. We should be trained to all the healthcare workers, even all the PGs sitting here from clinical side also. They should train their nurses, their ward boys, okay, to identify and to these reactions. So this is just a run-up. All transfusion reactions, adverse effects have been divided into acute and delayed. Acute is generally during transfusion or within 24 hours of transfusion, and delayed is after that. Okay, and then we go into immune and non-immune, both of them. All right. So depending upon the duration, the time when the transfusion reaction starts after blood transfusion, you can even or try to which type of transfusion. Okay, so even the time limits have been mentioned. Okay, so you can just find out what is the time of onset of the reaction and what it could be. Okay, from that. So basically, immune transfusion reactions are produced because of antibodies acting against antigens. Alright, antibodies may be present in the patient recipient or they may be present in the donor against the antigen in the opposite party. Okay, vice versa. Okay, what are these antigens basically present on RBCs, WBCs, and platelets? Some proteins which are being transfused to the patients may act as allergens. Alright, and there may be allergic transfusion reactions in the recipients. Right? What about non-immunological reactions? They are all physical changes or effects which are produced by these blood transfusions, like overload, iron overload, isn't it? Right? And also transmission of disease that has been already covered by Damle sir very well in the morning. Okay, so we'll just run up transfusion reactions so that you remember some things while you are writing your answers. Alright, so hemolytic transfusion reaction. Alright, hemolytic transfusion. See, the most common transfusion reactions which are documented are febrile, non-hemolytic transfusion reactions, allergic reactions, mild type of allergies, and hemolytic transfusion reactions. Okay, so these hemolytic transfusion reactions may be either acute or delayed depending upon when they are occurring. All right, and they may be produced because of transfusion of RBCs, antigens, okay, or because of transfusion of FFP, etc. What is in them? We are going into the recipients. Alright. So remember always acute hemolytic transfusion reaction can be immunological. Alright. Most commonly immunological because of mismatched blood transfusion, because of ABO mismatch especially. Alright. But hemolysis can occur because of non-immune mechanisms also. Alright. And this is because of very commonly because of bad blood transfusion practices. Okay, like excess of warming of the blood bags or unnecessary too much cooling of the blood bags may lead to hemolysis. Okay, or exposure of RBCs to some hypotonic solutions may lead to hemolysis, or transfusion of RBCs through very small bore needles may lead to hemolysis, etc. So there are so many. Okay, bacterial contamination before or improper storage of these particular bags can lead to hemolysis. Okay, so we are not going to detail. So in acute hemolytic transfusion reactions, especially there is intravascular hemolysis. As a result, hemoglobin is released in the bloodstream, a lot of hemoglobinuria also occurs. Okay, and this may lead to renal failure, okay, and acute tubular injury, renal failure, okay, and there may be secondary system inflammatory responses. But in case of delayed hemolytic transfusion reactions, generally immune response to the antigens, and these antigen antibody complexes, that is especially attached to the RBCs, they are hemolyzed inside the lympho-reticular system, especially in the spleen. So there is actually extravascular hemolysis. Okay? As a result of which hemoglobinuria, hemoglobinemia doesn't happen, but the patient suffers from jaundice. Okay? Very common. So these are some of the most common signs and symptoms. Especially those marked in red are of acute hemolytic transfusion reactions, and those in brown you can see there is pallor, there is jaundice, fatigue in delayed hemolytic transfusion reactions. Okay, I hope everybody has understood how they are produced now. Okay, especially in delayed hemolytic transfusion reaction, we should look for hemoglobin after transfusion, post-transfusion hemoglobin. Okay, it doesn't rise to the level which is expected, or it even falls. Okay, so there is an in these particular patients, even after transfusion. So these are all the various investigations, all related with hemolysis, basically. Okay. Also, hyperbilirubinemia in delayed hemolytic transfusion reactions. Okay. Next common transfusion reaction is febrile non-hemolytic transfusion reaction. Okay. Now, why this febrile? Why fever happens? Antibodies in the recipients, they act against the donor platelets or WBCs. Okay, so there are antigens present on the donor platelets, WBCs, against which these antibodies act, and they are HL antigens and granulocyte and platelet specific antigens. Now, when this antigen-antibody reaction occurs in the recipients, it leads to release of cytokines causing fever. So, hence this particular patient is suffering from fever. Okay, this is more common in multi-transfused patients because they are sensitized already to the antigens, okay, to the WBC and the platelet antigens. So hence these reactions are more common in multiple transfused patients. fever. Of course, fever can also occur in hemolytic transfusion reaction. Right? Okay? So we have to exclude hemolysis wherever there is acute febrile transfusion. Degrees Celsius. This is very important. Okay? Not 0.5 degrees Celsius. More than 1 degree Celsius. It should be. Okay? Along with chills and dryness, headache, etc. Alright? So, how can we prevent this? How can we prevent this? We can prevent it by leukoreduced or transfusion with leukoreduced or leukodepleted components. Okay? About allergic reactions, we have already said. What are the allergens? The plasma proteins, okay, of the donor entering into the body. They are the allergens against which type 1 hypersensitivity reaction is produced. Everybody knows what is type 1 hypersensitivity reaction, isn't it? Right? Now, this particular reaction may be mostly it is mild. Mostly it is mild in the form of urticaria or any mucocutaneous rashes. Okay, very rarely it is severe in the form of anaphylaxis. Alright, especially in patients with IgA deficiency or in patients with anti-IgA antibodies, these particular allergic reactions are more severe. Okay, they say. Alright, this is one of the most commonest immunoglobulin deficiencies actually, IgA deficiency. Alright. So, all the features of mucocutaneous signs and symptoms, especially mild allergies and anaphylaxis in severe allergies. Alright. So, how do we try to prevent these allergies by plasma reduction? We should reduce the amount of plasma in packed red cells, in platelets, okay, so that the allergens present in the plasma are not exposed, okay, for allergic reactions. And even autologous blood transfusion can be used, okay, as one of the right. Then comes pulmonary adverse reactions. Okay, these are also very rare, but they have got very fancy names. We should try to remember them, isn't it? So actually there are 3 types. First 2 have been clubbed in one because they occur within 6 hours of transfusion. The other one, the third one, occurs generally up to 24 hours of transfusion. So the first one is TACO, the second is TRALI. Okay, I hope everyone can read the full forms, and the third is TAC, that is transfusion associated dyspnea. Right? So what is TRALI? TRALI is like ARDS. Okay, it is like ARDS, acute respiratory distress syndrome. So here the antibodies present in the donor product react with antigens present in the recipient. Which are the antigens? They are generally HLA and human neutrophil. Okay. Recipient get activated, they release cytokines, cause lung damage, okay, leading to production of ARDS-like feature. Okay, so the patient suffers from pulmonary edema because of this particular lung damage, lung injury. Okay, fine. So various risk factors. Certain patients are at risk of developing this, like those who are suffering from critical illnesses or undergoing surgery, so on and so on. Even when patients at risk are given high volume transfusions, then they are also at high risk of developing this TRALI. Okay, so TRALI have 2 types, TRALI 1, TRALI 2, depending upon whether the patient has any risk of ARDS, no risk of ARDS. Okay, so we will not go in detail with it, what you read about it. Okay, right. What about TACO? TACO is nothing else but overload, okay, in the body caused by the transfusion. Alright, as a result of which what is happening, and again, this has got certain risk factors, like this can happen in patients more than 60 years of age or those already suffering from chronic kidney disease, chronic heart failure, alright, and also getting high volume of transfusion and a high speed of transfusion. Okay, so areas for diagnosis of TACO basically lie with inside the body. So all clinical manifestations of volume overload. So there will be again pulmonary edema in this particular case, but what is the cause? Volume overload, not injury to the lung. Okay, fine. And apart from that, there may be radiological signs. Then there may be cardiovascular signs and symptoms of volume overload. So fluid overload documented by clinical improvement by diuretic therapy. This is very important. Diuresis, if you do in this particular patients, the patient recovers quite well as compared to TRALI. TRALI doesn't need any diuretic therapy. Okay, so that is how we can differentiate. Right. So if you want to prevent TACO, what will you do? That is volume overload. What will you do? You will avoid unnecessary transfusions. As sir was saying previously, Solanke sir was saying previously, we need to avoid unnecessary transfusion. If a patient requires multiple transfusions, there should be proper gap in between them. Okay. As far as trial is concerned, we should avoid certain things, like we should avoid plasma from multi-gravida females. They have what? They are already so much sensitized. They have got so many antibodies inside them, isn't it? Also, donation from wife to husband, children. Mahendra Singh Chauhan sir was saying, right? And improper storage of blood components should also be avoided in this particular case. Now we'll just run over some very uncommon things like transfusion associated hypotension. Alright, here, if you are suspecting hypotension, first you have to exclude all the other causes of hypotension, all the other reactions causing hypotension. Like there may be hemolytic transfusion reaction, allergic transfusion reaction, which may also cause hypotension. So first you have to exclude that. Then you have to label it like this. Okay, so there is a definition given. You can read that. Okay, and this is basically produced because of exposure to leukocyte filters. Leukocyte filters are not very commonly used in India, okay, as Mahendra Singh Chauhan sir was saying. So the incidence of this particular transfusion reaction is very rare. Again, sir has already told about the metabolic complications caused by transfusions. So hypocalcemia, hypokalemia, okay, they are caused because of massive blood transfusions or because of apheresis, which have got high citrates going inside the patient. Okay, and these particular citrates, they can bind to calcium causing hypocalcemia. Okay, they can produce alkaline milieu inside the patient's body, anemia. All right, and as sir said already, that prolonged stored blood components or blood products inside in the blood bank can cause hemolysis, the release of a lot of potassium, and causing hyperkalemia. Also, hemocytosis, everybody knows. And of course, transfusion associated graft versus host disease. Already Mahendra Singh Chauhan sir has told about this, isn't it? I hope everybody has understood it. It's a very interesting phenomenon. Alright? More common in immunocompromised recipients. Alright? And also, even in those patients, it depends upon how many T cells, T lymphocytes are present in the donor's blood, in the donor's blood products. Okay? So, if the patient is immunocompetent, those T cells coming from the donors, they are destroyed by the recipient's immune system. Okay, if the patient is immunocompetent, but if the patient is immunosuppressed, what will happen? Those donors T cells, they are not destroyed when they reach the recipient's body, and these donor T cells, they try to recognize non-H types, or heterologous HLA types in the recipient's blood and attack the recipient's cells, okay, leading to graft versus host disease. And as sir said, 100% fatality, almost 90 to 100% fatality in this patient, but very rare actually. Then again, post-transfusion purpura, okay, right? So what is there in these particular patients? There is and the antibodies are produced against platelet antigens, HPA, human platelet antigens, right? And what happens? Once these antibodies they act on both the donors as well as the recipient's platelets and cause severe thrombocytopenia. Alright? So, however, in order to rule out other causes of thrombocytopenia, what will you look for? Pre-transfusion platelet count. So, pre-transfusion platelet count will be normal in this particular patient. Okay? Only after transfusion, this thrombocytopenia will happen. Then, we should also know how to identify transfusion reactions in anesthetized or in unconscious patients, because the risk of identification of these reactions is very identification errors are very high. Okay, anesthesia can also cause signs and symptoms similar to transfusion reactions. All right, and however there are some signs and symptoms which have been told that you should look for these in order to identify the transfusion reactions. Okay. So what is the differential diagnosis, common differential diagnosis for all transfusion reactions? Alright, anaphylaxis, very important. Remember, this anaphylaxis is not related with transfusion. All these differential diagnosis. Okay, so anaphylaxis, DIC, hemolytic anemias, septic shock. Okay, and what are the complications which can be produced by transfusion reactions and can lead to death of the patient? DIC, lung injury, renal failure, okay, to begin with hemolysis actually, and death. Alright. So, how everybody should prepare for transfusion first of all. Okay? When you are thinking of transfusing a particular patient, what you should do, what preparation you should do. Okay? So before you are deciding for transfusion, you should know a thorough clinical, medical patient. Alright? You should always ask history of prior transfusion. Clinical check should be done as far as identification of the patient, identification of the donor, blood banks. Okay, right? In order to prevent any clinical, clerical errors. Also, what were the investigations done before transfusion? Blood group being cross-matching, everything. Okay, we should check. And if any doubt about the patient's blood group or cross-match should be first confirmed, then only the blood should be transfused. Okay. What should be monitored during transfusion, before and after transfusion? All the vital signs. Transfusion start for every 15 minutes. Alright? And which signs and symptoms we should look for in this particular patient? We have already discussed, shown these particular signs and symptoms. So any one of these may help us to go towards thinking that there is a transfusion reaction. But of course, there is always an overlap of signs and symptoms. No specific signs and symptoms as such for any specific transfusion reaction. So in case of suspected transfusion reaction, okay, in case of suspected transfusion reaction, what the clinicians should do, alright? So transfusion should be immediately stopped and immediately the blood bank should be notified, okay? The transfusion reaction form should be thoroughly filled, alright, and sent. And also the treating clinician should be notified for further treatment of this particular patient. Okay, this is very important. This is also very, very important, alright? The intravenous line can be kept open. All the clerical checks should be done, whether there was any mistake clerically, okay? I should be continuously monitored. And post-transfusion blood sample of the patient along with the blood bank, and all the tubing should be sent to the blood bank. And there itself, when you are checking the blood banks and all, you should look for any discoloration of the blood itself, any clot present in the blood bank, alright? Patient's blood sample removed after transfusion, that is immediately after stopping of the transfusion, should be looked for any discoloration of plasma, etc. Okay? And as I said, transfusion reaction form should be properly filled, alright? So, in the lab, we go for repeat ABO, RH grouping of the patient. We go as well as the bag, the blood bag. Okay. Then we go for repeat cross match. We go for direct Coombs test on the patient's sample, recipient sample, and we also check urine for hemoglobin. And you can go for so many other investigations depending upon which transfusion reaction you are suspecting. Okay. So, in order to avoid transfusion reactions, as I said, it's very, very important to avoid transfusion reaction because you are going to save a patient from an unnecessary death, unnecessary mortality. Okay, right? So we should avoid all clerical errors. There should be proper identification of the patient, which patient should receive which bag, okay? Which bag has been given to that particular patient. Correctly labeled samples should be sent to the blood bank laboratory always. Proper identification of the recipient and the bag. Incorrect blood component transfusion should be avoided. Careful and close observation of the patient during transfusion. That is very important. Not only when you are suspecting transfusion reaction, but during the whole of transfusion. Transfusion is a very safe procedure, but it has to be properly monitored. That is very important. Okay? And avoid, as sir said already, avoid inappropriate and unnecessary blood transfusion. That is very, very important. So I hope all the postgraduate students will be able to remember some points which I have told, okay, today, and will be able to write some answer, okay. So please go through it again. Thank you so much all of you for coming here. Thank you.
Understanding lecture. Any queries from audience side?
Department, everybody, I'm so glad our UGs have come, our batch. So I'm really very happy today, and thank you everybody for coming. We will conclude our CME here now. Alright. The bus will be just ready in 5 minutes. Okay. Thank you so much.
Thank you.
medical is ready for GMC and MG available.
It's a